Hi guys, welcome to the discussion. In today's world, all that matters is the strike rate. So I'll begin with a question from the GI tract, which is very simple and straightforward. He said an old man has come to the hospital. He's having lower GI bleeding, that is hematochezia, and his blood pressure is coming as unrecordable. So the nurse was saying unrecordable. So you said, okay, let me have a look. And you checked the BP was, let me say, 80 by 60 millimeter mercury. So the question said, after you've stabilized the patient, did a volume resuscitation, gave a blood transfusion, what is the first investigation that you'll be doing in this patient? Options are standard ones: upper GI endoscopy, colonoscopy, sigmoidoscopy. Yes, guys, in the next 5 seconds, can you quickly comment what investigation would be first done in a patient of hematochezia? And yeah, the blood pressure of this patient was very, very dismally low when the patient came. Your answer would be, I'm very sure you would have guessed it right. That's an upper GI endoscopy. You see, the rationale is that this guy could be having a peptic ulcer disease. The bleed could be occurring from the gastroduodenal artery, and the bleed would be so extensive that all the blood is flowing down. It's being passed in the form of hematochezia and is also contributing to hemodynamic instability. In contrast, I want to say that the routine causes of hematochezia like pious diverticulitis, they usually do not cause a hemodynamic instability in a patient. So usually GI is one topic which people think for them is like usually strong, but when it comes to solving questions, they can be errors as well. So what I want you to do is sit tight for the next about three and a half hours and focus on each and every word that I say. And I assure you that at the end of it, your scores in the GT and the actual exam will definitely improve. So let's begin with the first topic. This was just an opening statement, so it will not be in the notes at the moment. It is present in the later part of the notes, so don't worry. Like at the moment, you don't need to note down anything with respect to the question that I mentioned and the answer that I said, hemodynamic instability in hematochezia, the answer being upper GI endoscopy, that is given in the notes subsequently. Now, they gave an image in the exam in which they mentioned a person having diarrhea, and this histopathological image was given. My student said, sir, it looked something like a volcanic eruption. It looked like a big cloud hovering over the GI tract. He said, I could identify the GI tract because I could see some glands, and like if you zoom into the image, you can see a bit of goblet cells. But this exudate that is sticking on the top of the GI mucosa is a very classical presentation of pseudomembranous colitis. So the first topic that I'll be explaining to you here is called as PMC, pseudomembranous colitis. Before we discuss like what are the causes responsible for it and what will be the presentation, the generic term for this would be like a antibiotic associated diarrhea. The balance between the good bacteria and the bad bacteria in the intestine is distorted. So there's an overgrowth of a bad bacteria by the name of Clostridium difficile, and this is the one that produces those toxins by the name of toxin A and toxin B. And therefore, if he says what is the investigational choice for this condition, then don't answer a intestinal biopsy. In real clinical practice, nobody will do a clinical biopsy for this condition. The investigational choice for this condition would be answered as a stool PCR for toxin A and toxin B. The toxin A is called as enterotoxin, toxin B is called as a cytotoxin. Yes, guys, the investigational choice for this condition is not an intestinal biopsy. It's not even a colonoscopy. You can see those pseudo exudates, that is the volcanic exudate that I was talking about, which are sticking to the erythematous colonic wall. The main investigation for this condition is the stool PCR. Now, why does it happen? Obviously, the standard antibiotics are from pharmacology like cephalosporins, clindamycin, fluoroquinolones, ampicillin, amoxicillin. And recently, what he asked was also an important aspect, prolonged PPI usage. You will see that India nowadays, a lot of people, they just go to a chemist and say, ki gas ki goli de do, and that gas ki goli is PPI. And what he said is that over a couple of period of time with PPI usage, they can be like osteoporosis and they can be like the higher incidence or development of pseudomembranous colitis. The presentation of this patient is the standard post-antibiotic diarrhea. So he will always mention the word profuse watery diarrhea after a course of antibiotics, but there would be no blood present. So I will also discuss an MCQ before you where the patient received antibiotics and after that there is presence of blood in the stool. But at the moment, the message is that the person has come to you with like profuse watery diarrhea, tummy pain, fever. There might be leukocytosis present, and it's not that only oral antibiotics can contribute to this. Even intravenous antibiotics in a hospitalized patient, like for example, or elderly patient. So you could be having like a hospital acquired diarrhea from the hospital environment. The patient could pick up this infection, and therefore the disease manifestations would be explosive profuse watery diarrhea, but usually there is no blood. The TLC of the patient might be slightly elevated with abdominal discomfort. He will also ask you what is the first test to be done in this patient. So you will say stool, but now you will not say stool PCR. Stool PCR is obviously the test that is done in this patient, also written as nucleic acid amplification technology. But if he says the word, what is the screening test for this condition, then your answer would be given as stool GDH antigen, that is glutamate dehydrogenase. I repeat my statement. This is one of the very neglected questions in the paper. Everybody knows antibiotic associated diarrhea is Clostridium difficile. So it will always be a question that will say, what is the screening test that is done for this condition? Your answer is you want to check for GDS, that is glutamate dehydrogenase levels, antigen present. I mean, ELISA can be used for it. And the second test that you can do in this patient is obviously a stool EIA for toxin A and toxin B. Between the two in Harrison, first mention is stool GDH, glutamate dehydrogenase. And if he says what is the investigational choice for that, then this, I have already told you that stool PCR, nucleic acid amplification technology, basically mean the same, and we can do it for the toxin genes. We can do a PCR for the toxins also and for the genes as well. So between the toxins and the genes, if he says stool PCR for toxin genes, then the first priority would be toxin genes. In real clinical practice, we don't do a colonoscopy in these patients, but for the sake of information, I want to point out the erythematous mucosa, and between this erythematous, I mean islands of like that exudate present, there is erythematous colonic mucosa that is visible. And now we will have to treat this patient. So sometimes the question could be 2-step or 3-step, in a sense that he'll not even ask you the diagnosis, he will not ask you the workup of this patient, rather he will say that what is the antibiotic to be used. So the first antibiotic to be used in this patient would be fidaxomicin. The first episode in this patient, what we will be using is fidaxomicin. And the second thing that we do in this patient, in case there is like relapses that are happening, then it is vancomycin. The only problem is vancomycin that we need to give is not intravenously, it is oral. Lots of time when you will send the patient to get vancomycin, they'll come up with that injection because that's easily available as compared to oral vancomycin that is to be given. And then I'll say a very peculiar thing, like if it's like multiple recurrences of pseudomembranous colitis, we might even go for what is called as a stool transplantation. Stool transplantation means that fecal matter of a healthy person will be given to this person, which technically would be called as a fecal microbiota transplant. So Clostridium difficile is like what you already are aware of. What I just want to bring to your attention is that this mushroom shaped exudate cloud, or like a volcanic instead of mushroom, I can say it looks something like a volcanic eruption. Now it looks like a nuclear bomb. When the bomb goes off, now it produces that mushroom cloud. So mushroom or a volcanic cloud that is currently shown in this histopathological image is only for like histopathological image is only for academic reasons. So is the case for colonoscopy. Most of the time, like patients may not give consent for the same also. So a very, I would say, harmless way of identifying this condition is do testing of the stool. And two tests that I hope I've been able to make you remember are stool GDH for screening and stool nucleic acid amplification technology for the toxin producing genes. The antibiotic of choice is fidaxomicin, first episode. If he specifically mentions relapses or severe, then it is oral vancomycin that would be given for this patient. And now I'll mention a common error, which I was saying that the question mentioned that patient has taken antibiotic and then there is crampy abdominal pain, bloody diarrhea, but the word was bloody diarrhea. A lot of students casually answered this as Clostridium difficile, saying, sir, antibiotics were given and the patient was having diarrhea. Then one guy in the recall session said, boss, this was not the question. It mentioned specifically bloody diarrhea happening and the antibiotic given were not beginning with C. It was not cephalosporin, it was not clindamycin, it was not fluoroquinolones, the traditional antibiotics that I was saying for development of this condition, not even ampicillin. It's rather amoxicillin with clavulanic acid. So beta-lactam was being used. And then he also mentioned colonoscopy shows right-sided colitis without pseudomembranes. You see, the examiner had himself said that the answer for this question is not pseudomembranous colitis, because the word is without pseudomembranes. I'll just highlight the word without here. I mean, this is like, you get 30 seconds in a question, maybe 1 minute in a question. If you miss out the word there, then the entire question goes kaput. It's gone. So here the etiological agent would be given as option number B, that is Klebsiella oxytosa. So I want you to remember the following data now. If he says antibiotic associated bloody diarrhea, then your answer is Klebsiella oxytosa. Antibiotic responsible, amoxiclav, that is augmentin. But instead of saying the word bloody, he says explosive watery diarrhea post antibiotic with fever, a bit of tummy pain with leukocytosis, then answer it as Clostridium difficile, which is option number A. But here the answer is not A, guys. The answer is option number B, and the answer cannot be C or D because already you are giving antimicrobials to the patient. And for entamoeba histolytica, like the usual scenario would be flask staped ulcers. So here he mentioned colitis, that is okay. There was no pseudomembranous mentioned, and then the symptoms had resolved after stopping the antibiotics. So in entamoeba histolytica, you have to give metronidazole to the patient for improvement in symptoms. So I mean, if somebody wants to argue that, sir, why the answer is not entamoeba histolytica, I said two reasons. One is the examiner himself mentioned that the symptoms are resolving after stopping the antibiotic. And second, for entamoeba histolytica, the colitis could be right-sided flask-shaped ulcers. That flask-shaped ulcers can't be seen on colonoscopy. I agree to that. But then you will have to treat the patient with metronidazole, only then the disease will improve. And entamoeba histolytica can even cause a development of amoebic liver abscess. As I told you, overall, the most common cause of nosocomial diarrhea is Clostridium difficile. This again, like the question came in FMG exam, and would you believe it that people messed the question up and answered it as Staph aureus? And one guy was like, no, sir, the question was nosocomial diarrhea. You see, half the time when I take these discussions, people assume that the answer to the question is like a particular organism. And the question is totally different. The examiner played a mind game. He wrote the word nosocomial diarrhea, and people in their mind, the guy who was talking to me, he said, sir, it was dancing in front of my eyes. No, it is nosocomial pneumonia. That's what stress does to the mind. And like this guy answered it as Staph aureus, whereas the answer is Clostridium difficile. Obviously, the reasons being widespread use of antibiotics, widespread use of PPI by people, and this organism produces spores that can survive on hospital surfaces, and there's an increased risk in elderly patients with prolonged hospitalization. Now on the agenda is a topic which is very, very classical, and they love to ask about it because they'll give you a biopsy specimen of the intestine, and you can see a granuloma present in the middle in the image. So at the moment I'm talking about granulomatous colitis. Yes, guys, you guessed it right. The granulomatous colitis that I'm talking about the moment is called as Crohn's disease, and that is why the pathologist would have used the word non-granulomatous colitis for ulcerative colitis. Obviously, it's a non-caseating granuloma, and in Crohn's disease, the highlight would be presence of skip lesions and a cobblestone mucosa. Most of the time, what happens in Crohn's is that there is a submucosal fibrosis, and this can cause development of strictures across the entire length of the intestine. In Crohn's disease, the most common site that is involved, as you are aware, is the ileum, and the site that is usually spared is the rectum of the patient. And because this disease can involve both the small intestine as well as large intestine, so one of the very highlight features from the clinical perspective that can develop in these patients is strictures. You see, the pathologist will say the word cobblestone mucosa, or they will say submucosal fibrosis. But for me, what matters is not that cobblestone mucosa. Obviously, we can find it in the oral cavity of these patients in the advanced stage, because the aphthous ulcers, when they'll heal, there would be irregular surface on the inside of the oral mucosa because of submucosal fibrosis. But across the entire length of the intestine, small intestine as large intestine, both are involved. It is strictures that are present. Now, when the food will try to go through this area, the intestine will now contract with more force to push the food forward, and therefore the presentation in these patients will most of the time be a presence of a colicky abdominal pain. So most patients would come to you with like right quadrant pain. That right quadrant pain word can be written because he wants you to start thinking in terms of appendicitis, but it's not going to be like one sudden episode that occurred and like there's a tenderness at the McBurney's point. It's a abdominal pain which is more like generalized but is more focused in the right lower quadrant of the patient. And because in this condition, the mucosa of the intestine is also damaged. I mean, the ileum mucosa is damaged, so malabsorption will occur. So the question will begin deliberately by saying the word chronic diarrhea in a patient. That's because malabsorption will also occur in this condition, because duodenum, jejunum, ileum, all the three parts of the intestine would be involved, with most common site being ileum, and therefore like a stricture formation will obviously occur. But like for the stricture formation, the abdominal pain that is described would be given in a very nondescript fashion. If the question began by saying colicky pain round the clock, I mean, it becomes easier for you, so he will begin by saying that there is a diarrhea. The reason for that is malabsorption, and because of this inflammatory condition, there can be weight loss, there can be low grade fever. So you might be thinking in terms of intestinal tuberculosis also, because interstitial TB tends to involve the ileocecal area, especially like the ileum is again inward. You see in TB, if you remember, there would be like a transverse ulcer, and then there would be fibrosis that would be happening that will cause a stricture formation. But in TB, it's usually a single structure, not multiple structures present all through. So while you're reading the first and the second point in the question in the theory, you might still be in a dilemma. Should I think about Crohn's disease? Because this could be intestinal tuberculosis also. Low-grade fever, weight loss happens in the same also. Now, what is that word? What is that buzzword, as you guys call it? Gen Z calls it buzzwords. That buzzword is perianal disease would be present, because Crohn's disease has a tendency to tendency to cause involvement of even the anal canal, and there can be formation of fissures, there can be fistula formation. In fact, what I've underlined at the moment is a hallmark feature. Like the question will say, which of the following is a hallmark clinical feature in patients of Crohn's disease? Your answer would be given as perianal fistula, and because of this perianal fistula there might be discharge that would be occurring from the perianal area, and that will stain the undergarments of this patient. It will cause bad smell to come from the patient. He might get used to the bad smell, but the family members will always ridicule this person, that there's always some like fecal smell coming from this person. And then there can be like abscess formation. There could be ischiorectal fossa abscess that could even rupture, so there could be a tracking fistula that is developing, and skin tags in these patients. Apart from that, even subacute interstitial obstruction can develop. So features of abdominal pain, colicky pain could be described in this question. In fact, at this moment, I want to say that the risk of malignancy is increased in patients of Crohn's disease. The risk of malignancy is actually increased in both. Malignancy risk is increased in both ulcerative colitis as well as Crohn's. According to the latest editions of the books, the malignancy risk is increased in both ulcerative colitis as well as Crohn's disease. In both of them, the risk is equally increased. And to test the severity of this disorder, we do a test we do a scoring pattern that is called as CDAI, that is Crohn's Disease Activity Index. The word AI here is not artificial intelligence. That's the in thing nowadays. Everybody is using ChatGPT paid version, but it is an activity index that I'm talking about. This activity index values, if they're lesser than 150, it indicates the disease is going into remission, whereas values more than 450 indicate the severity of the disorder. So to assess, why do we use Crohn's disease activity index is to assess the severity of manifestations. The must know fact is that this condition has perianal fistula present. Obviously, the fistulas can be anterocutaneous fistula. There could be a fistula between the bladder as well as the colon. Imagine like a fistula developing between the urinary bladder and the colon. So fecal matter will go in the colon of the patient. If fecal matter from the colon will go into the bladder of the patient, and therefore don't be surprised if you read words like fecaluria. I'm saying a very horrible thing, guys. Because of fistula formation tendency, there could be communication. The bladder wall will stick to the colon. And then from the colon, an ulcer will go deep, deep, deep. It will penetrate to the serosa. It will penetrate through the bladder wall. And now feces of the colon are entering into the urinary bladder. You can imagine the amount of cystitis that will cause fecal matter going in the bladder. That is, fecaluria is you don't read this term anywhere else, man. Fecaluria. Obviously, the incidence of this has become lesser because of the ease of diagnosis of this condition and the aggressive management that we do. But as far as fecaluria is concerned, I just want to bring to your attention that this could be due to a colovesical fistula in this patient. Though most common type of fistula is the perianal fistula, colovesical fistula, anterocutaneous fistulas could be present. So this is like a very peculiar statement that I have made at the moment, especially from the perspective of fistula, of fecaluria, and then like the colicky abdominal pain. That's because of the stricture formation that is occurring. And yes, we do have skip lesions present here. So what I've not written here and said verbally is the word cobblestone mucosa. You already know that. Skip lesions, you already know that. So there's no point of there's no mystery about it. I need to talk about things beyond like how to identify Crohn's in a question. Like it will sound like tuberculosis, it will sound like malabsorption syndrome, but you have to pick up the buzzwords which are in the form of fissures, fistula, or abscesses, and then he'll talk about even a possibility of fecaluria. Now let us look at how do we diagnose this condition and how do we quantify the extent of the disease. So if he says the word severity, then I have already explained to you the word you will give as CDAI, Crohn's Disease Activity Index. But then he can also ask you regarding the extent of the disease. Extent of the disease would mean like the whether it is involving only the ileum, is it ileocolic, is it only involving the colon, and even the behavior of the disease needs to be identified. So as far as the extent of the disease is concerned, there's a special classification called as Montreal classification. So you will notice that in this discussion, I'll be using a lot of, the Western city names: Prague classification, Los Angeles classification, Montreal classification. So all of these are named after cities. Like Montreal is in Canada. Montreal classification is for extent of Crohn's disease. I'll just highlight this there, that for extent of Crohn's disease, it is like Montreal classification, where it's a scoring pattern. You have to feed in the age of the patient, the location, and then the behavior of the disease, especially from the perspective of whether stricture formation is occurring or a perineal disease is occurring. This disease can also cause extraintestinal manifestations. So the question will say, what is the most common extraintestinal manifestation of inflammatory bowel disease and Crohn's disease? Then there is a change. In older books, the answer was arthritis, but now it is not arthritis, it is osteoporosis. Yes, guys, if I say what is the most common extraintestinal manifestation of Crohn's or IBD, then answer would be given as osteoporosis followed by arthritis. He can also ask you with respect to this arthritis that which joints would be involved. So you will notice that there can be two patterns that can be seen. One pattern would be identical to what you get with respect to rheumatic fever, that is a migratory polyarthritis, where the arthritis will be jumping from one large joint to another. The second component that could be present in the question or could be described as sacroiliitis. And in fact, for this sacroiliitis part, I want to say that lots of time patients of inflammatory bowel disease can be having HLA-B27 positivity. When I've described ankylosing spondylitis in the rheumatology section, I've mentioned this statement that HLA-B27 positivity is not only seen in ankylosing spondylitis, but even in inflammatory bowel disease. So in the question in the clinical domain, he can not only mention the intestinal, but extraintestinal manifestations also to throw you off the track. You will obviously not go off the track because you are already aware of these classical terminologies that I said: perineal abscess formation, perineal fistula formation, fecaluria, migratory polyarthritis. Those are like the words that would help you get back on the track that this is not intestinal TB. I mean, intestinal TB does not have these features. Now, if it's a two-step question, he will ask you what is the first investigation to be done or what's the best investigation to be done. Then I will be doing a set of following investigations. First is MRE. We'll make the patient drink oral contrast and we'll do a MRI. So MR enterography will be the initial investigation that will be done to determine the number of strictures that are present in the extent of the disease primarily. But now I need even more evidence. The evidence that I need to go ahead is a capsule endoscopy. Routine endoscope will not reach up to the jejunum or ileum where the disease is actually present. So I need to send in a small capsule that will a digital capsule swallowed by a patient, and this will take images of the entire length of the small as well as the large intestine. If in the question he says what is the first investigation to be done in this patient from the imaging perspective, then first imaging investigation to be done would be answered as MRE. But if you ask me single best answer for investigation of choice, then it is capsule endoscopy. Here there would be slight discrepancy from what the surgeon would be saying. He'll emphasize on the word MRE. I don't dispute that. He might even say that there might be very strong stricture or very powerful stricture or very severe stricture present at ileocecal area that the capsule can get jammed in that area. We first check out, if I know that the stricture is so small that capsule cannot navigate through that area, the capsule can get retained. I understand that. But we take adequate precautions. So the message here is most of the time the capsule is very small. It can navigate through a stricture as well. That is why it has been designed like that. You want digital images, real-time images of the actual lesions of the cobblestone mucosa. I said in today's evidence-based world where people say, show me the proof, you need to show the image that, okay, this is cobblestone mucosa in the jejunum, then some areas normal, then again the cobblestone mucosa is starting, then ileum, more cobblestone mucosa, normal area, again more cobblestone mucosa. So skip lesions and cobblestone mucosa needs to be demonstrated in the digital format. That is a capsule endoscopy would help us get that real-time evidence. Then there's an antibody which may be positive in these patients. Don't assume that this antibody is causative. It is just an associated antibody. Guys, this is not the causative antibody. It is rather one of the associated antibodies, but because of the peculiar name, that is anti-Saccharomyces CVSA antibody. The examiners love to, ask you these tongue twisting names. That is why it is being discussed at the moment. ASCA antibody can be associated. Plus, if you do a CBC with ESR, then obviously because this is an inflammatory disorder, so the erythrocyte sedimentation rate can be increased. Now he will ask you what is the drug of choice for management of this condition. The standard options would be sulfasalazine, mesalamine, azathioprine, biologicals also that I'll bring to your attention, and obviously steroids, budesonide. So among the four, can you select what is the drug of choice for this condition? Yes, guys, you guessed it right. The drug of choice for management of this condition is steroids. How would we give the steroids? It's not oral steroids. We will not give prednisolone because of obviously risk of avascular necrosis, Cushingoid appearance developing in a patient, menstrual abnormalities developing, diabetes mellitus risk, or at least impaired glucose tolerance risk with the usage of steroids on long-term basis. So what I will give to the patient is budesonide ileal release preparation. And along with that, I can use mesalamine for this patient, a controlled release preparation. Plus, we'll be giving azathioprine mycophenolate as a step up. Like if the patient is not improving with budesonide and mesalamine, I can add azathioprine or mycophenolate. And if it's still not improving, then it is biologicals. Biologicals are what examiner loves to ask. You see, from the pathogenesis perspective, one of the cytokines which is responsible for development of this disorder is tumor necrosis factor alpha. And because TNF alpha is the cytokine causing development of those aphthous ulcers developing in the intestine, and then there is these granulomas formation, there is like a transmural involvement occurring. The whole length and the whole, I would say, thickness of the intestine is involved. I mean, this is a full thickness involvement, transmural involvement. The disease, the ulcers in this condition can go so deep that they can even damage the serosa. That is why that fistula formation is occurring. Now, if there's an aphthous ulcer, it goes deep. It goes through the submucosal area to muscularis mucosa, penetrates through the main trach plexus, then reaches up to the serosa. That is why fistula formation is occurring. So TNF alpha is the villain which is causing all of this, that deep fissuring aphthous ulcers that would be developing in this person. And that is why in these patients, the biological that we can use as an anti-tumor necrosis factor alpha agents, that is infliximab and adalimumab, and we can also be using certolizumab for fistulizing or a perineal disease. So the main message is that if there is a fistula formation developing, that means the disease is extensive, then I mean, if I can go for a fistula excision also, like the surgeon, I can first get a fistulogram done, then I can send him to the surgeon can do a fistula excision. The problem is that fistula will develop again, maybe at the same site, or maybe 1 centimeter proximal to it, 1 centimeter distal to it. Patient will fight with the surgeon, you did not operate on me properly. So if I'm demonstrating a fistulizing disease in this patient, perineal fistulas present carrying that foul smelling discharge, I would be putting the patient on antibiotics. I'll obviously ensure be good hygiene, but then anti-tumor necrosis factor alpha, I mean anti-tumor antagonist need to be used, that is infliximab, which would help in management. Then another molecule that's used here is vedolizumab. This is an anti-integrin. Integrin, helps in adhering of the T lymphocytes with the bowel wall, so that adhesion of the T lymphocytes with better bowel wall can be reduced. Then is another monoclonal antibody that they love to ask, ustekinumab, that is anti-interleukin 12/23. So this also plays a role in the pathogenesis of the disorder. And I will be speaking about these biologicals even in rheumatology. In the rheumat, in fact, I've done a little more extensive discussion than what I'm doing at this moment in the GI section, because in India, we don't start with biologicals. In America, for management of Crohn's disease, right from first day, they go super aggressive and they give biologicals. But in India, you see, there's not medical insurance. People can't afford such expensive drugs. So we will be using budesonide ileal release preparation, mesalamine, and then we keep on upgrading. There are two ways to treat this disorder. One is you go aggressive, ballistic right from day one. First, and second is you go moderately aggressive approach right from day one. So that moderately aggressive approach is budesonide, and the ballistic and the super aggressive approach is to use biologicals like infliximab or vedolizumab for this patient. Then you will notice a lot of physicians nowadays started writing JAK inhibitors for this patient. JAK inhibitor that is specifically used for this condition is not tofacitinib. Tofacitinib that is being discussed in rheumatoid arthritis topic is a JAK1 as well as a JAK3 inhibitor. Here he will ask you specifically which JAK inhibitor is used. This was an INISET question, and your answer is ubardanacitinib. Especially if you are an FMG student, you can still skip the biologicals part and you can move on in the discussion. But if you are sitting for NEET PG or NESET, this is inexcusable. Most questions of Crohn's disease will focus on biologicals. Just like in asthma topic, I've highlighted biologicals, no? Dupilumab, mepolizumab, benralizumab. Similarly here, I focused on upadacitinib, that is a JAK1 selective inhibitor, which is used for these patients. And then like ustekinumab, anti-interleukin 12 and 23. And if you put practice, you'll be able to, this will become second nature for you over a period of time if you are going to practice with me. So as far as Crohn's is concerned, we are sorted. Like I said, the disease severity activity index is via CDI. Extent of Crohn's disease is via Montreal classification. Now, before I move on, a question to you guys again, though it's given in the notes, so don't move the notes now. Tell me for ulcerative colitis, where only the colon is involved, their small intestine is not involved, what disease is done to check for the disease activity or the severity of the disorder? Yes, guys, this is a repeat. NESET question was repeated in FMG exam, that what score will be used by you to assess the severity of ulcerative colitis. Your answer would be given as True Love and Witts criteria for severity of ulcerative colitis. What I'm discussing next before you is part 2 of the topic of inflammatory bowel disease, irritable bowel syndrome. And the word IBS and IBD can be confused by anybody if we read casually, but then that's only on casual reading. No, irritable bowel syndrome, IBS versus inflammatory bowel disease, there is huge differences, and one of the huge differences is presence of blood in the stool. In irritable bowel syndrome, he'll have abdominal pain. When you go to the washroom, he'll pass a lot of gas. He will be having constipation alternating with diarrhea. So in IBS patients, irritable bowel syndromes, they're like anxious people, and like a lot of these patients, they can sleep very comfortably. Crohn's ulcerative colitis patients will be having a terrible sleep. So sleep time is disturbed in irritable bowel syndrome. And apart from this, like in sleep time is not disturbed in irritable bowel syndrome, but sleep time is always disturbed in Crohn's and ulcerative colitis. And blood in the stool is again a feature of inflammatory bowel disease, not in IBS. I'll just write it just for the sake of completion, though I think this is very primitive and very easy for you to remember. IBS, the nighttime sleep of the patient is perfectly normal. They can sleep comfortably at night without a problem. But Crohn's disease patient will toss and turn in the bed because dard ho raha hai na pet mein, colic pain, because strictures ke through the food will be migrating, so it will cause abdominal pain. So IBD patients, the sleep time will be disturbed, but here the nighttime sleep is very good. And then there is no blood in the stool. Even if you do fecal occult blood, no visible blood to hoga nahi, even if you do a fecal occult blood, even that will turn out to be like negative. So no blood in the stool is found in IBS, whereas in IBD, obviously they can be bloody diarrhea. Therefore, to check for the severity, he said, what is the scoring pattern that is used? So we will call it True Love. True Love is rare nowadays, obviously. True Love and Witts criteria is used for assessing the severity at the moment. And here the couple of parameters, not that they've asked the parameters, but we'll just practice them. The number of stools per day, you can see going up to 6 per day, and most of the time it will be literally blood only. Patient will say first time when he went, it was maybe some fecal matter, but the second time when he went, there was like no fecal matter present. It was literally like bloody diarrhea that was occurring in this patient. The name was True Love and Witts. Then because there is blood loss, you will notice that the pulse rate is on the higher side. I'm not saying that there's a tachycardia and heart rate is more than 100. You can see in the classification, he said pulse rate going up to 90 or between 90 to 100. Normal pulse rate is 60 to 100. So here the blood loss is not so much that you'll be having like a hemodynamic crashing of a person. But yeah, the blood loss is substantial enough to result in like tachycardia in a relative faster heart rate in a patient, not fitting the definition of tachycardia. Then because of extensive blood loss, there would be anemia developing. Hemoglobin will begin to fall. A lot of these patients may self-diagnose themselves as having piles. But when you do a proctoscopy, there is no piles. In piles, in internal hemorrhoids, you will always notice that there would be veins at 3 o'clock area, at 7 o'clock area, at 11 o'clock area. This I'm just saying, you would have read that in surgery, that in hemorrhoids and piles, the veins will prolapse into the lumen of the proctoscope at primary piles position at 3 o'clock, 7 o'clock, 11 o'clock area. I'm removing this from the discussion because this is what you read in surgery. So if ever in doubt about somebody who's having blood in the stool, always do a proctoscopy, at least basic minimum investigation proctoscopy. If you can see the veins prolapsing into the lumen of the proctoscope, it's hemorrhoids. But this guy never came for follow-up, and now his hemoglobin is dropping. And when he will come for like proctoscopy now, because hemoglobin is falling, I will notice proctitis. Ulcerative colitis, guys, if he says what is the most common site that is involved, the most common site involved here is the rectum. The rectum was, remember, spared in patient of Crohn's disease, but is the most common one that is involved in patients of ulcerative colitis. This is referred as proctitis, and you cannot see any granulomas present here. Granulomas are a feature that are seen only in granulomatous colitis. That is why, like, ulcerative colitis is also called as non-granulomatous colitis. Then weight of the patient, some magnitude of weight loss can be present, and because this is an inflammatory condition, so you'll notice the body temperature being elevated for like maybe few days in a month or few days in a week. ESR would be elevated. These components would tell you that there is an inflammatory state happening. And then I also want to draw your attention to a negative acute phase reactant, that is albumin. Like ESR elevation, CRP positive, they are all taken to be positive signs, but I said the negative acute phase reactant would be albumin values, which would be less. The most common site involved in this condition, INV here basically means the most common site involved and not like investigation, obviously. That would be the rectum, and proctitis is the presentation. The IOC for this condition is colonoscopy, and we'll do a Montreal classification for again the extent of the disease. Extent of the disease can be involving only the rectum. Then it can go from the rectum to the rectosigmoid junction and then go into the descending colon. So if it's going in the descending colon, it will go up to the splenic flexure. If I do a crow diagram like this is like, let's say the descending colon. Then I've shown is the sigmoid colon, and then would be the rectum of the patient. So the disease is starting in the rectum, then it will go into the sigmoid colon, then it will go into the descending colon, and this is the splenic flexure as is written, or the tick mark. Then is the transverse colon, then is the hepatic flexure, and the ascending colon, cecum, and the appendix. So what I want to say is that the disease will progress like this, and I want to see the extent of the disorder. So the disease is limited to the rectum and to the sigmoid colon, descending colon. I'll write E1. But if it moves up to the splenic flexure and even goes proximally into the transverse colon, then I will say E2. And if it's moving down into the ascending colon also, then it would be E3. So extent of the disease is Montreal, but the severity is True Love and Witts criteria. And if he says what is the drug of choice for this condition, then I think you are aware that now the answer for drug of choice is changed. We don't answer sulfasalazine. That is because of the side effects that are associated. So the drug of choice for management of this condition is mesalamine with rectal steroids. The drug of choice for management of this patient is mesalamine with rectal steroids. In one of the questions, he mentioned a student is having ulcerative colitis, he's having an exam. So there was an ulcerative colitis exacerbation, like the number of stools has jumped up from 3 to 6 to 8 per day, and it's literally frying blood. He said, what drug would you be giving for a ulcerative colitis exacerbation? So I will be giving steroids more aggressively at the moment. That is budesonide enemas will be given to these patients more frequently so that the inflammation of the rectum can be subsided. I was initially also giving mesalamine, the rectal steroids. I mean, patient may or may not take it. Oral medicine patient will take mesalamine. So drug of choice mesalamine is okay. But the second thing is that rectal steroids thing, patient may not be like very comfortable taking it. But once there is like, severe bloody diarrhea, that is when patient might be agreeing to taking this, that is budesonide enemas. Then there's the role of biologicals here. So the anti-tumor necrosis factor alpha antagonist, as I've explained to you, is infliximab and adalimumab. Anti-integrin is vedolizumab. Anti-interleukin 12 and 23 is ustekinumab. And the JAK inhibitor that can be used for these patients at the moment is tofacitinib. Yes, guys, you heard it right. The JAK inhibitor that I can be using in this patient is tofacitinib. When I was describing Crohn's disease, I said tofacitinib is not recommended, and the molecule that I spoke was upadacitinib. But here JAK inhibitor, which is both like a JAK1 and JAK3 inhibitor, tofacitinib can be used. Traditionally, it is used in management of rheumatoid arthritis. Additional point I want to bring to your attention is an extraintestinal manifestation that can be seen in patients of UC, ulcerative colitis. Here, he will give you an image-based question. The image will be shown to you in the later part of the discussion, but at the moment I'm just giving you a heads up. The image will be of the shin of this person. He will give a description: patient having bloody diarrhea and like having weight loss, having low grade fever, his ESR is elevated, albumin is turning low, and then the image of the shin would be given on which an ulcer can be seen. He will say, what is this manifestation that is seen on the shin of these patients? Then your answer would be given as pyoderma gangrenosum. At this moment, I just want to draw a parallel example here. In the rheumat section, you will hear me talking about sarcoidosis lady, and she'll be having purple lesions on the shin, purple nodules on the shin. Those purple nodules on the shin are called as erythema nodosum. But at the moment, I'm talking about a presence of a ulcer on the shin of the patient, that is called as pyoderma gangrenosum. This was actually an FMG exam question, so I'll handle the image subsequently. But at the moment, just wanted to give you a heads up. I'll just say that fast again. In sarcoidosis on the shin, you can see some nodules. Those nodules are purplish. They are tender. They're called as erythema nodosum. But this time I'm describing an ulcer on the shin of the patient. That's called as pyoderma gangrenosum. The image to follow. At the moment, let's look at the next image. In this question, there were two images that were given labeled as A and B, and what my student said was that in the A image there was literally a blunting of the villi. You can notice the flattening of the villi which is happening here. And in the second one, he had mentioned that the doctor had identified the medical condition and had suggested dietary modifications. So after 4 weeks of dietary modification, when the repeat small intestinal mucosal biopsy was done, the image B was given, and he said like this repeat biopsy, you have to compare with the first one and tell about the disease. So you can see the regeneration of the villi. I mean, this is like that leaf-shaped, frond-shaped appearance of the villi. Villi increase the intestinal absorptive surface area. So since he himself mentioned that there was a dietary modification done by the physician, and after that there is a regeneration of the villi. So we're talking about an allergic condition called as gluten enteropathy. I mean, the moment I showed these two images to you, you would have been picking it up immediately that the case that I'm talking about is celiac sprue. In celiac sprue, the patient is having a gluten enteropathy. There is allergy to gluten, and this gluten is present in the following cereals, which are called as BROW, B-R-O-W. I'll just write down the names also for the sake of completion, though obviously you are aware of these names. That is barley, rye, oats, and then wheat. So BROW cereals are not to be given in these patients. The HLA associations are HLA DQ2 and DQ8. I would rate that as the most important information for celiac sprue, which is allergic response to gluten/gliadin present in the diet. So sometimes the question will say, what is the antibody responsible? The antibody name is TTG antibody, that is tissue transglutaminase antibody, that is TTG. And the specific antibody, if he says, then the answer is anti-endomyosin. You see, specificity does not gel with sensitivity. Sensitivity is true positive and specificity is for false negative. So first I need a test which is both sensitive and specific. So that is tissue transglutaminase antibody. And then subsequently, like to improve my diagnostic yield, I can do an anti-endomyosin antibody. If the patients are immunoglobulin A deficient, because IgA is the mucosal immunity, sometimes children have IgA deficiency, then it would be IgG class of anti-TTG or anti-deaminated gliadin peptide antibody that would be used. A bit of technical jargon, but you just have to take care of the fact that your first answer would be IgA class of tissue transglutaminase antibody. Now, what will you do in these patients for management purposes? So obviously you can't give BROW. So the mother or the adult person is asking, lots of time it will be child. There would be diarrhea present. There would be steatorrhea that would be described. So he will say, what will you give to the patient? So you can give quinoa, or you can give bajra, maize or rice with iron and folic acid supplementation. In celiac sprue, what we usually find is that duodenum is the one which is most severely involved. In celiac sprue, it is duodenum. Duodenum is the site mainly for iron absorption. The second part that is involved very severely is the jejunum, though the severity is less. So I've just put like a double hashtag sign for duodenum, single for jejunum, to say that the injury in the proximal part of the intestine is more than the distal part. Most of the time ileum is spared in this condition. Because ileum is spared in this condition, so vitamin B12 deficiency is usually not seen. Duodenum is damaged, so that is why there is an iron deficiency. So I put double arrows to say severe iron deficiency. Jejunum is affected, so there is a folic acid deficiency present in this condition, but B12 levels are normal. And because of the fact that iron and folic acid deficiency is present in these patients, that is why he might even mention regarding presentation of dimorphic anemia in this condition. Celiac sprue will require extensive follow-up because these patients in future can develop type 1 diabetes. They can develop a skin manifestation. This skin manifestation is the starting point of a lot of questions. That is dermatitis entero. The name itself is like very characteristic. Dermatitis herpetiformis. This dermatitis herpetiformis, how the question would be given is what I'll show before you next. The question will begin by saying that a teenager has been brought to your OPD, and the complaints of this teenager are that there are pruritic papules. In fact, sometimes he may even show the image of the elbow of the patient. There would be so much of scratching marks here that literally some excoriation marks and bleeding can be seen from this area. So pruritic papules on the elbows and pruritic papules on the knees of the patient is the representation that would be seen in DH, that is called as dermatitis herpetiformis. For the workup of these patients, I will be doing a test now that is called as anti-epidermal transglutaminase antibody. If you're paying attention, you will notice that the antibody for diagnosis was TTG. It was tissue transglutaminase antibody. But for like dermatitis herpetiformis, obviously because it's a skin manifestation, your answer is anti-epidermal transglutaminase antibody will be useful for diagnosis of this condition. So this is the antibody useful, and the manifestation is pruritic papules on the elbows and knees. For the management of this condition, we shall be using Dapsone. Obviously for celiac sprue, I'm gonna go for dietary modification, but for the treatment of DH, it is Dapsone that would be used. And then comes a horrible complication. He will say, what is the most common cause of death in patients of celiac sprue? The most common cause of death in the options, diarrhea will be given, dehydration will be given, electrolyte imbalance will be given. Obviously all of them will be there. Diarrhea will also be there, dehydration, electrolyte imbalance will be there. But the most common cause of death should be answered as lymphoma of the intestine. Yes guys, it is lymphoma of the intestine that is the cause of death. Enteropathy associated. The technical word is enteropathy associated T-cell lymphoma. So this is again an important question from the medicine perspective, that you need to remember that the number one cause of death in patients of celiac sprue is EATL. EATL would stand for enteropathy associated T-cell lymphoma. Obviously like diarrhea, dehydration, malabsorption, and even like I can say the presentation of electrolyte imbalances all will contribute to mortality, but the number one is EATL, and this is a condition in which there is an allergic reaction to gluten. There would be maximum damage to the duodenum, then to the jejunum, and usually the ileum is spared. So I'm just erasing this ileum word from the discussion to say that if I write it just like that, it may look like a misplaced entry. The point I'm trying to bring to your attention is that in celiac sprue, proximal part of the intestine is usually involved and the distal part is usually spared. This is in contrast to a condition called as bacterial overgrowth syndrome, in which it is the ileum that is mainly damaged and the proximal part is less affected. Celiac sprue mainly causes proximal damage. That's the reason a lot of cases of celiac sprue may present only with iron deficiency anemia initially. The severity of presentation can also vary. Obviously the diarrhea, steatorrhea, malabsorption, vitamin, fat soluble vitamin deficiency will be there because of the steatorrhea component. So vitamin A, D, E, K deficiency can also be given. At this moment, a general question, what is the investigational choice for malabsorption syndrome? Your answer would be fecal fat estimation, where there is more than 7 gram of fat determined by Sudan 3 stain. As far as the clinical bites for this condition are concerned, I'll just, summarize it, though I have just said this before you. The clinical bites for celiac sprue will be, the question will begin by saying that patient is having weight loss, or he may write the word FTT, that is failure to thrive, that the weight of the child is not increasing because there is a diarrhea. Then he will obviously talk about the diarrhea, steatorrhea manifestation. I mean, there's foul smelling stools. These foul smelling stools will be difficult to flush away. Along with this, he can mention manifestations of fat soluble vitamin deficiency, like vitamin A deficiency can cause night blindness in a child, D can cause bone pain, E can contribute to acanthocytes in a peripheral smear, but K deficiency can contribute to development of bleeding. So don't be surprised if you read about purpuras or you read about bleeding incidence being more in patients because fat soluble vitamin, that is vitamin K, is not getting involved. And along with that, he will mention that the patient is having dimorphic anemia. Meaning of the word dimorphic anemia is that there is iron deficiency anemia also happening, and there is folic acid deficiency causing macrocytic anemia. So when micro and macrocytic anemia coexist in a patient, then we call it dimorphic anemia. So these would be like a couple of clinical bites for the topic of celiac sprue that would be given. And sometimes the question may be in retrospective. He may tell you all this in a 4 or 5 liner question. Like in FMG exam, what happened was it was almost a 5 liner MCQ. My student said, sir, aankheं thak gaya padhte padhte. Last mein kya pucha? He said, what is the reason behind it? That is HLA DQ2 DQ8. Obviously, like, he said, sir, I was searching for an allergy to gluten. There was whether there is any mention of gliadin enteropathy. There was no gluten written in the question. क्योंकि इतना आसान भी नहीं करेगा ना कि भाई gluten enteropathy and gliadin sensitivity. So in the paper, it was like the reason why you get the development of this clinical presentation is answer is genetic susceptibility due to HLA DQ2 DQ8 positivity. And the second must know image for this topic is like there is a small intestinal mucosal biopsy that is given. I would also like to highlight, I'll use a different pen to highlight this statement. The gold standard investigation. The gold standard investigation for diagnosis of celiac sprue is a small intestinal mucosal biopsy. But lots of time you see, because it is invasive, you may not get a consent from the patient. So if I'm not getting a consent, that does not mean that I can't diagnose the disease. No, I can still do the antibody test, anti IgA class of anti-TTG antibody. Just for the sake of completion, additional point added, gold standard investigation to be done for celiac sprue, small intestinal mucosal biopsy. Initial report will be showing what you saw initially, that is that very classical blunting of the villi. I mean, you can see the classical blunting of the villi. Now we have stopped gluten in this patient, and after 6 weeks we are starting we are starting feeding in the patient, but this time it is like a gluten-free diet, like quinoa or maize or bajra is being given. So you can notice the regeneration of the villi that is happening. The image here is showing villi in comparison. One is before the gluten was present in the diet, and the B images after a strict gluten elimination. In the MCQ, the word gluten was nowhere to be found. So like if you are thinking that gluten gliadin word will be given, no, they will not be given. They'll just begin by describing a patient having anemia, failure to thrive with manifestations of bleeding and diarrhea, steatorrhea, weight loss, and that's when he will expect you to pick up these specific findings that I highlighted before you: HLA DQ2 DK8 positivity or association with dermatitis herpetiformis, risk of type 1 diabetes, or EATL, that is enteropathy associated T cell lymphoma. The investigational choice for malabsorption has already been spoken about. 72 hour fecal fat estimation. Now I'll talk about Whipple's disease. Whipple's disease is again a favorite of our examiner because of association with this bacteria. When you read the name first time, it looks like a fungus actually. The name is Trophema whippleri. The name is Trophema whippleri. In fact, sometimes he just asks, what is the cause of Whipple's disease? Answer is, it is a intracellular bacteria. All that purple thing that you are seeing is the bacteria concentrated in the cytoplasm of the macrophages of the intestine. This is a intracellular bacteria, guys, in the macrophages of the gut. Unlike Helicobacter pylori, which is an extracellular bacteria. Helicobacter pylori is an extracellular bacteria. Here, Trophema whippleri would be an intracellular bacteria. And this intracellular bacteria that I said, this is found it is present in the macrophages of the GI tract. The point to be understood is when I'm talking about macrophages of the gut, they are trying to destroy the bacteria, obviously, but the infection is very deep-seated. Like this particular condition, because it's a very deep-seated infection, so for management of this condition, we have to give ceftriaxone. Yes, guys. Like normally GI diseases, we don't give ceftriaxone is a high power antibiotic. You use it in meningitis, you use it in typhoid, but today you're using ceftriaxone for management of a GI malabsorption. Yes, because it is a deep-seated infection. The bacteria hides in the security system of the gut. Just like HIV virus, HIV virus is infected by it infects the white blood cells, and white blood cells are searching for it everywhere, whereas it is hijacking the white blood cells. Similarly, this particular bacteria is hijacking the security system. It is searching for the bacteria everywhere. And where is the bacteria hiding? In the security system. I'll say that again. Just like HIV virus hides in the white blood cells, the white blood cells, the security system is searching for the virus everywhere. It is sitting in the security system, hijacking the command center. Similarly, here, this is a nasty infection which contributes to damage to the gut from within. The question will begin with the adult patient. This time, most of the time, he will say he's having diarrhea, steatorrhea, weight loss standard. Then he will tend to delve into a couple of these facts which have to be remembered, especially like arthritis that could be present in these patients. Yes, this organism can contribute to development of arthritis component. Then there can be low-grade fever of phenomenon, hyperpigmentation. Especially the manifestation number 2. And manifestation number 4 may be the opening line of the MCQ. That is to, waste your time. Like, in recent FMG exam, there were 5-liner, 6-liner questions. So he increased the length of the question by writing all these things like joint pain being perceived, hyperpigmentation. Hyperpigmentation can be due to nutritional causes in these patients also, no? That can cause hyperpigmentation of the skin. So the message here is that 2 and 4 are like data not very clinically relevant, but they are used to increase the length of the question. But then obviously the standard thing which you have to pick up is, what is the main pickup point in the question is point number 1, diarrhea, steatorrhea, weight loss tells you it's a malabsorption syndrome. The investigation choice for this condition is to go ahead with a duodenal biopsy, and then it will be stained with a special stain. The name of the stain is PAS positive. In your entire medical curriculum, 2 times you read PAS positivity words. Hemat I'm not talking about, I'm talking about from the perspective of GI. PAS positive inclusions in hepatocytes. That is alpha-1 antitrypsin deficiency. The topic of alpha-1 antitrypsin deficiency is covered in the lung section. If you go towards the end of lung section, I've discussed alpha-1 antitrypsin deficiency. I've said presence of PAS positive inclusions in the hepatocytes. But today I'm talking about PAS positive bacteria, PAS positive macrophages, which is because of the bacteria concentrated in the security system. And I can do a PCR on the blood sample of this patient as well. But the main investigation is a duodenal biopsy with a report saying PAS positive inclusions. For the treatment of this condition, as I've explained to you, we give an antibiotic which has a high power of penetration into deep-seated tissues. And then I will be putting this patient on trimethoprim and sulfamethoxazole. Last time I spoke about trimethoprim sulfamethoxazole was for a person of pneumocystis jirovecii pneumonia. He was a HIV positive patient with CD4 count less than 200. But here it is like for 6 to 12 months that trimethoprim and sulfamethoxazole would be given. Now, for those of you preparing for NEET PG or INISET, they will ask you one step ahead. They will ask you what are the complications that can be seen in this patient. So one you could be having is a development of cognitive decline. You could be having like dementia-like manifestations occurring in these patients. You could be having like neurological complications like oculomasticatory. This is a very peculiar terminology. In fact, what I'm writing at the moment was asked even in NEET SS exam. And you also need to remember this terminology, especially if you're sitting for INISET, oculomasticatory myarrhythmia. You don't read this term anywhere else in medical literature except for the topic of like Whipple's disease, and then it can have cardiac involvement as well. The cardiac involvement is culture negative endocarditis with mainly aortic valve being involved, more common as compared to aortic valve. Why this is being asked is simply because when you read about malabsorption or when you read about like Whipple's disease, thought process it's a GI disease. लेकिन ये तो joints को भी involve करता है. This disease can cause arthritis. So that's the peculiarity of the disorder. Arthritis that can precede the GI symptoms, that is one. Second, it can cause CNS manifestations. Third, it can cause cardiovascular associations. So Whipple's disease from the GI perspective तो बहाना है. Actually में वो क्या सुनना चाहता है? Joint involvement, brain involvement, and the cardiovascular associations that are seen in this condition, and also the fact that for treatment of Whipple's disease, we start with the 3rd generation cephalosporin. Initially, like this ceftriaxone IV will be given for about 2 weeks. They'll not ask you this 2 weeks, or they will not ask you this 6 to 12 months. That is only for improving your comfort level. But I wanted to say that I'll first go a little aggressive, harsh on this bacteria, and then we start using trimethoprim sulfamethoxazole for 6 to 12 months, and can be associated with CNS manifestations, including that peculiar oculomasticatory myarrhythmia and cardiovascular association. Next stain that I'm showing before you is Warthin starry stain. This brownish yellow color stain that you can see is what is called as a Warthin starry stain. This is a silver stain, and then you can notice the mucosa, and you can see this like rod-shaped bacteria which are like extracellularly present. So this Warthin starry stain, that's a silver stain, is demonstrating extracellular bacteria, and the extracellular bacteria is by the name of Helicobacter pylori. Guys, this bacteria can even cause a development of a tumor in the stomach by the name of maltoma, mucosa associated lymphoid tumor. So a question in the paper said like which tumor can be prevented by administration of antibiotics. You can understand that if I will kill this bacteria by giving antibiotics, I will just talk about those antibiotics also, like we'll talk about triple therapy, we will talk about quadruple therapy, but at the moment the word is Helicobacter pylori. This bacteria is an extracellular bacteria. It is a urease producing bacteria. The enzyme will cause alkaline pH in the stomach. You see, the point is, this is a very smart bacteria. He knows that stomach, we can hurt the ego of the stomach. And if you hurt the ego of the stomach, then the stomach will, I'm just putting in literal term. Ego means G cells, right? Alkaline environment will irritate the G cells. क्योंकि stomach का ego hurt हो गया, it's producing more acid, more acid, more acid. Then more acid will cause damage to the stomach itself as well as to the duodenum. I'll say like this: if somebody irritates you, don't respond. If you will in ego respond, you will cause more damage to yourself than to that person, right? Like somebody is trying to irritate you without a reason. If you will react, that's his purpose. No, he wants to irritate you. If you will react, that means that you have actually lost the battle. Never get into a fight with people, as they normally say, no, avoid the fight till the very last moment. Similarly, here this bacteria is irritating the stomach. So the stomach is reacting. अरे तू मुझे challenge कर रहा है कैसे? Because the bacteria is producing alkaline pH. The enzyme urease produces a alkaline pH in the microenvironment of alkaline pH in the stomach. The stomach's ego is hurted. He said, "अरे मुझे मेरे सामने alkaline pH, right?" So the stomach is now producing more acid to counterbalance that alkaline pH, and that more acid is actually causing harm than benefit. Obviously, it's thinking, I will eradicate the bacteria. It's not getting eradicated. Rather, the acid is damaging the mucosa of the stomach or the mucosa of the duodenum, and you could have peptic ulcer disease. Helicobacter pylori knows that stomach is a very egocentric organ of the body. This extracellular bacteria contains an enzyme by the name of urease, and this urease enzyme causes breakdown of urea to produce ammonia. Now, if you are having ammonia, ammonia is highly alkaline. If this will be having ammonia production in the microenvironment of the stomach, then ammonia production in the stomach would result in irritation of the G cells. The irritation of the G cells will cause irritation of the parietal cells, and parietal cells know only one thing: acid production. The extra production of extra stimulation of parietal cells due to microenvironment of alkaline pH being created by this bacteria will now cause hyperchlorhydria. This explains why these patients would be having epigastric pain, why these patients would be having peptic ulcer disease manifestations. I'll just write it once again. Hyperchlorhydria is the manifestation that I'm talking about with Helicobacter pylori, and this organism is also called as a class 1 carcinogen. It's called as a class 1 carcinogen by WHO because it can cause a tumor by the name of multoma. The clinical manifestations that will be occurring in these patients will be mainly in the form of deep boring epigastric pain, and this epigastric pain will then cause the patient to think that maybe he's eating too much of spicy food. A lot of people will do all kind of dietary modifications, but nothing is going to work. I mean, Helicobacter pylori, the main complaint is continuous epigastric pain, and most patients use PPIs, and this is usually a PPI abuse because the problem is not that there is extra production of acid. If you can just kill the bacteria, then the extra production of acid would be circumvented. So what is the screening test available for this condition? We don't need to go ahead with the endoscopy. The screening test in this patient is UBT, that is called as the urea breath test. It's a non-invasive test. It will tell you regarding the presence of this bacteria. Urea breath test is answered 2 times. It is the screening test for this condition. It is also done to confirm the eradication of infection on therapy. It is basically, the word here is, I'll just modify that slightly. It is eradication on therapy. The point is this bacteria, the highlight of this bacteria is that this is a gram-negative Coccobacillus and it is a non-sporing bacteria. I'll just write this. This is a gram-negative Coccobacteria, and normally bacteria live either in coccoid format or they live in bacilli format, but this is a smart bacteria. It can survive in both coccoid as well as bacilli formation. Then what I also added was that this gram-negative Coccobacillus, it can live in little bit of oxygen because in the stomach there is hardly any oxygen. So it's a microaerophilic bacteria. That's the second criteria of this. And the third criteria, or the third feature of this bacteria, is that it can spread via fecal-oral spread. That's important, guys. I mean, ulcers are more common in developing countries than developed countries. It is low socioeconomic strata society countries which will be having a higher burden of peptic ulcer disease because of fecal-oral spread. And as I said, this bacteria, gram-negative Coccobacillus, is a non-sporing bacteria. The importance of knowing this microbiological information is that if you kill it, then you are able to eradicate it. That's why I said confirmation of eradication on therapy. Confirmation of eradication on therapy. I'll talk about the therapy also, but at the moment, like the main focus is that any non-sporing bacteria, if we are able to tackle it head on, then eradication is possible. At this moment, an invasive test that is useful for diagnosis of this condition should also be mentioned. This invasive test that I'll be doing is along with upper GI endoscopy. When you do upper GI endoscopy, I will be taking a scraping from the wall of the stomach, and the test that we'll be doing is called as a urease test that helps in identification of a Helicobacter pylori, and then comes the treatment of this condition. For the treatment of this condition, earlier we were using triple therapy, but now triple therapy is not recommended for these patients. Like the treatment that was being given for these patients was clarithromycin with amoxicillin and then PPI. But now he says don't use clarithromycin because of resistance in India most of the time. So what we can use is quadruple therapy in this patient. Bismuth and quadruple is the first line. What I mean by quadruple is the first line is, let me write down the drugs here, the antibiotics first. The antibiotics that I can be using is like tetracycline. Then the second one that I'll use is metronidazole. The third medicine that I can use here is bismuth. Bismuth has an anti-H. pylori action, and it also has a surface protective agent that it coats the base of the ulcer, so it reduces the acid mucosa contact time. And apart from tetracycline, metronidazole, and bismuth, I will be using PPI in this patient. So in quadruple therapy, it is like now the first line, that is, earlier it was like triple therapy followed by quadruple. If there was no improvement with triple, we used to go for quadruple. But now he says because of the high clarithromycin resistance, it is quadruple therapy that is recommended. A tumor that can be caused with this is called as maltoma. As I said initially, this bacteria is a class 1 carcinogen. So I'll just add that feature right here. This organism, class 1 carcinogen is one which WHO, when you read the WHO classification for class 1 carcinogen, it says that presence of this ensures that after a few years, cancer will develop. The usual list of class 1 carcinogens that I would like to share with you, or just say it verbally at the moment, is Epstein-Barr virus. Epstein-Barr virus can cause nasopharyngeal cancer, Burkitt's lymphoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma. Just like, human papilloma virus 1618 can cause cervical cancer. So normally when you read that list, it's always viruses that can cause cancer, like HIV associated with Kaposi sarcoma, HIV associated with non-Hodgkin's lymphoma of the brain. So viruses are leading the list when it comes to class 1 carcinogen. But even H. pylori, that one we have discussed, is a class 1 carcinogen because the presence of this in the long-term basis in patient can cause a development of a tumor by the name of maltoma. And what I'm saying is that if I eradicate this infection with quadruple therapy, then this maltoma is not gonna happen. This maltoma will not happen. That's the last line that I put up here, that maltoma can regress after H. pylori treatment. At this moment, I also want to bring to your attention that if he says what is the most common cause of vomiting of blood, then please don't answer esophageal varices. The most common cause of vomiting of blood in a patient is peptic ulcer disease. Most of the time it's a duodenal ulcer where the bleeding can be occurring from the gastroduodenal artery, and sometimes this bleeding can be so fast and so aggressive that not only patient will vomit blood, but the blood will progress down by itself because of the blood is coming from an artery. It moves fast through the gut, and it can cause hematochezia with hemodynamic instability in a patient. The source of bleeding in a bleeding duodenal ulcer, bleeding duodenal ulcer, the source of bleeding would be gastroduodenal artery. This is overall the most common cause of hematemesis. Though if he says alcoholic, फिर कोई चक्कर नहीं है. Alcoholic है तो obviously it will cause cirrhosis, portal hypertension, and after portal hypertension there would be a development of bleeding esophageal varices in a patient. So for the second question, I don't think so anybody will have any hassles in answering. But for overall number one cause, it is peptic ulcer disease. If he mentions the word alcoholic, or he mentions the word splenomegaly, that is like indicating portal hypertension in a patient, or he can mention the word caput medusae. I'm trying to give you alternative terminologies. Not all questions will say the word alcoholic because then it will become very obvious. So instead of saying alcoholic, he may write down findings of portal hypertension. He will say patient is having vomiting of blood. On examination, caput medusae is noted. Or he might say ascites is noted. If you have any one of this information that I've currently written here before you, ascites, caput medusae, or for that matter of fact, the word splenomegaly written in any question, these are surrogate terminologies. These are surrogate terminologies for alcoholic patient. I'll repeat my statement. Alcoholic patient will have cirrhosis. Cirrhosis will cause ascites. It will cause portal hypertension. So there would be dilated veins around the umbilicus. I'll show you caput medusae also in the image-based format when the time comes. And then would be splenomegaly. All these are indicators. All these are indicators that the question is talking about alcoholic. So if he writes alcoholic, ultra cool. If he does not write it, I'm still going to crack it on the basis of the inputs that I have currently mentioned before you. The most common cause of painless hematochezia in an old man. And when I'm saying the word painless hematochezia in an old man, like the usual cause for this would be answered first as hemorrhoids only. But in hemorrhoids, there will be no need of any admission. There would be no need of any hospitalization. Suppose he says that the person required hospitalization. In those circumstances, painless hematochezia old man, the hemorrhoids are the first cause. Hemorrhoids will never cause like hospitalization in a patient. If he mentions that the hospitalization was required, then you will answer it as diverticulitis. I'm gonna just highlight this once again with red color only to keep the symmetry on for like the colors on the slide. The number one cause of hematochezia in an old man, your answer is hemorrhoids. They're the same hemorrhoids, internal ones that I was describing at 3 o'clock, 7 o'clock and 11 o'clock position. But suppose if this is not given in the options, then your answer would be given as diverticulitis. What is the word that you will search for? If he says that the patient need hospitalization, then it is not hemorrhoids, then it is diverticulitis. If he does not mention anything, most common cause of painless hematochezia, old man, so old people, sedentary lifestyle, they can be hemorrhoids present, but diverticulitis will always cause blood loss to be severe enough to cause a development of hospitalization. And then comes the question by which I started the discussion, that what is the first investigation of a hematochezia patient with an unrecordable blood pressure? Then your answer is, this is what Harrison flowchart says, that don't go for colonoscopy. He says you will do a colonoscopy subsequently if you don't find anything in the upper GI, but first investigation, the word is first. I will do a colonoscopy if I don't find a cause, but first investigation of hematochezia with a crushing blood pressure in a patient, the algorithm says that you should go for upper GI endoscopy. Most of the time it will turn out to be a peptic ulcer, a duodenal ulcer, gushing like blood. It's literally fawara, khoon ka fawara chal raha. It's like a fountain of blood. The blood is spurting from gastroduodenal artery, a large artery, from the branches of the celiac trunk, which is directly coming from the aorta. So the blood loss can be fairly extensive. Then what is the most common cause of melena? Melena means black tarry stool. It is as black as coal tar. It sticks to the toilet seat. It is difficult to flush away. Not every black stool is melena. It's like very dense black coal tar like stool present sticking to the toilet seat. The most common cause of melena is going to be answered as peptic ulcer disease. So guys, melena is again because of PUD. The overall most common cause of hematemesis is peptic ulcer disease. That's okay. But then the leading cause of hematemesis will also cause sometimes blood to come slowly also. No? Like it's not necessary always that it's the main trunk of the artery that is affected. It's the branches of the artery that are affected. So if little blood will keep on oozing. It's not full penetration that has happened up to the artery. It's the branches, superficial ones that are getting affected. So that little blood would contribute to development of degradation by the intestinal enzymes. And this can cause a black tarry stool, that is peptic ulcer disease. Okay guys, so we'll next discuss a very easy topic, that is achalasia. Can you tell me the most common cause why we get achalasia? I understand that in this condition, there is like degeneration of inhibitory neurons, nitric oxide producing, VIP producing. So because of the loss of inhibitory neurons in the Auerbach plexus, A for achalasia, A for Auerbach plexus, the inhibitory neurons are gone. So therefore the tone of the lower esophageal sphincter in this condition will be increased. If the tone of the lower esophageal sphincter will increase, then food will not be able to go down from the esophagus into the stomach, and therefore the patient will say that the food sticks behind the chest bone. Yes guys, overall the most common cause of achalasia is not Chagas disease. Chagas disease is something that you come across mainly in South America. So suppose I was describing a patient from Brazil, or if I was talking about like Peninsula, Peru, etc. And then I said the patient was having a mega heart. What I mean by mega heart is that this parasite would cause damage to the myocardium, so they can be dilated cardiomyopathy. Then it can cause damage to the esophagus, so you could have a mega esophagus, that is achalasia. It could damage the motility of the colon, so there could be a mega colon happening. So suppose in the question question, I was mentioning ethnicity of the patient who's come on medical tourism to India. Though it's very unlikely, why would a South American patient come all the way to India? They'll go to America, they'll go to Canada, better medical facilities there. But then the point is, Chagas disease per se would be having DCM megaesophagus megacolon, that is Trypanosoma cruzi is the parasite in this particular case. But this, like the disease is unlikely to be present on a global basis as a cause of HLHA cardia. I gave sufficient time for you to think about it, and if you are like checking out the printed notes, then the real thrill goes away because it's already printed. So I would suggest you to take the unannotated part PDF, and then if you practice, you will be able to retain and understand things better. The most common cause for this would be answered as autoimmunity. Yes, guys, autoimmunity. That is why most MCQs on this topic will begin by saying a young female with progressive dysphagia. That progressive part is because the autoimmunity will continuously damage the inhibitory neurons of the Auerbach plexus, and thereby there would be two things developing in this patient. HLHA cardia from the pathology perspective is characterized by one, development of aperistalsis. So the food will stick behind in the lower part of the esophagus. It's not going down. In you and me, not even a single drop of food and water will ever be retained. But in these patients, the food and water will get stuck behind aperistalsis. And second, the lower esophageal sphincter tone will be increased. At this point, I also want to say that if the food is getting stuck here, then solid due to its weight can still go down. But liquid is lighter, so it will not be able to go down. So all MCQs of this topic will usually in the clinical bites, he will always say, the language of the question will always say young female. Then he will say progressive dysphagia. What I mean by progressive is that as compared to last year and last to last year, the symptoms of this patient are worsening. He may not write the word progressive, but the language of the question will give you a suggestion of the fact that the symptoms of the patient are deteriorating because autoimmune disorders worsen with time. So progressive dysphagia would be mentioned. And as I said, that because liquids are lighter, so they'll not be able to go down. Solid food, because of its weight, can still go down into the stomach, but liquid is light, it will not be able to go down. At this moment, I also want to say that in you and me, not a single drop of water will ever remain behind in the esophagus. But in this patient, the water can be retained in the esophagus. The question will mention dysphagia more for liquids as compared to solids, and also because like food and water can be retained there, so the food will keep on getting rotted, and therefore halitosis, regurgitation of food items, and even recurrent pneumonia episodes can be written in this particular question. I'm not written that because that's a very standard information that you always read with respect to esophageal disorders. Halitosis, bad smell because food and water will keep on rotting here. Regurgitation of food items, not vomiting of previous day food items. Vomiting of previous day food items would mean contents coming from the stomach. I said vomiting of previous day's food items. No, I said regurgitation of food items. And then can be like recurrent pneumonia episodes, because if this patient has a heavy meal is lying down, then microaspiration can occur and therefore pneumonia presentation would be there. Now, as far as the types of HLHA cardia are concerned, there's a Chicago classification, so another setting name coming up, like I was describing Vienna classification for the extent of ulcerative colitis and Crohn's disease. Now the name is Chicago classification, which classifies this into total of 3 varieties. The traditional one that I was describing was type 2, in which there was absent peristalsis and there was an incomplete relaxation of LES thanks to the loss of Auerbach plexus inhibitory neurons. Then in type 3, however, they can be spastic distal contractions. So don't be surprised if you read chest pain. Normally in HLHA cardiac questions, he will not mention chest pain like if it's an FMG exam question. But if it is NEET PG, he will begin by saying young female comes with. And then he will say that she's having recurrent episodes of chest pain also. That may be intermittent chest pain. You might start thinking that the question is on diffuse esophageal spasm, because diffuse esophageal spasm will also be discussed subsequently where chest pain will be described. But the barium swallow image given or the findings given on manometry will be totally different. Here the manometry findings will be mainly in the lower 1/3 of the esophagus. There would be demonstration of aperistalsis and lower esophageal tone in this condition would be increased. So the disease has a predilection to affect the lower 1/3 of the esophagus. Let me just rephrase this here. The word is aperistalsis. It usually does not involve the whole of the esophagus. The predilection is for the lower 1/3 of the esophagus. And now the question for you guys is, what is the cause of pseudo-HLHA? The word pseudo-HLHA, as the name suggests, is obviously it's not due to autoimmunity, neither due to Chagas disease. So what is the cause of development of pseudo-HLHA? Okay, I'll give a hint. There's a condition which causes linitis plastica. All of you know, no, leather bottle appearance of the stomach. That leather bottle appearance of the stomach is because of carcinoma stomach infiltrating into the wall of the esophagus. So just like you can relate to the fact that the stomach cancer, adenocarcinoma, can infiltrate into the wall of the stomach and can cause a leather bottle appearance, linitis plastica, the cancer can go up also, and it can involve the Auerbach plexus of the esophagus, and therefore pseudoachalasia will occur. The answer for pseudoachalasia would be answered as malignancy, or if he wants to be more specific, he will say which malignancy, then answer would be given as carcinoma stomach. Again, this was an FMG exam question. What is the cause of pseudoachalasia? Answer is stomach cancer, cancer infiltrating into the wall of the stomach and can retrogradely move up into the wall of the esophagus, causing infiltration and damage to the Auerbach plexus. It's a physical damage to the Auerbach plexus, but in the overall most common cause, it is autoimmunity antibody mediated damage. From the barium swallow perspective, what is the finding that is shown here? Then please don't answer it as the rat tail appearance. The rat tail appearance will always be having irregular margins. No need to draw at the moment, guys. Just follow me. In malignancy, you will always notice irregular margins. Here, if you check out, it is very smooth margins. If I do marking here, you will notice that this has very smooth outline present. So any condition which is having a cancer will always have irregular margins, whereas when it comes to a benign condition, very smooth margins would be present. The classical terminology that is used for this is a Birdback appearance. And then apart from this, there would be a sigmoid word to say that the proximal part of the esophagus will appear relatively more dilated, because sigmoid colon is one of the most, sigmoid colon is like a dilated part of the colon. So that's why the word sigmoid esophagus is used in a literal sense to describe the dilatation of the proximal part, and the distal part is contracted because of loss of inhibitory control. I am erasing this irregular filling defect because it will cause unnecessary confusion if it is present in the handout just like that. So we'll keep it to the point. Cardia is an autoimmune condition where air peristalsis predominantly affects the lower 1/3 of the esophagus. The proximal part gets dilated and the tone of the sphincter is more due to loss of inhibitory control. I'm saying that again and again because that is what people forget. Inhibitory control is lost, tone of the sphincter is more, and chest pain can be deliberately given as opening line of the MCQ to make you think in terms of diffuse esophageal spasm, though that would be discussed separately. But then the features that are mentioned, especially the word liquids more than solids, the dysphagia component more for liquids as compared to solids, is a very good pickup point in a question, along with halitosis and like regurgitation of food items that were consumed previously. Now, as far as type 2 is concerned, it shows very good response to pneumatic dilation. And apart from pneumatic dilation, I can also inject botulinum toxin into the lower 1/3 of the esophagus. So at least that contracted part of the esophagus would, become lesser, and therefore like the food will at least be able to go down. So combination pneumatic dilatation botulinum toxin will do wonders for the patient. Worst prognosis is with respect to type 3. The surgery of choice in this condition is Heller's myotomy with partial fundoplication. That fundoplication is done to prevent the development of GERD, because you are trying to ease off the pressure in the sphincter, so the reverse can happen. There can be reflux esophagitis, and this is effective for all the varieties as mentioned for all the Chicago types, especially type 1 and type 2. Type 3 relatively has a bad prognosis, and then other methods which are available would be written in MCQ as PD, that is pneumatic dilation, botulinum toxin, and even calcium channel blockers. And remember, cardia is a pre-malignant condition of the esophagus, and now we'll be comparing this condition with another one where halitosis, regurgitation of food items would be given. Let's look at this condition, which is called as Zenker's diverticula. In this condition, you can see the food will be retained in this posterior diverticula. This is also written in MCQs as pulsion. Either the word written is Zenker diverticulum or it would be written as pulsion diverticula. There would be retention of food present here, and the diverticula could be developing from any of the following areas. One, you can notice that the pulsion diverticula could be originating like this from the weakness that is present in this triangle, which is at the junction of the smooth muscle and the cricopharyngeus. Can you tell me the name of this anatomical triangle which is present just below cricopharyngeus? Yes, guys, the name of this anatomical triangle would be called as Lymer's triangle. Yes, this is not to be answered as Zenker's. In Zenker's diverticulum, traditionally we always read about what is called as Killian's triangle, but the yellow marking that I've shown is not the Killian's triangle, it is Lymer's triangle. The one which is marked purple if the diverticula was developing from this area, like if I mark a diverticula originating from the area that I marked in purple or magenta, then I will be calling it Killian's triangle. So yes, the more common site among the two is obviously Killian triangle. So I put 2 star marks for this as compared to Leimer's triangle. But then the point is the inherent weakness is because of the arrangement of the fibers. You can see that the inferior constrictor fibers are obliquely placed. This is esophagus shown posteriorly. This is esophagus shown posteriorly. I have shown inferior constrictor, that is, I would say, fibers which are present obliquely, and cricopharyngeus fibers are transverse. If you check out the representation, you will notice these are the transverse fibers of cricopharyngeus. Inferior constrictor, these are like, the oblique fibers which are present. So the orientation of the fibers is such that there could be a weakness that is developing. The question on this topic will always begin by describing a geriatric age group patient, 70-year-old man, and the 70-year-old man is coming with complaints of dysphagia. So initially, because of the old age and dysphagia, you will think it is a malignancy. But then what will be written in the question that will tell you that this is unlikely to be malignancy, which is that he will say that the symptoms of the patient have been persistent for past couple of years and they've not changed. You see, in cancer, the progression of dysphagia is very fast. In 6 months, you get like very severe manifestations and you get a progressive dysphagia. But here it will always be a non-progressive dysphagia. I mean, as compared to last year, the symptoms would almost be same because the size of diverticula, no, last year it was 2 centimeter, this time it became 2.5, maybe 3 centimeter. So if the diverticula will become relatively from 2 to 3, it will not be a significant increase in size to cause a change in the severity of dysphagia. So old man with non-progressive dysphagia. Then because the food will get stuck here, so the standard presentation would be rotting of food, so halitosis, regurgitation of food items which were consumed previously, like this guy had cucumber for like his in salad at lunchtime, that might be coming out in evening. So regurgitation, patient can identify that undigested food item. That's why the word is regurgitation of food items and not vomiting. And then they can be like recurrent pneumonia episodes as well. This can actually be the opening line of the MCQ, because when he will say recurrent episodes of pneumonia in an old man, you will start thinking in terms of curve 65 score. No, I mean, the examiner wants you to think in terms of that bacterial pneumonia or lobar pneumonia that we were discussing in the respiratory section. But then you will realize he's talking about GI aspects by mentioning the non-progressive dysphagia. The investigation of choice for diagnosis of this condition should be answered as a barium swallow. We can do a endoscopy in this condition also. In fact, if he says what is the first investigation to be done in this case, if he says what is he gives this clinical presentation and he says old man comes with dysphagia. In any old person with dysphagia, first investigation is upper GI endoscopy. The endoscopy will not show any cauliflower growth in the esophagus in the middle 1/3 or lower 1/3, wherever. I mean, first investigation is upper GI endoscopy. Once I've done that, then the investigation of choice would be answered, which is barium swallow. In fact, I can say this is one such condition of the GI tract where barium swallow is the answer. 2 times in GI, in upper GI, barium swallow is answer. One with respect to sliding or rolling hernia, that's called as hiatus hernia, and second is the one that I've discussed at the moment, that is Zenker diverticulum. I'll repeat this once again. Barium swallow is answered 2 times in the GI section, upper GI section. One is for hiatus hernia, which is of 2 types, sliding and rolling hernia. I've not written it in the notes here because that is given in your surgery notes. And the second time is for the topic of interest, that is Zenker diverticulum. We can identify this condition with help of endoscopy also, but most of the time the endoscope would be having a front viewing camera. So front viewing camera, we cannot see the diverticula opening. So ideally, if we have a dual viewing camera, like a lateral viewing camera present in the endoscope, then you can. But most endoscopes know if it's a front viewing camera, maybe the view might be such that opening of the diverticula which is present posteriorly can be missed. The investigation choice here is a barium swallow, and then he will talk about surgery. So the indication, I would request you to read about this topic from the surgical domain as well. That is, size more than how much is when you would like to intervene. Obviously, whatever the value the surgeon will say is the one which I would like you to remember. But in my opinion, what I have read is if there are symptoms which are significantly present in a patient, and along with that, like the size of the diverticula is more than 4 centimeters, symptomatic patient with size more than 4 centimeters of the diverticula is the indication for surgery. What is the procedure done? Dolman procedure, which is also called as endoscopic diverticulotomy, and then a Z-poem name to procedure can also be done. That's a percutaneous endoscopic myotomy for this patient. Z means it's done specifically for Zenker diverticulum. It's a per oral, POEM is a per oral endoscopic myotomy. So do read about this procedures from the surgical domain. The most important information that I mentioned is that if we will deliberately mention the origin present as below the cricopharyngeus, then don't answer Killian's triangle. Then the answer would be given as Lymer's triangle, though Killian's happens to be the most common site. So that's point number one, inferior location, Lymer's. Second is old man with dysphagia. First thing in terms of malignancy, till proved otherwise, that is endoscopy report in the patient should be normal. And once the endoscopy report in the patient turns out to be normal, that is when barium swallow will be done. Now I will change the perspective and say that I have even a younger patient, 50 to 60-year-old man, and he's having progressive dysphagia. That is like the symptoms of this patient have deteriorated so severe that now this patient is not able to eat anything. The dysphagia in this particular case would be given more for solids, because you can see this is a cauliflower growth which is occurring in the lumen. This cauliflower growth in the lumen of the esophagus is causing a luminal narrowing. So because of luminal narrowing, like liquid will still be able to pass across the luminal narrowing, but solids will not be. So the question will mention in this case dysphagia more for solids as compared to liquids. When I was describing HLS cardia, it was a young female. She also had progressive dysphagia, but it was more for liquids as compared to solids. Here solids, because you can understand it will, solid food will get retained. Liquid will still be able to navigate its way across. So there would be progressive dysphagia. Then the examiner himself will say significant weight loss. Like this patient was like 6 feet 2 inches. He was 100 plus kgs. And now after like 6 months, the guy is only 50 kgs. 110 kg guy, 6 feet 2 inches is now like 50 kgs. Cachexia would be, emaciated appearance would be present. Cancer, like, it causes very significant weight loss in a patient. So progressive dysphagia with cachexia. Then the next aspect which I want you to remember in this case is that he will waste your time now by, this could be the opening line also, halitosis, because food is getting retained here also. So halitosis, regurgitation of food items, and pneumonia episodes. This is gonna be a standard, dialogue that the examiner can be using in any one of the esophageal disorders. So don't give too much of importance to the same. But yeah, the point here is that there would be no mention of chest pain. That's a feature of diffuse esophageal spasm or type 3 variety in Chicago classification for HLS cardia. He gave this kind of a presentation in the paper, and he said, what is the first investigation that you would like to do in this patient? So as by default, the investigation would be an upper J endoscopy with punch biopsy. This is also the investigation choice for this condition because I need a tissue diagnosis, and this tissue diagnosis will be revealing evidence of squamous cell cancer. You can see a radiological finding which is present here. The radiological finding which is present here is not called as an apple core appearance. It is not called as an apple core appearance. Apple core appearance is said to be present exclusively for colorectal cancer. Here the radiological finding of barium swallow. This is also not a rat tail appearance. It is shouldering sign. Guys, the cancer that is present here is squamous cell cancer of the esophagus. It is usually common in the middle 1/3. You see, in the paper, they deliberately don't give that rat tail appearance that the radiologist or the surgeon will be showing you. If you check out with students, check from students who are sat for the paper, they will say, sir, there was no rat tail image. The classical Wikipedia image, that most people are showing you, that does not come in the paper. This is the image that actually came in the paper. People were searching for the rat tail. I'll just hand draw that rat tail once again. This is what people were expecting, that we'll be given this irregular filling defect that's called as a rat tail appearance. So agreed. Rat tail is a term that can be misinterpreted, misrepresented, and is involvement of the lower 1/3 of the esophagus, whereas the cancer is more common with the middle 1/3. So don't rely on the word middle 1/3, rely either on the word shouldering sign, or if not shouldering sign, the key word is irregular. That's valid for both of them, whether middle 1/3, upper 1/3, or wherever. Your answer would always be given as irregular filling defect. Now, once you get this data right, then subsequently, I would like to mention the next investigation to be done in this patient. That's going to be a CT abdomen, because you know that the cancer can spread. In fact, esophagus lacks serosa. I just want to say that why esophageal cancer has a bad prognosis is because esophagus lacks serosa. So by the time the diagnosis is made, it has already spread to distant organs. So at this moment, if there is any TNM staging that the surgeon has told you, I would request you to basically check for the TNM staging, because the Mets could be occurring to the liver of the patient. The word is CT abdomen can show Mets to the liver of this patient, and then the treatment or choice of this patient would be mainly from the surgical domain. And I can say, like, lots of time we will not be able to do anything. Maybe chemotherapy, that also the patient will refuse because the cancer would have already spread to distant organs, including metastasis to the liver. The main focus was to tell you that if you get a geriatric question with dysphagia described, maybe more for solids as compared to liquids for both age groups, then you have to rely on the following words, which I'm now highlighting: non-progressive dysphagia versus progressive. That's the gist of the question that I want you to understand. And obviously I need a tissue diagnosis finally. So whenever you're suspecting malignancy, or in old age group, whenever there's a dysphagia question given, first investigation is upper GI endoscopy. In the MCQ, punch biopsy word was not written. If that would have been written, then everybody would have answered it. So a lot of guys casually answered barium swallow. Yes, I'll do a barium swallow also, but the barium swallow will not give me a tissue diagnosis. No, first the main investigation should be get the tissue diagnosis. So endoscopy with punch biopsy would be recommended for this particular case. And the speciality of this condition is that the progression is very, very fast. It's like more common in the middle 1/3. The incidence is increasing in the lower 1/3 due to association with Barrett's esophagus. That will come up in the discussion subsequently. Next up, I'll describe a condition where the classical corkscrew appearance is present. This corkscrew appearance is a feature that is seen with diffuse esophageal spasm. So let's look at what will be the case presentation that is given and why does it happen. In fact, I can put that as a question to you. What is the cause of development of diffuse esophageal spasm? The question is in a similar spirit, like I told you, HLHS cardia is autoimmune, it's not idiopathic. Can you tell me the number one cause for diffuse esophageal spasm? Here the answer would be given as idiopathic. It's a idiopathic origin disorder in which what happens is that there is non-peristaltic premature contractions of the esophagus. In diffuse esophageal spasm, you have non-peristaltic premature contractions of the esophagus. Let me just explain this terminology to you. Let me just draw this. This is proximal part of esophagus, middle, lower. So what I'm trying to say is that when there is food in the esophagus, then if one particular part will be contracting, then the distal part will always be relaxing, because that is what we say as peristalsis, and this favors the forward movement of food. Now in this particular condition, what will happen is that the whole of the esophagus is contracting together. Like if you look at the vectors of the arrows that I'm showing here, I'm saying that all the parts of the esophagus are contracting. I've not even shown food. No, but normally in response to food, our intestine will begin to show peristalsis. But here the whole of the esophagus is contracting prematurely, simultaneously. It's a non-peristaltic. Non-peristaltic means, like, in peristalsis, one part contracts, other part relaxes. Here all the parts are contracting together. In fact, the esophagus in this condition may contract so powerfully. Like if this is the wall, the wall has to be given a bit of thickness so that I can come towards the periphery. In our case, when peristalsis is happening, there is no impact on the blood vessels. Like our blood vessels are perfectly okay. But in this condition, what happens is that the esophagus contracts with so much of force that it constricts its own blood supply. Like in dotted, I'm showing that the esophagus is contracting forcefully to the level that it constricts its own blood supply. And that is the reason, that's like primarily the reason why in this particular case, you will read about that the condition is called as esophageal angina. One of the primary reasons why this topic has been asked in the exam is the term chest pain that is described. The question began by saying, what is the cause of esophageal angina? Your answer is idiopathic. The esophagus is exhibiting a non-peristaltic contractions. There is no food present. All part of the esophagus contracting together. The lower part of the sphincter relaxation is okay. But then here the problem is that non-peristaltic premature contractions. Then we have a more severe variant of this condition. The more severe variant of this condition is called as jackhammer esophagus, where there is like even higher amplitude, prolonged peristaltic contractions on high resolution manometry. So one message is that the investigational choice for this condition, though it is written here, I'll still like to mention HR stands for high resolution esophageal manometry. So 2 times you can see in this disorder or in discussion of the esophagus, high resolution esophageal manometry has come as the investigational choice. The first time this came as investigational choice was for HLHS cardia, and the second one is for the topic of interest. There's no definitive treatment. We start first these patients on anxiolytis, because a lot of these patients would be thinking that they're having cardiac disease and the doctor is not able to diagnose the cardiac disease. He's blaming it on the esophagus. Think from a non-perspective perspective. If somebody is having chest pain episodes on a recurrent basis, ECG is normal, treadmill test is normal, cardiac echo is normal. So like the cardiologist is saying there's no cardiac cause, but patient is not believing us. No, he's thinking that we are maybe missing the diagnosis and I'm having a cardiac disease because of the severity of chest pain present here. It's intermittent chest pain at rest that is present. But once the cardiac tests are normal, then when you do a high resolution esophageal manometry HRM, that's when you are able to demonstrate either of the two, either like non-peristaltic premature contractions or high amplitude contractions, which is why it is called as a jackhammer esophagus. So give anxiolytics, give nitrates. Nitrates will relax the esophagus. You will also give calcium channel blockers for these patients. CCB that can be used is like amlodipine, because that is usually not talked, so I'm not writing it. But yeah, just for the sake of completion, anxiolytics, then nitrates like isosorbate mononitrate, and then nitroglycerin can be used. Nitroglycerin like is short acting, no? So my point is like if I give NTG, then the effect of nitroglycerin will go away very fast and it also causes hypotension. So I would like to use a long acting nitrate, that is isosorbate mononitrate. Don't answer nitroglycerin for the chest pain of this condition. Cardiac origin chest pain, answer nitroglycerin chalega. But for diffuse esophageal spasm, no rule of like nitroglycerin, or even if you give it once in a while, it will have side effects, no, hypotension, headache, that you will be saying, nahi baba, ab nahi use karna. So isosorbate mononitrate would be given, and along with that calcium channel blockers. But this is not the treatment of choice. So there's no treatment available for this condition by the name of DES, that is diffuse esophageal spasm. The condition that I've described, HLIS cardia, happens to be a pre-malignant condition, and because it is autoimmune, that is why we'll begin with a young female exhibiting progressive dysphagia. Now the next question that I'll discuss before you is a colic patient with multiple episodes of vomiting and retching and this chest pain also. So the questions said what is the first differential diagnosis? X-ray is also given, and the moment you read this question, alcoholic, vomiting, retching, the first thought process is it can be malarious, but then malarious will always be having vomiting of blood, that is hematemesis, whereas when you read the stem of the question there is chest pain but there is no mention of any hematemesis or vomiting of blood. As far as bleeding esophageal varices is concerned, bleeding esophageal varices will not contribute to like chest pain manifestations. Chest pain is again something which is going again bleeding esophageal varices. Then varices will always cause hypotension. So there's no crashing of blood pressure also. So by exclusion, the answer is obviously B, that you would have guessed at this point of time, that is Boerhaave syndrome, because what we are trying to identify in this condition of Boerhaave syndrome is a triad. The triad that we use for diagnosis of this condition is called as Macular's triad. Macular's triad will be having the following things present. So let me just enumerate them. The first is obviously that there is vomiting, there is retching, like he's trying to puke, it's a forceful vomiting. So the sound that comes with forceful vomiting is called as retching. So vomiting with retching is obviously the trigger. Now there would be a development of chest pain in this patient. The reason for chest pain is pneumomediastinitis, because now when the esophagus will burst, then maybe the saliva or the alcohol that he had consumed, chicken that he had consumed, that would be coming into the chest wall of the patient. So the reason why there is chest pain in these patients is chemical mediastinitis. And the third manifestation that is seen in this patient is evidence of pneumomediastinum. In this question, the pneumomediastinum evidence that is given is the X-ray finding that I'll just write before you. In some questions, to make it easy for you, he may not give you an X-ray, but may mention a finding of pneumomediastinum, that is subcutaneous emphysema. Last time I spoke about subcutaneous emphysema was when I described pneumothorax in the respiratory system. I said that there could be air leak and the air of the lungs can dissect into the muscles of the chest and you can get crepitus under the skin. But today the air is not coming from any damage to the lung. It is rather subcutaneous emphysema, not due to pneumothorax, but due to pneumomediastinum in this patient. What I'm trying to say is that in Boerhaave syndrome, what will happen is that there would be a rupture of the esophagus. Because of the rupture of the esophagus, the air of the esophagus will now come into the mediastinum. So that's why the term is pneumomediastinum. How will the examiner give you pneumomediastinum? Two ways. One, he can give an X-ray chest and you can see the air which is present just below the heart of the patient. So the radiological finding which has been shown here and is being emphasized to you is called as continuous diaphragm sign. If you read a question that says X-ray chest shows continuous diaphragm sign, cool, that's a feature of pneumomediastinum. The second thing that could be present is crepitus under the skin, which is a palpatory finding with respect to subcutaneous emphysema. I wanted to save some space, so I wrote the word subcutaneous emphysema. Whether I say the word subcutaneous emphysema, crepitus under the skin, they both basically mean the same. So since macular striatum is present here, that's why the answer is Boerhaave. And Boerhaave as a condition will be causing involvement of usually the lower part of the esophagus. It's the lower part of the esophagus that will give away here, and the rupture will cause air to come into the mediastinum. That's pneumomediastinum. At this moment, I also want to bring to your attention that Boerhaave syndrome can be seen with respect to instrumentation. Though it has become less rare nowadays, but if endoscopy is being done and patient is not sedated properly, the gag reflex could actually contribute to, like when you're putting the endoscope, it could perforate the esophagus. It could cause a complete like through and through rupture of the esophagus. If instrumentation is the cause, then the distance from the incisor teeth will be something like about 22.5 centimeter, where the esophagus tends to constrict at the cricopharyngeus. So if he mentions the word Boerhaave syndrome and he says which is the part of the esophagus that is involved during instrumentation, if Boerhaave syndrome is developing, then your answer is it's a cervical esophagus perforation. But if it is going to be related to vomiting, then it would be the lower 1/3 of the esophagus that would be involved in this case. I repeat this again. In Boerhaave syndrome, it's the lower 1/3 of the esophagus that is involved that will give away in traditional cases where it's like alcoholic with vomiting. But if it's instrumentation, it is cervical esophagus that would be involved. So let's just do a quick recap of Boerhaave syndrome so that we can remember the core issues for this one. The first point to be remembered for Boerhaave is what is the investigational choice for diagnosis of this condition. Obviously, I will be doing a CT chest. The question is open for you guys. Would you like to do a CT chest with contrast or without contrast? Obviously, I cannot give barium swallow in this patient because there would be contrast going in the mediastinum that will cause chemical mediastinitis worsening. So I need to I cannot give oral contrast to the patient from the barium perspective, but I can be using gastrogafin, that is water soluble contrast. So yes, we do give oral contrast in this patient. The only message is that it should be a water soluble contrast and contrast like barium. So investigation choice for this condition is CT chest with oral contrast. Had I not specified the word water soluble, then the query of most people is that doctor, you are giving oral contrast, it will spill over into the mediastinum, it will worsen the chemical mediastinitis. Agreed. I mean, I'm not using barium, I can use gastrogafin in this condition. So that's the investigational choice. As far as Boerhaave syndrome is concerned, the second thing that you need to remember is the site. Between the sites which are already mentioned, but still for practice sake, your answer would be either lower 1/3 of the esophagus, which is more common. If nothing is given in the question, just answer it as lower 1/3 of the esophagus posteriorly. Otherwise, answer it as cervical esophagus, but that's obviously explained to you with respect to instrumentation. Endoscopy was being done by a resident PGT1, not very skilled enough. Patient's throat was not anesthetized properly, propofol was not given, and the patient was being done without any kind of proper preparation. So cervical esophagus damage can be seen with instrumentation. As far as the diagnostic criteria for this condition are concerned, the triad that we discussed is called as macular striate. Let's do a 15-second recap of it. Macular striate would be having three things: vomiting. Then after vomiting, there would be a development of subcutaneous emphysema, that is crepitus under the skin, and there would be chest pain that would be involved. And then he has asked, what is the treatment? You guys can tell me, since this topic is covered in surgery, what will you do? So your answer would be that we will be doing an emergency thoracotomy. The chest will be opened and esophageal repair needs to be done, because otherwise there would be a continuous leak of saliva into the mediastinal cavity. So thoracotomy with emergency repair of the esophagus needs to be done. The question for you guys is, thoracotomy will be done from which side, left side or the right side? I'm just writing emergency, thoracotomy in emergency would be done. And our objective here is to ensure that the chemical mediastinitis part does not worsen. In fact, in these questions, pneumomediastinum is present. So even that Hammond-Krantz sign as an auscultatory finding can be present. I just said it verbally. The Hammond-Krantz sign and pneumomediastinum finding is discussed in the respiratory section with pneumothorax. So I put it to you guys once again, guys. We are doing a thoracotomy in this patient, emergency thoracotomy. That is understandable. But from which side it would be done, that is from the left or the right. So we can do it from left also, but then on the left, the arch of aorta would be present, blood vessels related to aorta would be present. So right thoracotomy, though this is a surgical topic, I invested time into this just to sensitize you to the fact that for him, it's not like medicine versus surgery. That's what we create in our mind. In Boyerhoff syndrome, it would be a right thoracotomy that would be required. At this moment, I also want to bring to your attention that if he begins by saying alcoholic is having vomiting of blood, then what are the things that you need to check out in a question are as follows. If the BP of the patient is stable, the pulse rate of the patient is perfectly normal, and he says that the alcoholic patient had vomiting after binge drinking, then we will think in terms of a Mallory-Weiss. Mallory-Weiss is actually a submucosal tear. It is not a perforation. Mallory-Weiss syndrome is a submucosal tear. While I've written the word submucosal tear, I said hemodynamic stability will be present in the patient. Leave a line if you're noting it in a register with me, though a lot of you would be having printed notes, but nowadays, like, the printed notes take the zing out of it. It's literally like trying to take the sting out of like whatever you should be learning, because then everything is in front of you, so the data does not evolve, right? Alcoholic with hematemesis, if it's a crashing patient, or if he mentions the word hemodynamic instability, BP less than 90/60, or on examination he says splenomegaly, or he says the word caput medusae, then you understand that portal hypertension is present, and in those circumstances the answer would be given as like bleeding esophageal varices. Guys, while noting this data, my suggestion to you guys is that keep a line in between, because I can add some filler in details at the moment. Hemodynamic instability is always a feature of bleeding varices, whereas Mallory-Weiss is a submucosal tear, though the source of bleeding here. If he says in Mallory-Weiss syndrome, where is the source of bleeding? The answer is left gastric artery. So the query that I get from lot of students is, कि sir, artery se bleeding ho raha hai, then why is the BP being maintained? Because the bleeding is not occurring from the main stem of the artery, it is from the superficial branches. Like in peptic ulcer disease, in hematochezia, when I described like peptic ulcer right in the beginning of this video, I had said that the person was having unrecordable BP, and that is like the main stem of the artery, gastroduodenal artery, that is bleeding. I repeat that again. If a guy is puking blood and the blood is coming from the first part of the duodenum, it would be gastroduodenal artery. Gastroduodenal artery can cause hematemesis, vomiting of blood. It can cause hematochezia, that is like a fresh, it would be like bright red blood present in the stool of the patient. The message is duodenal ulcer can cause a upper GI bleeding and can also cause a hematochezia with hemodynamic instability. That's the point. Hemodynamic instability in peptic ulcer disease. But in Mallory-Weiss syndrome, there is no hemodynamic instability. It is a self-limiting condition. It is the bleeding from the superficial branches that would be occurring. Can you tell me the site of Mallory-Weiss syndrome? Where is the tear located? You want me to give options? Okay, pylorus, lower esophageal sphincter, esophagus. Where is the tear present? Where is that submucosal tear present? Yes, the tear is present in the lower esophageal sphincter under surface. Actually, when I say the word vomiting, the vomiting will result in development of alcoholic with hematemesis, vomiting of blood. The vomiting will cause development of reverse peristalsis. So the tear starts from the cardia and involves the lower esophageal sphincter. But when you do endoscopy, you will first access the lower esophageal sphincter. When you do endoscopy, you will first access the lower esophageal sphincter. So the message at the moment is that if he specifically mentions the word that what is the site of bleeding in this particular case, then your answer would be given as lower esophageal sphincter starting from the cardia. If the BP is unrecordable, then yep, that's gonna be bleeding esophageal varices. If he says what is the source here for bleeding esophageal varices, though I'll touch upon this later also, but at the moment in bleeding esophageal varices, the source from the perspective, like the primary source would be answered as left gastric vein. I will be describing like the porto and the systemic, because it's a portosystemic collateral. So I tell you the portal source and the systemic source, both are asked individually, but the single best answer would be that it is the left gastric vein that would be bleeding, and due to increased pressure in the portal vein, the pressure is transmitted via the azygos vein to the left gastric vein, and that results in like the congestion, and therefore the vein will burst. The hints in the question can be splenomegaly, caput medusae, or unrecordable blood pressure. So just like in arrhythmias, I was saying check out the blood pressure. Similarly, in alcoholic with hematemesis, check out the blood pressure before you mention the word Mallory-Weiss versus bleeding esophageal varices. In fact, I would rate this as the more important information than any of the information for diseases of the esophagus that I mentioned before you, because this would be a critically sick patient. So, I mean, hemodynamic stability will straight away tell you it can't be peptic ulcer. I said initially, no, I mean, peptic ulcer can be present in alcoholic also. So your answer would be malarious. If he's giving hemodynamic instability, don't assume even then that it is, it's bleeding varices. Even then it can be peptic ulcer. H. pylori can be present in alcoholic also. So what you should look next in the question is these findings like splenomegaly, because in H. pylori infection, obviously there would be no splenomegaly, no caput medusae that is given. So I repeat my statement, guys, so that I can emphasize this information. Alcoholic with hematemesis can be due to peptic ulcer also. Due to peptic ulcer also, the blood pressure of the patient will crash, but there's no splenomegaly, no caput medusae that is given. But if you get hypotension, splenomegaly, caput medusae, then it is evolving towards portal hypertension. The source of bleeding is the left gastric vein. These are like overlap from surgery, guys, but in the exam for them, it's not like medicine versus surgery. They just give you a case. So a lot of the data that I've said, like macular striate, may be a repetition for you from the surgical domain, but it is worth this effort, because I said right in the beginning, all that matters is the strike rate. Also, you saw that the word crepitus under the skin, that is subcutaneous emphysema, was repeated. I first time said subcutaneous emphysema when I was describing pneumothorax to you. But today, even in subcutaneous, even with respect to pneumomediastinum, this was described. And radiological finding additional came up, continuous diaphragm signs. So the ones in yellow that I've highlighted are like the must know non-negotiable facts that you have to remember. I mean, there's no excuse if I miss up words like continuous diaphragm sign, macular striate, or like the use of water soluble contrast for evaluation of Boyraf syndrome. And overall, the most important information that I've said is this blue box that I mentioned right in the beginning, with stability hemodynamically and hemodynamic instability. The next x-rays that I'm showing at the moment before you are very straightforward cliche diagnosis that have to be remembered. This would again be a repetition from surgery, but still worth the effort. What you can notice here is the presence of gas under the diaphragm. This gas under the diaphragm can also be written in MCQs as Moustache sign, or it can be written also as cupola sign. Irrespective of the terminologies, whether you say gas under diaphragm, Moustache sign, cupola sign, they all indicate pneumoperitoneum in this patient. The second aspect which I want to draw your attention is that why is all this happening? Like he gave this x-ray and he said what is the reason? So the reason would be a peptic ulcer disease, mostly in the first part of the duodenum, which can not only cause bleeding but can cause a pneumoperitoneum occurring in a patient. So the technical word that was given in the recent exam was the word viscous perforation. The message is viscous perforation is occurring because of duodenal ulcer. Most of the time, the duodenal ulcer that would be present here will be anteriorly located. The posterior location of the duodenal ulcer usually causes bleeding because that's where the gastroduodenal artery is present. But the anterior location of the duodenal ulcer will result in pneumoperitoneum to develop in this patient. In one of the previous exams, what was asked was what will the surgeon be doing for management of this person? So because the number one causes duodenal ulcer in an anterior location, what they will be doing is one exploratory laparotomy. But after exploratory laparotomy and washing the peritoneal cavity with saline and removing all the acid that is spilled over, they will be putting a omental patch. That omental patch is what is called as Graham's patch. So do read about this topic from surgery as well. That is pneumoperitoneum is what I have currently explained to you from the radiological perspective. At this moment, assuming that you have done respiratory system, there are three pneumos that I want you to be very, very thorough with: pneumothorax, pneumomediastinum, and pneumoperitoneum. The pneumomediastinum X-ray will once again come up in the discussion. That is where the air was present at the lower border of the heart. So the word was continuous diaphragm sign. But now for the pneumomediastinum perspective, after pneumomediastinum, the pneumoperitoneum perspective, it's gonna be gas under the diaphragm, also called as Moustache sign, and we have to put a Graham's patch to take care of the perforation that has occurred. The next X-ray that I'm showing before you is showing these dilated bubble loops right in the middle. So the diagnosis becomes very easy. That is small bubble obstruction, even if I don't give the history. But yes, I mean, the history most of the time can be given. Like he can say that this person is having development of severe colicky abdominal pain. I mean, colicky abdominal pain because intestine is trying to overcome the obstruction. So it will contract with more force and will constrict its own blood supply. So that is why the description of colicky abdominal pain in this case can be given. Along with colicky abdominal pain, he may even mention bilious vomiting. That is again a pointer towards small bowel obstruction in a patient. And the X-ray of this patient is showing presence of multiple air fluid levels. Instead of saying the word multiple air fluid levels, I can say dilated bowel loops present. I mean, with respect to the central part, so multiple air fluid levels, dilated bowel loops are shown in the central part. The clinical diagnosis is small bowel obstruction. It will be a two-step question. He will say, why is this happening? So that's the main point why you should be, remembering this acute abdomen scenarios that I'm describing before you. This is colicky abdominal pain. Patient is tossing and turning in the bed. In peptic ulcer disease, if there is gonna be like the perforation that I was describing, the pain will be causing extreme guarding rigidity of the anterabdominal wall. Patient will lie still. He will not even turn, because if he will turn, the acid will spill over in the peritoneal cavity. But in this case, the patient is gonna lie still. In this particular case of peritonitis, person will lie still. In small bowel obstruction, he will toss and turn in the bed. The colicky abdominal pain. Yes, guys, I've given sufficient time. Why is this happening? The number one cause of intestinal obstruction, can be adhesions or it can be congenital bands. Either it is adhesions or it can be congenital bands. Then comes the issue of large bowel obstruction, because you can see hostorations present here. Like you can see the bade hostration. So this is LBO. The question will usually begin by describing like an old person. Like this is a 60-year-old man. He's come to the hospital with what are the complaints? It would be gross abdominal distension and obstipation. Obstipation means that there would be no passage of any gas or flatness by the patient. So abdominal distension, obstipation are the presentations of LBO. Even in this condition, multiple air fluid levels can be seen. I'll just rephrase the statement. Both for SBO as well as for LBO, it is multiple air fluid levels that can be seen. The same thing is present here also. But as I explained to you, the orientation is also telling you the sigmoid colon is forming a loop like this. So multiple large bowel loops are present. Or instead of writing the word multiple air fluid levels, he may himself mention the word hostorations of the large bowel are visible. Now the question arises, why is this happening? Why an old man is developing a large bowel obstruction? There looks to be abrupt cutoff here also. So the probable reasons could be manifold, but one of them could be colorectal cancer or a malignancy. This can contribute to like a physical obstruction that can explain the initial symptoms of this patient. He might be having constipation, and now that constipation has worsened to the level that there's abdominal distension and obstipation occurring in a patient. Obviously, apart from colorectal cancer, there could be one more cause which you can pick up from this coffee bean appearance that I've shown before you. This coffee bean appearance is a characteristic feature that is seen with the sigmoid volvulus. It is also called as a bent inner tube sign. And if we do a barium enema in this patient, it will be showing that bird beak appearance. You can see the bird beak appearance coming up for second time in the discussion. Bird beak appearance was mentioned for barium swallow with respect to HLSJ cardia. But if I change the question to bird beak appearance on barium enema, then my answer will change over to sigmoid volvulus. And this sigmoid volvulus can also be a reason behind development of a large bowel obstruction in a patient. So now you are aware of two causes of small bowel obstruction and two causes of large bowel obstruction. Small is adhesions or congenital bands, and like large bowel obstruction can be colorectal cancer or can be sigmoid volvulus. Here also the question will mention colicky pain, obstipation, abdominal distension, tympanitic note on the abdomen. But then he will start saying couple of things which are like very characteristic. That is empty rectum on upper rectal examination, visible peristalsis. You will read visible peristalsis also in that pediatric MCQ, idiopathic hypertrophic pyloric stenosis. Today also in sigmoid volvulus, I have mentioned the word visible peristalsis. The colon is rotated on its own axis. In sigmoid volvulus, the rotation is usually anti-clockwise. Remember, in cecal volvulus, C for cecum, it is clockwise rotation, but in sigmoid volvulus, it will always be a anti-clockwise rotation of the sigmoid colon that is happening. The best way for diagnosis of this condition is a CT abdomen in all abdominal emergencies. Though conventionally we start with an X-ray, but he says best investigation is always a CT abdomen. The CT abdomen will be showing a Wurl sign. Wurl sign would mean that there's a twisted mesentery that is happening. So you have to read about this from even the surgical domain. And that X-ray abdomen finding of coffee bean appearance lots of time may not be given in the question. that barium enema fending or bird beak appearance may not be given in question. So these are isolated image-based questions that I've covered on the topic of sigmoid volvulus. Make it a habit to solve the question of sigmoid volvulus without coffee bean help and without a bird beak appearance. A lot of guys are so like addicted to the word coffee that they are not able to answer this in the exam. So I have said the words are empty rectum on upper rectal examination, and then is visible peristalsis, plus if there can be perforation, because if it will rotate on its axis, it will compress its own blood supply. So complications can occur with respect to the gangrene part of the gut can happen. Insufficiency of the blood vascularity can predispose to development of a perforation also. So the first step for management is endoscopic detorsion with the sigmoidoscopy. That is what they recommend. But otherwise, if the detorsion is not possible, then a sigmoid colectomy with a primary anastomosis would be required. In unstable patients, obviously Hartmann's procedure, so that you would be knowing from surgery. But I wanted you to be able to pick up the Wurl sign, the visible peristalsis, empty rectum on peer examination for sigmoid volvulus. This entire slide I can say is covered in surgery also, but there it will be like maybe 1 hour because they have to tell so many other domains. What I've done is compiled the data together: pneumoperitoneum, small bowel obstruction, large bowel obstruction, sigmoid volvulus. Guys, if you are an FMG student, each one of these is a question which line to line will come. Even the surgeon would have talked about it and beautifully talked about it. I mean, I can't take credit. They'll obviously talk about abdominal emergencies better than I do. I can diagnose, but they are the ones who are handling it. But there the time frame is more. So my bits that I've said, my suggestion would be that whenever you are doing GI, first read from surgery, then read the medicine part. If you have come directly here, then you might be having a problem, guys. If you're having a problem, that means that this is not a cool subtopic. Then it means it needs to be worked upon. GI max focus is from the surgical domain. 90% is surgical domain, 10% is the medical domain. I've tried to amalgate the two so that if you are having paucity of time, if you are having less time, that at least you are able to get those questions correct. But yeah, if you want to improve your strike rate further, if you listen to the surgeon after this, or if you have listened to him before me, then this will be making much more sense to you. Now we will talk about pre-malignant conditions of the GI tract. One of the pre-malignant conditions, an important one to be remembered, is Peutz-Jeghers syndrome. In Peutz-Jeghers syndrome, you can see the mucosal melanosis, and you can also see this I would say connective tissue strand which is present or distributed in the entire. This is like connective tissue support that is present in the polyp present in the small intestine of this patient, that is in the bowel. So most of the time, like the radiologist will basically focus on the polyps which are present in the hamartomatous polyps which are present in the jejunum of the patient while we are doing an endoscopy. But the pathologist will always talk about arborizing pattern on the polyps. I'll repeat that statement. One is obviously the radiologist will be saying that I want to check for the hamartomatous polyps. Hamartomatous polyps means that there is a lot of connective tissue present. Normally polyps are all about increased surface area. Increased surface area means that there can be a neoplasia developing there. But in this condition, there is a arborizing pattern on the polyps present. That's because of the connective tissue that is present, and that's why the word is hamartomatous polyps with this mucocutaneous pigmentation. In fact, a lot of these questions will begin by saying what is the mutation, that is STK11 on chromosome 19. The pattern of inheritance is autosomal dominant, and there would be like these dark brown macules on the lips, on the oral mucosa, and the perioral skin of the patient. At this moment, I want to say that these would be macules, so they'll be relatively smaller. Don't mistake it or confuse it with the hyperpigmentation that is seen on the tongue of a patient or the gingiva of a patient of Addison disease. That's like big black patches seen on the tongue, on the gingiva. This is like much more smaller on the just above the vermilion border of the lip or on the lip per se. So these are macules, and these would be present even on the, oral mucosa, perioral skin, and sometimes even the perianal area, perianal skin as well. Those are the sites for the mucocutaneous pigmentation. It may fade with age except the oral ones, and then is the core issue, polyps. Polyps means increased surface area, therefore neoplasia can develop. The most common site of polyps here is the intestine, that is jejunum, more than as compared to the ileum. This is again peculiar because normally we read about polyps in the large intestine, that's called as familial adenomatous polyposis. Those polyps do not have any connective tissue, but here because connective tissue is present, therefore the word that I highlighted was initially verbally, that is hamartomatous polyps, or the histopathological finding that was arborizing pattern of connective tissue distributed in the entire polyps per se. Because of these polyps, manifestations of diarrhea can be present and they can be intussusception as well. It can act as a lead point for intussusception. The arborizing pattern I've already highlighted. And then the question came as like cancer of which part of the GI tract is substantially increased. So the peculiarity of this condition is that the polyp is in the jejunum, but we are not getting a jejunal adenocarcinoma. I said polyps are in the jejunum, but we are not getting a jejunal adenocarcinoma. We are getting in this patient rather presentation of pancreatic cancer. So it's like hepatobiliary cancers which are relatively increased in this patient, especially like pancreatic cancers, colorectal cancer, and then even like small bowel cancer can be increased. Even breast cancer incidence is increased. You see all the things that I've said: gene mutation, autosomal dominant, and arborizing pattern you know from pathology. What I wanted to say was, when you read this pigmentation, then don't think only that this could be Peutz Jeghers. It can be Addison disease also. Addison disease will also have mucocutaneous pigmentation, but there it would be like salt wasting, hypotension that would be described. So I mean, keep your minds open if he mentions the word hemodynamic instability, salt wasting, salt craving kind of things with mucocutaneous pigmentation. Second, the presentation of polyps could be in the form of diarrhea or malabsorption in a person. If the number of polyps is very extensive, it can contribute to diarrhea as a presentation in a person. And there would be no steatorrhea. No steatorrhea, I said malabsorption like presentation. I did not say it will cause malabsorption. So please be like remembering, it's not malabsorption syndrome. It is malabsorption like presentation in the form of diarrhea. The polyps can be involving the stomach and the colon and can act as a lead point contributing to intussusception. And the last point is that the polyps are in the small bowel. I went into this again to sensitize. Where is the disease present? Small bowel, small bowel, small bowel. Where is the cancer present? Not in the small bowel. It can involve, obviously, it can occur in the small bowel, chalega, but then the risk is highest where you can see the risk is max in the pancreatic. That's what he wants to hear, that the cancer is occurring in the pancreas. So it's like, the perspective is disease is present and the cancer developing are not matching, unlike in familial adenomatous polyposis. If I talk about familial adenomatous polyposis, it is APC gene on chromosome 5, and there the cancer will be increased in the colon itself. Familial adenomatous polyposis increases the risk of colonic cancer. It is colorectal cancer or colon cancer in incidence that would be substantially increased. Like this young guy who came to me, he's told me that his father died of colon cancer at 55 years of age. Because this condition is having again because it is genetically oriented, so his son can also be having colon cancer in future. So in this patient of familial adenomatous polyposis, where I'm already having a positive family history, increased colorectal cancer risk and positive family history is present, I decided to do colonoscopy of this person. When I did colonoscopy, there were more than 100 polyps in the colon. This itself is a diagnostic criteria for this condition. Person's father died of colon cancer. Colorectal cancer in this patient is more. So you did a colonoscopy. Colonoscopy in this condition reveals more than 100 polyps. That means that any one of them can turn malignant in future. So I told this guy that I would suggest you to go for a prophylactic colectomy. He said, wait a minute. What are you saying? You are saying, doctor, that you will remove my colon. Then how will I ever go to the washroom? You mean I will never go to washroom to defecate? And how will the fecal matter be passed out? So I said, we'll do a ileostomy. We'll attach a bag to your tummy. He says, are you crazy, doctor? Are you mad? You're telling me that I will be passing fecal matter from my abdominal wall and you'll put on a bag. What about the smell? What about the quality of life? This is a young 25-year-old guy with whole life ahead of him, and I suggested him a prophylactic colectomy. He says, doctor, you are being like super aggressive about like a cancer that will develop at 60 years in me. I said, sir, in you the cancer can develop at a younger age. These patients should be subjected to a prophylactic colectomy by 30 years of age. In fact, some guidelines mention by 25 years of age. What I want to say is that earlier, if we do a prophylactic colectomy, because there are 100 polyps now, how can we monitor each one of them? You can't do a colonoscopy every single day in a patient. So the message here is prophylactic colectomy by 30 years of age should be done in familial adenomatous polyposis. Then is an association, Gardner syndrome. Gardner is like a person who's working in the field, so hands will become hard. So because the hands are hard, I want to draw attention to like tumors which will be very hard here, like desmoid tumor, bony osteoma, and fibromas. These are like hard inconsistencies. So Gardner. In Turcot syndrome, the word C is present. Turcot, C alphabet tells you there are malignant CNS tumors like medulloblastoma present here. So familial adenomatous polyposis is asked not only for the increased risk of colon cancer in these patients and a prophylactic colectomy, but he can ask about Gardner and Turcot. I'll just move up the slide. When it comes to Gardner syndrome in a patient, it was hard tumors. Terms were osteomas, desmoid tumors. And when I spoke about Turcot, then Turcot was having a C, that is a CNS tumors like medulloblastoma association. Similarly, for Peutz-Jeghers syndrome, the highlight is increased risk of pancreatic cancer in this patient. So all of these are pre-malignant conditions, including Barrett's esophagus, where another city, formerly Czechoslovakia's capital, Prague, is coming in. So I described about like I said Vienna, Austria's capital, right? Vienna for ulcerative colitis and Crohn's extensive disease. Then I spoke about Chicago classification for patients of HLHS cardia. Now Prague classification for Barrett's esophagus to check for the extent and the extent and the circumferential spread of this Barrett's esophagus. It would be having these finger-like projections. Barrett's esophagus tends to have these finger-like projections into the esophageal mucosa because this is related to GERD. Acid will be going up, so long-standing GERD can cause Barrett's esophagus. And if you look at this image, it is very classical that in the esophagus normally we have squamous cell cancer, but here you can see intestinal glands that are coming. So on one side you can obviously see the squamous epithelium. I'll use a finer font here. You can see the squamous epithelium, but along with the squamous, you can also notice the columnar metaplasia that is happening here. So that squamous to columnar epithelial metaplasia is what is represented in this image. How do I know it is columnar epithelium? You can see so many glands, you can see so many goblet cells which are present. So considering that there are goblet cells and there is glands present, so it's a squamous to columnar metaplasia which is occurring. That is what they usually ask. What kind of metaplasia would be seen? Pretty straightforward. It is squamous to columnar. Meaning of the word metaplasia is the change in the epithelium. The original epithelium was squamous. It is changing to columnar, and then there is an increased risk of cancer. He has also asked what is the investigation of choice for Barrett's esophagus. Your answer would be I'll do an upper GI endoscopy, and after that I'll be doing a punch biopsy from multiple sites to identify Barrett's esophagus, and if required then maybe surgical. We might have to go for surgery in these patients, since if it's pre-malignant and it turns out to be a malignancy, then we will have to resect that part of the esophagus and then to do an anastomosis. At this moment, additional point that would come to your attention is a condition GERD can contribute to obviously that heartburn sensation in a patient. That's obviously very classical, but that in GERD when the acid will go up, it can also go up to the trachea. It can irritate the trachea, it can irritate the vocal cords. So don't be surprised if the patient of heartburn who keeps on taking PPI, he also mentions about recurrent episodes of sore throat. That's because of chemical laryngitis that can be occurring in this patient. Then these patients would be having nocturnal cough, because if the acid micro drop of it will irritate the vocal cords, then there would be like the irritation of vocal cords would contribute to sore throat, and some acid can go down into the trachea. So chemical tracheitis can cause nocturnal cough. Like the mother of this person is telling him that, why do you cough so much at night? Why don't you go and show a doctor? I said chemical laryngitis can be there. There can be chemical tracheitis in this patient. Then the acid can come in the mouth, so that can contribute to damage to the teeth. So dental caries is more extensive. Dental caries is more extensive in patients of GERD. Acid, when it comes in contact with the tooth dentine enamel, it will destroy it. So dental caries manifestation can be present. Then even, they can be damage to lungs, no? There can be chemical pneumonitis occurring in this patient. Due to this chemical pneumonitis, the manifestations can be that of ARDS, acute respiratory distress syndrome, and in the long run, there would be pulmonary fibrosis happening. So I wanted to bring to your attention extra-intestinal manifestations of GERD. The extraintestinal manifestations of GERD can be chemical laryngitis, chemical tracheitis, chemical pneumonitis in a patient, and then it can be even dental caries that is occurring with respect to GERD. The investigational choice for diagnosis of this condition is to be performed as upper GI endoscopy, as already explained to you. But if he says what is the gold standard investigation to be done for gastroesophageal reflux disease, then your answer would be given as 24-hour pH monitoring. On 24-hour pH monitoring, the pH in the esophagus should be less than how much for how many hours, that you will say GRD. Then 24-hour pH monitoring, if it shows presence of pH less than 4, pH of less than 4 for more than 4 hours in every 24 hours, that means that the person is having gastroesophageal reflux disease. So remember, the gold standard investigation is 24-hour pH monitoring, but not the investigational choice, which happens to be an upper GI endoscopy. And for management of these patients, we'll anyway be using proton pump inhibitors, and we also need to evaluate them for the risk of hiatus hernia, that is sliding and rolling hernia. If that is present, then surgical correction would be required. Otherwise, Barrett's esophagus, as you can see here, involved by Prague classification, implies that they could be extent of metaplasia, and that could result in dysplasia, and then of adenocarcinoma of the lower 1/3 of the esophagus can develop in these patients. Next on the agenda is the topic of GIST, that is gastrointestinal stromal tumor. This is a non-epithelial tumor of the stomach. The origin cell in this case is the pacemaker cell of the intestine. You are all aware that the pacemaker of the heart is the SA node, pacemaker of the respiratory system is the pre-Butzinger complex in the medulla, but this time we're talking about interstitial cell of Kegel. Then he is asked what is the mutation involved? So it is c-KIT gene on chromosome number 4 that is involved. The immunohistochemical marker is CD117, and second is DOG1 also. DOG1 is a special terminology because this was documented first time on gastrointestinal stromal tumor. DOG is documented on GIST. So that's why the name is DOG1. The usual presentation is incidental detection only, but then from the symptoms perspective, the stromal tumor, when it grows, it can cause GI bleeding in the form of hematemesis, or it can present as melena. The investigational choice for this condition is a CT abdomen. We don't do an endoscopic biopsy because of the risk of spillover of the tumor. So CT contrast enhanced CT scan is sufficient for identification. And as far as the treatment of choice for this condition is concerned, if it is a localized tumor as determined on a CECT, then the treatment of choice is a surgical resection of the tumor. But if he says that it's a malignant tumor, it's already spread to the liver, then it is imatinib. Here I want to draw your attention that a lot of students in the paper inverted the data, and that's the main reason why we're discussing it, that they answered imatinib mesylate for management of localized tumor. Localized tumor is surgical resection only. Only if it will spread, that imatinib mesylate would be given. So tyrosine kinase inhibitors are used for management of this condition, the same drugs that we use in chronic myeloid leukemia, but the point is this time it is being used for malignant tumor. And TKI resistance sunitinib, and prognostic marker is standard tumor size and mitotic activity. Now, this is a rare cause for development of lower GI bleeding, but yes, this is a non-epithelial. Normally, it is epithelial cell tumor like adenocarcinoma of the stomach, which could be related to even Helicobacter pylori. But here I've described a non-epithelial tumor of the stomach with incidental detection being like most common. Endoscopy was done for some different reason, and there was a protuberance in the wall of the stomach that subsequently turned out to be GIST, or it could erode and could cause local damage to blood vessels, causing a GI bleeding. Now, as far as carcinoid tumor is concerned, the most common location of carcinoid tumor is a bit of a controversy. The surgeon will here say it is appendix, whereas most books say, medicine books say, that overall the most common site is bronchus. Yes, guys, it is like in the gut. It is ileum, rectum and appendix. But overall, if he says what is the most common location, then most common location overall should be answered as bronchus. This controversy has been present since I was a student, and for if last 20 years, if this could not be solved, then it cannot be solved now also. So just follow Harrison here. The most common location is bronchus. The surgeon will like with tooth and nail, he'll fight. No, Bayesian love says appendix. So I don't want to get into the controversy. I said there are total of 4 sites: bronchus, ileum, rectum, appendix. It can even even be found in the ovary, guys. I mean, carcinoid tumor is so peculiar that it can be found in the ovary or it can be found in the testes also. So, I mean, don't be surprised if he mentions these atypical sites, but the number one site is bronchus. Now, what does this tumor produce? So, it is causing overproduction of 5-HT derivatives. The 5-HT derivatives produced in excess would be like serotonin, and second one is histamine. In fact, histamine is a very powerful vasodilator. So because of the vasodilation action, there would be flushing episodes that would be described there, and histamine will also act on the smooth muscle of the airway, so it will cause a bronchospasm occurring present here. Vasodilatory activity, bronchospasm, so that's why I said asthma-like illness. In fact, the 5-HT derivatives which are produced in excess here can also cause cardiovascular association. The cardiovascular association that I described earlier before you was for Whipple's disease, where I said aortic valve or mitral valve are the either ones that can be involved. But now I'm saying that there could be valvular insufficiency, not for the left side of the heart. Like for Whipple's, it was left side. Now aortic or mitral, two valves were discussed. But here it is TIPS, that is tricuspid insufficiency, or the second manifestation that can be occurring in this patient is pulmonic stenosis. This itself is a question, pure hardcore medicine one, that which valvular lesions can be seen with like patients who are suffering from Whipple's disease. It's aortic and pulmonic valve involvement. I'll just bring that to your attention also. I mean, like I have explained it, maybe you might have forgotten it, so just a good idea to look at that slide again. Yes, Whipple's, and it can cause a cardiac involvement, culture negative endocarditis, aortic and mitral valve. So just like you are comfortable with this, you have to remember for the right hand side that would be TIPS, TIPS, as I explained to you, tricuspid insufficiency and pulmonic stenosis. Murmurs could be present, and histamine is also going to act on H1 receptors in the skin, so extensive itching can be present. One of the very fine Bollywood actors, if you watch that movie, Pan Singh Tomar. Pan Singh Tomar was this actor who played that role of Pan Singh Tomar. He ultimately died because of carcinoid tumor. So I mean, one of the very fine Bollywood actors, unfortunately we lost him to this nasty tumor, which presented in the following fashion and will be given in the question in the same way. I also want to bring to your attention that there is a amino acid by the name of tryptophan. This tryptophan in our body is used for production of 5-HT derivatives like serotonin and histamine. The tryptophan is also required for production of niacin. Now what will happen in this condition is that all the tryptophan will be wasted and diverted towards 5-HT excess production, because tumor is causing diversion of all the products towards 5-HT overproduction. So availability of tryptophan for niacin production will become lesser. I said the tumor is causing a diversion. The tumor is causing more utilization of tryptophan for 5-HT derivatives. Suppose initially tryptophan 50 units were used for 5-HT derivatives and 50 units for niacin. Now instead of 50, maybe 80 units are being used for 5-HT derivatives and 20 only for niacin. So niacin deficiency will occur. This niacin deficiency will result in the question mentioning pellagra-like manifestations. Yes guys, normally we read about pellagra with respect to nutritional cause like niacin deficiency, due to, like he may say, farmer is having that castle's necklace of niacin deficiency. But today I'm telling you a tumor that can cause pellagra. In fact, this is one of the reasons why I've gone into this discussion. Pellagra is an association with carcinoid tumor / carcinoid syndrome. Then is the TIPS, tricuspid insufficiency, more common as compared to pulmonic stenosis. And flushing episodes, if you ever read this statement ever, flushing episodes, you have to think in terms of carcinoid tumor. The only other time you will read carcinoid, I mean flushing episodes, would be acne rosacea. If you listen to rheumatology discussion, I have described acne rosacea there. So flushing episodes are read in carcinoid, and in patients of acne rosacea, that's discussed separately. The most common site of mets in this case is the liver. The best scan is a dotated PET CT scan. This dotated PET CT have been very vocal about it in endocrine section. Now investigation of choice for pheochromocytoma, investigation of choice for pancreatic neuroendocrine tumor. So the same test that is used in endocrine is the best one for identification of carcinoid tumor, which would be originating at any of the following sites, bronchus being most common. And then, I mean, what do you do for treatment if it's localized disease, segmental resection? And if it's gonna be like metastasis present, then we might be using PRRT, that is a peptide receptor radionuclide therapy, where like dotatate based ablation would be done only. And then lastly, I would like to mention regarding carcinoid crisis, just like we read about I mean, crisis word comes once with respect to scleroderma crisis. There we use ACE inhibitors in a patient. Today it is carcinoid crisis in which we'll be using octreotide for management. Octreotide is the inhibitory hormone of the GI tract. So that inhibitory hormone will cause reduction in the manifestations like histamine, pruritus presentation, histamine liberation causing pruritus, histamine causing bronchospasm. Those manifestations will become lesser. So what I've done here is also compared two more topics, that is carcinoid tumor and GIST, which are covered in surgery also, but like we have done the main like heavy lifting at the moment of what is to be answered in the MCQ. Like when this question came in FMG exam, a lot of people wrongly answered imatinib mesylate for the localized version, whereas for that it is a surgical resection. Then is carcinoid tumor aspect, where pellagra is one of the important things to be remembered, because normally we read about a farmer and with pellagra with Castle's necklace. That's due to nutritional reasons. He's a maize eater, he's a corn eater, so that he's ending up with niacin deficiency. But at the moment it is diversion of tryptophan more for 5-HT and less for niacin, which causes these manifestations. Okay guys, so next we talk about the topic of liver. The first question to be remembered is the leading cause of acute viral hepatitis in adults. Now, what I've seen is a common error that the students are doing here, and the answer is hepatitis A virus. I agree that that's a very important cause in children, but according to Harrison, the number one cause of acute viral hepatitis when it comes to adult population is hepatitis E. But if he changes and says which virus will be having highest chances of progression to chronicity, here I have not seen any mistakes happening, because even the pathologist would have said C for chronic hepatitis, C for chronicity. But overall, when we look at the number one cause of chronic viral hepatitis, then answer is hepatitis B. At this, the query of a lot of students is why the answer is not hepatitis C for both of them. So I just want to say that one of these questions is talking about total number of cases. When you look at total number of cases in one of the biggest populations in the whole of the world, India, and second is in China, then it is hepatitis B cases that are more common. But when it talks about predisposition, that which among the two viruses will have more chances, then the answer is hepatitis C. In fact, just to ease off the information, I want to say that hepatitis B is not a dangerous virus as it is made out to be. Like normally on media, no, they'll talk like this, that hepatitis B is a very dangerous virus and you need to get vaccinated. I mean, that's okay. But then in 90% of cases, recovery is the rule. Yes, guys, that is what Harrison says, that hepatitis B is not all that a dangerous virus as it is made out to be. In fact, it is C that is more dangerous, because look at the data that I'm saying. In 90% cases of hepatitis B, there would be recovery. In contrast, 90% cases of hepatitis C will progress into chronic hepatitis C. Then comes the aspect of viral cause of fulminant hepatic failure and fulminant viral hepatitis. For the word fulminant one, I want to say that when do you say the word fulminant is when either of the two things are developing in a patient. You see, liver is responsible for production of clotting factors. So if you are having a development of coagulopathy, now the manifestations of coagulopathy could be in the form of a lower GI bleeding, it can be an upper GI bleeding, it could be just in the form of melena. So if a person with liver damage is having prothrombin time, which is more than 1.5 times the normal limit, the normal values of prothrombin time is like 11 to 16 seconds. So if prothrombin time is elevated more than 1.5 times of the normal, then it would imply that there is a coagulopathy happening. That means liver is in the process of getting destroyed. The second function of liver is detoxification of ammonia. Therefore, if the ammonia will rise, it will cause asterixis in a patient, that is flapping tremor, and development of encephalopathy. So what I want to bring to your attention is that if a person is having any of these, it is not both of these, if any one of these is present, either coagulopathy or encephalopathy develops within 8 weeks of liver insult. The liver insult could be in the form of viral hepatitis, paracetamol toxicity, introduction of antitubercular drugs. Like I have explained to you in earlier videos that the most hepatotoxic antitubercular drug is pyrazinamide. So within 8 weeks of pyrazinamide introduction, that is within 8 weeks of a liver insult, if the liver begins to show any of the two manifestations, that is either in the form of coagulopathy or encephalopathy, I say fulminant hepatic failure or fulminant viral hepatitis. And the number one virus which is responsible for this, I'm just using a separate color to introduce contrast, because everything that written in blue in this horizontal table is with respect to like the definition of the word fulminant. So for viral, the main aspect would be, again, answer is hepatitis B. On this, the query of a lot of students is that, we have read about hepatitis D also. So like, what should we answer in a question? So first, I want to bring to your attention the fact that both B and D together cause a manifestation that is called as co-infection. And that co-infection has high chances of development of fulminant hepatic failure. You see, the single best answer that I want to write for this question is hepatitis delta virus. The point is that delta virus alone does not cause damage. Please appreciate that fact. Delta virus is an incomplete RNA virus. So alone, it will not cause a damage. So the technical answer is co-infection. By English word co-infection, I mean that there is like acute viral hepatitis B developing, then there is acute viral hepatitis D developing in a patient. So the message here is that if he says like, give me a single best answer, then answer would be given as hepatitis B, hepatitis D for Delhi. But it is due to coexistence of two types of acute viral hepatitis, that is B and D, that you will have a fulminant hepatic failure. I'll explain the data once again just to let you imbibe this information. Acute viral hepatitis B for Bombay will have 90% chances of recovery. If B infection is occurring alone, recovery. If D infection D for Delhi is happening alone, recovery. But if the two are together, then it is like two villains. Two super villains coming together. The body can handle villain 1, body can handle villain 2. But if two villains will come together, the poor liver, the poor hepatocyte will get like overwhelmed, and he will not be able to respond to the overwhelming, I would say, cytopathic impact caused by combination of two infections. That is where the technical word is co-infection, but because in a lot of MCQs like that, co-infection word would not be given. So your answer would be given as hepatitis D for delta. But I'm writing both the points here. Like the first answer is single best answer, delta virus. But if he specifies, then it is a co-infection. In co-infection, it is acute viral hepatitis D as well as hepatitis B combination, which the textbook says results in development of fulminant hepatic failure incidence going up to 20%. Having said that, the next question will say leading cause of fulminant hepatic failure in pregnancy or fulminant hepatitis in pregnancy. Here, there is no dichotomy of data. Here, there is no confusion because the answer is standard hepatitis E, even the gynecologist would have said about it. But when it comes to the general question without a pregnancy, then it is delta virus in combination with the B virus. The co-infection has a high incidence of fulminant hepatic failure going up to 20%. In pregnancy with E, the incidence goes up to almost 30%. So I'm writing the data to just bring to your attention that this 30% incidence is with respect to the topic that is being discussed, fulminant hepatic failure in pregnancy. Overall, the most common cause of acute viral hepatitis is also E, which is transmitted due to fecal route, as you all know. And most of the time after floods, the person could end up with development of jaundice and a hepatomegaly. You see, the traditional question that comes in the paper is like, after floods, the patient is having jaundice, then there's a renal failure. That could be leptospirosis. So I'll also write in a question how to differentiate in a question in 30 seconds whether it's going to be leptospirosis versus hepatitis E. I'll mention that in the form of a common error just at the bottom of this slide when I'm done, but just keep posted for like, just to give you a heads up, like, we will be discussing like if he says floods and then he says jaundice, then what are the differentials to be considered. So just after I'm done with this table, I'll just describe it. Next is leading cause of hepatocellular carcinoma. Here also, like I find students getting confused between hepatitis B versus C. I want to quote Harrison. I agree that in Robbins it is written hepatocellular carcinoma with C. He has mentioned USA word there. But in like Harrison, he has mentioned that majority of the world population lives in Southeast Asia. Harrison says majority of the world population lives in Southeast Asia and max cases of hepatitis B are in Southeast Asia, and therefore liver cancer is also more common in Southeast Asia. So for America, it is okay that it is C, but for Southeast Asia, it is the B virus. Then is what is the treatment? Do we treat every patient of hepatitis B? No, we treat only patients of chronic viral hepatitis. So I'll teach you the threshold. I mean, what is the viral level? What should be the viral level? What should be the SGPT levels at which treatment is started? But at the moment, I just want to bring to your attention that what are the drugs that we can be using? What is the firepower that we have? So we have tenofovir, and the second molecule that we have at our disposal is entecavir. Any of the two can be used. Tenofovir, I'm putting a star mark just to say that it is also active against HIV. So another question of your paper said like which antiviral drug will be working most against HIV as well as hepatitis B? The answer is tenofovir. Then is question for hepatitis C virus. The answer is obviously genotype wise, but yes, guys, I think you guys can help me out. What is the drug of choice for hepatitis C virus, C for Calcutta? The common route of spread of the C virus is mainly going to be like parental route. I mean, how the C virus will mainly spread. B virus, the main route of spread would be like sexual contact. But when it comes to the C virus, it could be like parental route. Parental would mean like needle sharing, or it could be like tattoo needles. Blood transfusion obviously is an important cause. So we'll talk about the routes of transmission also. But for C, the single best answer is parental. Okay, guys, I gave you enough lead time to think about what are the drugs that would be used in this condition. So one of the drugs that is used is sofosbuvir. The word is buvir, right? It's gonna work against NSB antigen. And the second one that I'll write is called as velpatasvir. So the words to be picked up are like asvir, ASVIR, and buvir, and you need to just be familiar with like NSB versus NSA. And when it comes to drug of choice for hepatitis delta, D for Delta, then it is alpha interferon. So if he says what is the drug of choice for hepatitis delta virus, then answer is given as alpha interferon injections that would be given. And overall, what is the most common cause of orthoptic liver transplantation? Then I would not like to waste liver on a person with alcoholic cirrhosis. A patient of alcoholic cirrhosis will be like, oh, it's a party time for me. I destroyed my liver. Now Dr. Sahab has given me a new liver. He will again go back to drinking. So now we don't waste liver in patients of alcoholic cirrhosis. We'll be utilizing that in those patients who are having NAFLD, that is non-alcoholic fatty liver disease. I erase that because the new term that is used for this is metabolic dysfunction associated steatotic hepatitis. I'll say that again, metabolic dysfunction associated steatotic hepatitis. This is the terminology that is used for NAFLD, that is non-alcoholic fatty liver disease, which is an old terminology. You would still come across this in the older books, but then I want to also bring to your attention another fact, like I've just put an arrow to say that which virus is having higher progression of conversion of acute into chronic, and then chronic into cirrhosis, and cirrhosis into end stage liver disease, ESLD, end stage liver disease. It is hepatitis C. So if he specifies in the question what is the most common viral etiology, the word is viral etiology that causes substantial chronic liver damage or end stage liver disease, which will require orthoptic liver transplantation, then answer is C. But if it does not mention anything like that, then the overall number one cause is metabolic dysfunction associated steatotic hepatitis. We'll talk about the drugs for MASH as well, but at the moment, let's handle a common error that the students might be making. You see, after floods, like, he will mention that there is a case with jaundice. Now, the moment you read after floods case with jaundice, you will be thinking, yes, man, it could be leptospirosis or it could be acute viral hepatitis. So what are you supposed to read in the question? What are the keywords? What are those so-called buzzwords in the question that would tell you that, okay, man, I am dealing with viral hepatitis or whether I'm dealing with leptospirosis? If he uses words like conjunctival suffusion, then he talks about myalgia present in a patient. The myalgia is like specific for like muscles everywhere in the body, but especially if he says calf pain being present, the question might begin by saying farmer also, or he might say like instead of farmer, he might say person living in a high-rise building. I mean, the point is after floods, everybody is susceptible, whether it's a farmer or somebody staying in a multi-story society. So conjunctival suffusion, cough pain described in a question, then I'll think in terms of possibility of leptospirosis in a patient. But if he just says that there is a hepatomegaly that is appreciated, and there is a jaundice that is present, and then when you look at the liver enzymes in the patient, you are noticing predominantly that the SGPT is showing a substantial increase. SGOT is also showing a substantial increase in a patient. Then I will think isolated finding of hepatomegaly also given. Instead of hepatomegaly, he may write the word even like pain in the right upper quadrant or tender hepatomegaly. Then you will think in terms of query viral hepatitis. But in case he mentions that there is like case with jaundice, but there's a conjunctival suffusion, there is a cough pain, obviously like there would be description of fever as well. The severity of fever can also vary with respect to both of them, but like we cannot say that fever more than this much or less than this much is suggestive. So on the left hand side, I will first think in terms of conjunctival suffusion, cough pain. I'll think in terms of possibility of leptospirosis. Moving ahead, I'll now discuss regarding hepatitis B. The overall most common route of spread is not blood transfusion. Yes, guys, here a lot of guys make a mistake because the question There are two separate questions. One says, what is the leading cause of transfusion associated hepatitis? Then it is hepatitis B. You see, private blood banks in India might be charging up to 10,000 rupees for 1 unit of blood before the transfusion in the patient is done. That is the cost of testing the blood. But due to corruption issues, there might be like testing that may be substandard or may not be done at all. If the testing has not been done, or if the kit was not good enough, or the QC, the quality control, was not maintained, then a patient might be getting a hepatitis B positive blood, and that can result in transfusion associated hepatitis. So the problem lies from the administrative perspective and QC quality control. This does not mean that the overall most common route of spread of hepatitis B is blood transfusion. I said it does not mean that the number one cause route of transmission is blood transfusion. This is just an administrative failure. So overall, the most common route of spread would be answered as sexual contact. That would be like sometimes MCQ wise, he may write the word percutaneous route as well. So sexual contact or like percutaneous route is common. And then another important route that should be remembered is vertical transmission from the pediatric perspective from mother to child. Now let us study regarding the antigens that are seen in this virus. The question for you guys is, would you like to answer this as it's obviously a DNA virus. Would you like to call it a single-stranded DNA virus or a double-stranded DNA virus? Yes, guys. Would you like to call it a single-stranded or a double-stranded DNA virus? Your answer would be it's partially single-stranded, partially double-stranded. How this is written in MCQs is SS/DS. Suppose I write only the word SS, single-stranded. If I write only the word DS, that is double-stranded. अगर वो दोनों लिखता है, that means it is partially single-stranded, partially double-stranded DNA virus. So I'll just prefix that word partially here to say that SS/DS means it is partially single-stranded, partially double-stranded DNA virus. Let us now study regarding the antigens that are seen and the questions that come on that. From the antigen perspective, the first one, the important one to be remembered is surface antigen. Now, this is the first one to appear in the blood from the serological testing perspective. Because this is first one to appear, therefore, I want to say the question will say what is the earliest serological indicator of the infection. Then earliest serological indicator is surface antigen. At this moment, I also want to say that in reality, even before the surface antigen, what comes is the hepatitis B DNA. Even before, what comes before the surface antigen is actually hepatitis B DNA, for which we will have to do PCR, and lots of time in our country, like that facility for PCR, even if it is available, it will be expensive now. I mean, imagine surface antigen test might be like maybe 350 rupees, maybe 500 rupees, max, I'm saying, and like PCR can go up to 3,500 rupees to 5,000 rupees. I mean, I'm saying like if you order a hepatitis B profile in a patient, max 350, 500 rupees, something like that. But a PCR test is going to be running into thousands. So though in reality the virus is actively multiplying, so the hepatitis B DNA will be detectable in the blood even before the surface antigen, but nobody is going to do a PCR in India, no early presentation. So it is surface antigen. I mean, like going by traditional workup in a patient, surface antigen is first to appear. But I just wanted to bring to your attention that if he makes it technical and writes the word hepatitis B DNA, then answer is hepatitis B DNA, where we'll do a PCR. I'll give a parallel example, just to explain this to you. Like, okay, let me write it down so that this becomes much more clear to you. Let me say, I'll use a different color for this. A doctor got an accidental need. I'll write it and then like I'll comment on the figures. A doctor was doing sampling of a patient who's HIV positive. Unfortunately, though the doctor was using double gloves, he was doing recapping of the needle, so he got an accidental needle stick injury. This accidental needle stick injury has occurred in a doctor from a HIV positive patient. Now, once the accidental needle stick injury has occurred, he removed his gloves. Obviously, there was blood present. And from PSM that we will be using in this condition post-exposure prophylaxis, where we'll be giving tenofovir, lamivudine, and dolutegravir, and that has to be given for 28 days in a patient. So you are already aware that the percentage of chances of transmission in this case are about 0.3%. And what you should do in this patient is start the post-exposure prophylaxis as early as possible. Usually, like you should not delay it beyond 72 hours because it is not effective after 72 hours, and it is given to the patient for total of 28 days. The drugs used are TLD, tenofovir, lamivudine, and dolutegravir. You all know this from PSM, so I've just written it down. My question to you guys is, like, this healthcare worker, he initially neglected this injury. He has come to you after 1 or 2 days of the needle stick injury, and he says, I got a prick yesterday, day before yesterday. Like, this person was on night duty on a Saturday. Now, maybe like the CMO in charge or the medical superintendent on his leave. So you are the senior doctor. He comes to you. He says, I got a prick on a Saturday duty, doctor. There was nobody available and these young guys were on duty. So he says, doctor, what test should I do for early detection? My question is, a nurse or it could be a laboratory technician, it's a doctor on a weekend got pricked. Obviously, you will give PEP to this patient. Testing can wait, but my point is, what test will you write for this healthcare worker for early detection? The serum ELISA for HIV turns positive on 23rd day of acquiring the infection. I'm saying, God forbid, if this doctor is unlucky and is getting the infection, he will turn positive for serum ELISA, 4th generation serum ELISA. HIV will turn positive on the 23rd day of acquiring the infection. He's not willing to wait it out for that long. So a test that I can do is by the name of P24 antigen. P24 antigen can be positive by 14th to 15th day. But can I have a test which is even positive before that? Yes, the answer is PCR. I can do a PCR HIV. Yes, guys, I can do a test. This was actually a PSM based question. So I'm a little being, like I've written it, but like I think you know the answer, that here the best answer would be given as PCR HIV RNA. This will turn positive by 7 to 10 days. If this is not in the options, then when I was a student at your age, when my consultant asked me this question that beta, a patient has got patient is having HIV, you got accidentally inoculated, then what test should you be doing in yourself or like in any person who comes to you? Go for early detection. Then I answered that as P24 antigen, which will turn positive around about 14 days. And the third test obviously I can do is a 4th generation ELISA, serum ELISA, which can turn positive around the 23rd day. So at this moment, like I am very sure that you would have read this domain from the PSM perspective. If you've read it, cool. Otherwise, anyway, I've told you the answer that you need to give PEP to the patient, tenofovir, the same treatment that we talked about in HIV, tenofovir, lamivudine and dolutegravir for 28 days. And it's a PCR HIV RNA that should be done for early detection. In the same spirit for hepatitis B also, I told you for early detection, it's a PCR hepatitis B DNA. Next, we move on to another test that's called as core antigen. The information for core antigen is that it would never be appearing in the blood. So the question will say, what is first one to appear and which one is never to appear? So core antigen is literally hiding inside. For never to appear in the blood is the core antigen. The third antigen we'll take care of is the E antigen. So S for Singapore, C for Calcutta, E for England. Just in case like the pronunciation part is causing a bit of issue, E antigen, E for England, is indicative of active replication. The word is E antigen is indicative of active replication of the virus, E alphabet to be focused on. And because it's an active replication, therefore I can say that the infectivity of this person to his or her sexual partner and the infectivity of this person to the doctor and nurse who's handling the blood sample of this patient will be substantially high. So from the antigens perspective, you need to remember E antigen highlights increased infectivity in a patient. Then comes the issue of hepatitis B X antigen, that is the alphabet X coming in here. That X antigen tells you that this is the risk factor for development of hepatocellular carcinoma. Guys, what this X antigen does is it turns off apoptosis. You all know from pathology that apoptosis is programmed cell death. If you turn off the apoptosis, the programmed cell death, then the cells can multiply continuously. And cancer is a condition of uncontrolled mitosis. I said if you turn off apoptosis, then the cancer cells can multiply indefinitely. So it inhibits apoptosis by inhibiting CD95. That's a bit from pathology aspect, that apoptosis would be having extrinsic pathway, intrinsic pathway. So it turns off CD95 and thereby the cells keep on multiplying. For the PCR, I can get a viral load. Like suppose they give you a report of 20,000 international units. How the MCQ will, how we will write it from the mathematical perspective, we will not write 20,000. He will say 2 into 10 to the power 4. 2 into 10 to the power 4 international units of DNA per ml. It is like 20,000 international units of DNA per ml with doubling of SGPT. Both of these data should be given in a question. Just like in MI, the cardiac biomarker troponin I should be showing a doubling, or it can go up to any particular level. Similarly, here I have established a threshold that cytopathic effect is causing a doubling of SGPT. If this is the report given in a question, it means that the treatment is to be done because the patient is having a high viral load. The threshold for high viral load is 20,000 international units with doubling of SGPT. Suppose he gives me a question saying 2 into 10 to the power 3. And SGPT is normal and he says, what will you do? I'll say I'll go for wait and watch. But if he says 20,000 international units or higher, like suppose he says 2 lakhs, 20 lakhs, 2 crores, whatever, with doubling of SGPT, then I have to act. I have to give a antiviral drug for this patient. That is going to be tenofovir. So the threshold at which we treat our patients in chronic viral hepatitis caused by hepatitis B is 20,000 international units with doubling of SGPT. At this moment, I also want to say that if he says which is the best liver function test, then the best liver function test is SGPT. I mean, because it's SGPT, guys, is in the cytoplasm of the hepatocytes. SGOT is in the mitochondria, and SGPT is present in the hepatocyte. So the cytopathic effect will cause SGPT elevation in a patient. Now we will study regarding antibodies. The antibodies which are present here are like antibodies against the surface antigen, antibody against the E antigen, antibody against the core antigen. So I'm just writing the same data once again: S for surface antigen, C for core, and E England, but it is antibody against each of them. To see that you are understanding me, let me know which of these three antibodies. Don't check out the notes. Answer without that next 5 seconds. Which antibody is the seroconversion antibody? Seroconversion would mean that it's a guarantee that if this antibody will appear, patient is not going to die. If this antibody appears after hepatitis B infection, it's a guarantee that the patient is not going to die. Your answer would be antibody against the surface antigen. S for security system is coming up here. The security system implies seroconversion antibody. This implies that the person is unlikely to die because good antibody titers would be present. For antibody against the core antigen, I would like to divide the discussion into two parts. That is IgM class of antibody and IgG class of antibody. Now let us look at the inputs. If a question talks about IgM class of antibody to the core antigen, then I will be thinking in terms of acute viral hepatitis B infection. Obviously, like in any acute infection, IgM class of antibody would be present, so no prices for guessing that. But in some MCQs, you will notice that the answer will not be given as acute hepatitis B. The answer will be given as gap period. So about 2 minutes from now, I'll be able to explain to you that in which MCQ should you be answering a gap period and which MCQ should you be answering as acute hepatitis B. I'm flagging this again as a common error. I mean, I've not written the word common error, but I'm flagging it because guys casually answer acute hepatitis B or gap period, either of the two, without looking at the technical information that I will be providing to you in about 2 minutes lead period from now. For the IgG class of antibody, again flagging it down as a common error because a lot of guys casually answer this as chronic hepatitis B, but the answer in the MCQ might be remote infection. Now, how would you in a span of few seconds decide in a question whether I should answer remote infection or chronic hepatitis B? This will come up in about 3 minutes lead time from now. So don't jump the video, but yes, in 2 to 3 minutes, I'll be in a position to explain to you when to answer because there's a dichotomy of data with respect to IgM and IgG class of antibody. The solution would be provided. For antibody against the E antigen, the simple logic is because E antigen is indicative of replication right on top of the slide. So if I will be having antibody against the E antigen, this implies that replication rate is decreasing. If the replication rate will decrease, the infectivity of this person to his or her sexual partner, to the doctor nurse handling the blood sample will also dramatically reduce. So what I've done at the moment is tell you standard data with respect to 5 antigens and 3 antibodies. And I also wanted to introduce the concept of PCR being done for HIV or for hepatitis B. That is to especially for benefit of healthcare workers. Like if I get a prick from a hepatitis B positive patient, if I want to find out that like whether I got the infection or not, I can do a PCR. It will help me in early diagnosis because all other tests take time. So it time to turn positive. Then the treatment, the drugs that we will be, like I mentioned for chronic hepatitis B, tenofovir and entecavir, they are given only in chronic hepatitis B. And I've also mentioned the threshold here. The threshold is right highlighted in red, 20,000 international units with doubling of SGPT. So we don't waste our firepower in acute hepatitis B because in acute hepatitis B, 90% cases recovery will happen. I mean, you use your firepower when required. There's no need of firing just because there is a virus present, because our immune system is so good that it will be able to kill the virus in 90% of cases. Only if the immune system does not kill. And how do you know immune system is not killing? The protection antibody will not appear. If the antibody appears, patient will begin to recover. He will not even come for second follow-ups, or he will not, even if your receptionist will call and say, no, Dr. Saab is calling you, patient will not come. Most patients of hepatitis B never come for a second or a third follow-up visit simply because recovery is the rule. But if he's coming the second time or third time and there is a jaundice present, that means that his immune system has not responded, the seroconversion has not happened, the security system is failing, and that means he needs drug support, because if you don't do that, he will get converted into chronic hepatitis B, cirrhosis, end-stage liver disease, and will finally die due to hepatic encephalopathy, coagulopathy. They would be like, bleeding, which could result in mortality. Also highlighted that D virus alone does not cause damage. D virus alone does not cause damage, but it's a mild virus only with B. When two villains attack the hepatocyte together, the hepatocyte is like confused. No, what the hell is going on, man? Like, so many people beating me up. So he there's a delay in response. And then because of the delay in response, these two cause substantial amount of damage. That's fulminant hepatic failure that I was teaching you earlier, co-infection. So the question was PSM oriented mainly, but still I'm covering it. Best for eradication of D infection is 100% coverage with hepatitis B vaccine. Small countries like Singapore have done it. I mean, Singapore, then a couple of these countries, they're doing like very small countries, easy to manage administratively. But yeah, the rules are very strict there. Dubai, for example, now they force rules like anything. So you will notice that the health indices of these countries will improve. And over in India also, I mean, if the government gets strict, if the benefits are linked to vaccination, then obviously the response of the general population to vaccination will also improve. Now coming to serological interpretation, I want to draw your attention to two graphs which have been asked in the exam. In the first graph that you can see superiorly, there is presence of a biphasic curves, right? You can see an initial curve, you can see a second curve. And also my student said that on the x-axis weeks was written. So they answered this as presentation of acute viral hepatitis, though I'll fill up the technical details also. But if you look at the second graph, you can notice that it is more like flat curve. There's no biphasic curve, it's more of a flat curve present. And at the same time, you will also notice that here it is written months. So that would go in favor of chronic hepatitis B. So first message is, if you are able to see two graphs or two peaks like this, that goes in favor of acute hepatitis B. Let's also do the marking so that we are more comfortable with this particular interpretation. First and foremost is surface antigen, which is shown in red. The second one is this dotted one. The dotted one is IgM class of antibody to the core antigen. And then very soon it will be converted into IgG class of antibody against the core antigen, which goes in favor of chronic hepatitis. But at the same time, what you're also noticing is this blue curve. The blue curve is basically the security system that is appearing. So what can happen in the paper is that they can just put these graphs and they can ask you to mark like the representation. So if you see a big biphasic curve, the initial part is to be answered as surface antigen. The second part of this biphasic curve is antibody against the surface antigen, that is the security system. And in majority of cases, in 90% cases, this security system will appear. That is why I said recovery is the rule that is present here. Also because weeks is written, so the interpretation that you will give in this graph is that of acute viral hepatitis B. And now I will bring your attention to a very interesting part of this entire discussion. You can see where I put the vertical arrow at 28 marks, that 28 weeks is like a range, it's 24 to 28 weeks. But what is happening is that the red graph, that is for the surface antigen, is showing a declining trend. So at this 24 to 28 week period, there's a possibility that patient's surface antigen report is negative. It is negative because of the declining trend, that it will be below the threshold of detection. Every test has a particular level of threshold of detection, because surface antigen is showing a declining trend, so it will be below the threshold of detection. So person will turn surface antigen negative. At the same time, the antibody against the surface antigen, which is in the dark blue curve, the navy blue curve, has still not appeared. So this particular period that I'm bringing your attention at the moment is what is called as gap period. It may be written as window period or it may be written as gap period, but like the question will say, what is the best test that would help in identification of gap period? Your answer will obviously not be surface antigen because it is negative and the antibody against surface antigen has not appeared. So for gap period, if he says what is the antibody that you will be using for detection, your antibody answer would be given as IgM class of antibody to the core antigen. Why? Because it is showing an increasing trend. You can see the dotted brown graph that is going up. So at the graph, at the gap period time, if he says which antibody will help in diagnosis, don't answer IgG class of antibody. That is for chronic hepatitis B. It is IgM class of antibody that would be present at gap period. And this data will make more sense to you when you listen to the later part of the discussion that I'm going to speak with respect to the serological interpretation. Now we focus on the second curve. In the second curve, you can notice that the green curve that can be asked to you, and this they have asked in the paper that what does this signify? So your answer is simple. Antibody is the core antigen, and antibody is the core antigen will be initially having IgM part which is declining, but the IgG part is persisting for months altogether. Guys, the IgG part of antibody to the core antigen is persisting for like months altogether. If it persists like surface antigen positivity for more than 6 months, IgG class of antibody is present against the core antigen, it goes in favor of chronic viral hepatitis B. Even if you don't remember the technical inputs with respect to the viral data that I put up here, like, the green is representing antibody of the core antigen, the minimum that I expect you to remember is that if it's a flat curve and months given, chronic viral hepatitis. If it's a biphasic curve and weeks given, then it is acute viral hepatitis. And also another fact that I want to bring to your attention is surface antigen is first to appear, then E antigen will turn positive, then liver enzymes will start turning positive, then jaundice will appear in the patient. You can see jaundice is the last thing to appear, but is the first one to disappear. I'll say this once again. Jaundice is the last one to appear and is the first one to disappear. The sequence is surface antigen first turns positive, then the E antigen, then the liver enzymes start rising, and the biochemical recovery will take a little extra time. Also, you can see E antigen will get replaced by antibody against the E antigen, but this graphical representation is just picked up from the textbook, and they said, what does this graphical representation representation show? So if it's a biphasic curve, it's an acute viral hepatitis B, and all of this will make more sense to you after you listen to the following tabular format that I described. Suppose I give you a question where I say a young college student has developed recent aversion to cigarette smoking. He's feeling pukish, he's having fever, he's having jaundice also. So he came to me. So I got a surface antigen testing done and it is turned out to be positive. At the moment, because it is early days of infection, so security system is sleeping and the class of antibody against the core antigen is IgM class. If you read a question where these two things are given together, surface antigen positivity as well as IgM class of antibody to the core antigen, you will say that you're dealing with a case of acute viral hepatitis B. You will say that you're dealing with acute viral hepatitis B. And if E antigen is positive, then you will also add that this patient is having high infectivity, to the sexual partner and to the healthcare workers as well, because we can get an accidental needle stick injury from these patients also. Now, because the security system kept on sleeping, had the security system woken up, then the patient would have recovered and would have never ever come for second follow-up. But because the security system kept on sleeping, lots of time government hospitals, people attack us and the security is sleeping. Similarly, here security system is sleeping, so the patient is getting converted to chronic hepatitis B. For chronic hepatitis B, two things should be given in a question: surface antigen positivity plus IgG class of antibody to the core antigen. If these two things are given together, then you will say that you are dealing with chronic viral hepatitis B. And since I have put E antigen also positive, so I will say patient is having high infectivity or is highly infectious. Either the two, either I say the word high infectivity or I say the word highly infectious, it basically means the same only. I can deliberately, or the examiner here deliberately can mention the E antigen to be negative, then you will say low infectivity. So high infectivity is a common data. High infectivity that I have currently marked before you is the common data with respect to both the first entry in this table and the second entry in the table as well. Now comes the critical part. If they give you a question where everything is negative except for the security system, only the security system, the antibody surface antigen is present. This is the this is what is the status for you and me who have taken the vaccine, because if you are having security system, you're not having any markers, that means that you are immune to any further attack from the virus. That is a vaccinated individual. In contrast, if they give you a report where everything is negative except for IgM class of antibody to the core antigen, this is the most important part of the discussion and should be listened with a lot of care. If only IgM class of antibody to the core antigen is present, you will say that the patient is in the gap period, and that is what I was trying to show to you in the previous graphical representation also, that IgM class of antibody would be present with respect to the gap period. I had marked it initially and I've just highlighted it once again. Even superiorly previously when I was saying that if you're getting a combination of the two, IgM class of antibody is surface antigen, answer is acute viral hepatitis. If only IgM class of antibody is given, answer it is gap period. And then there was a question in which everything was negative and only IgG class of antibody to core antigen was present. If only IgG class of antibody to core antigen would be present, then I would be calling it a remote infection. And I can give a short explanation also. Suppose you had COVID in 2021, then you had it again in 2022, because multiple people had multiple episodes of COVID at the time when SARS-CoV-2 was spreading. So the COVID antibody could still be present in your body. No? It's almost like so many years since the COVID pandemic ended, but even today we could be having antibody gassed in our blood. In a similar spirit, this patient suffered from infection in remote previous time, but the antibody could still be present. So this report that is currently highlighted before you is called as remote infection. And in this particular table, the inferior three entries are the ones which are to be given maximum importance, where single entries are present. What I mean by single entry is, in the first report that I'm trying to bring to your attention, it is only the security system present, so vaccinated. If only IgM class of antibody present, then it is the gap period. And if it's going to be only IgG class of antibody, it is remote. But if they give you a combo, the one that is marked acute viral hepatitis, if they give you a combo that is marked at the moment chronic viral hepatitis. So very simple, very straightforward data. And the same thing was highlighted in the graphical representation, and the same thing was represented even in this horizontal tables that I mentioned before you. It's just that different way of presentation or different ways of asking that have been shown at the moment. The most important question to be remembered is gap period is IgM class of antibody to the core antigen alone. And if it is IgG class of antibody to the core antigen alone, it means he might have suffered from infection in remote past as well. Plus the biphasic shape of the curve, as I highlighted before you, helps in like interpretations. Now, because we as doctors are exposed to the risk of accidental needle stick injury with respect to hepatitis B, so he will also ask you regarding the percentage chances of transmission. Like you are aware of the fact for HIV, the percentage chances of transmission are only 0.3%. With hepatitis B, the chances of transmission are a huge 30%. So he will give you a scenario that this is an intern. He's doing recapping of the needle. I mean, recapping of the needle is never ever to be done. You are using double gloves, that is okay. But after taking sample from a patient, never put the cap back on the needle, because howsoever careful you are, if your concentration wavers even for a second, you can get a prick. So this doctor is unvaccinated. He was taking a sample bedside. He should have, after taking the sample, first put the needle in the needle cutter and discarded the needle. And then you can handle the plastic hub. But if you're handling the needle directly, there's a high probability that it can prick, even because double gloves, the cutting edge of the needle is so sharp that it will go through that gloves, and therefore this guy got a prick. So this guy is now contacting you. You are a senior and you told him 30% chances. So he's very apprehensive. He says, sir, I have not even taken the vaccine. I got a prick. Will I develop hepatitis B? I said, yeah, 30% chances. So when I told him that, he got a little, nervous and jittery, and he said, boss, I don't want to die. So I told him, obviously you will not die, but we can protect you from getting jaundice and infection in the very first place by giving you passive immunity. So to this healthcare worker, we can be giving hepatitis B intramuscularly, that is passive immunity can be given. It should be given as early as possible, but preferably within the 24 hours of exposure. If this passive immunity is given to this person, then he will not suffer from jaundice or the ill effects of the virus. But suppose I change the data and I say it's a partially vaccinated healthcare worker. For a partially vaccinated healthcare worker, if he says, what will you do? Then your answer will vary a bit, because he has taken the vaccine. So I'll not straight away give passive immunity. In this question, I will say that I will first check for the level of the security system titer. The security system is antibody against the surface antigen. So there can be two possibilities now given in the question. One question will simply say, what is the next best step with respect to accidental needle stick injury in a partially vaccinated healthcare worker? Your answer is next best step is measuring the values of antibody against the surface antigen titer. If the titer turns out to be less than 10 international units per ml, or the titer can turn out to be more than 10 international units per ml, the examiner himself will give you a mathematical value, and you will then have to decide. If the value is given to be equal to or more than 10 international units per ml, you will tell this person, calm down. There is nothing to worry. There is no further intervention required. Your answer in the MCQ will be that the person is adequately protected. Because he is adequately protected, no further intervention is required for this particular case. But if they give you a scenario where it is like less than 10 international units per ml, then yeah, I need to give active immunity. So my answer in this particular case would be that I'll be giving a single dose of hepatitis B vaccine to this individual. Yes, guys, this time we are using the concept of active immunity to upgrade the antibody titer in the patient. The message is in an unvaccinated individual, because there is no immunity, so it's a passive immunity. But for partially vaccinated, I just need to upgrade, and therefore the threshold to be remembered for when do you need to upgrade is less than 10 international units. If it's higher than 10, then there's no further intervention required. In one of the NEET PG MCQs, he mentioned that the healthcare worker is a non-responder. What I mean by non-responder healthcare worker is that at least 2 times vaccination has been done. This guy has received at least 2 or more than 2 courses of vaccinations. And every time after receiving these 2 courses, every time he received the course of vaccine, that is at 0, 1 and 6, we checked the level of the antibody against the surface antigen and it was undetectable. He has already received 2 courses of vaccine received, and in spite of this, he is a non-responder to the vaccine because his immune system is not taking up this antigen. And like we gave him at once at 016 maybe last year, then since his antibody against surface antigen did not appear, so we repeated the course once again in another year. Still the antibody against surface antigen had not appeared, but this guy today make the fatal mistake of getting that needle stick injury. Then I will have to give 2 dosages. I will have to give 2 dosages of hepatitis B surface antigen. So the message at the moment is that in partially vaccinated, it is like a single shot that is to be given. In unvaccinated individual, you can see it is a single shot that would be given, but here it is 2 dosages, one immediately and second can be repeated after 1 month. All of these 3 are like even discussed in public health perspective, but there they have to tell you so many other public health domain that this is usually neglected. So is a must know information. And nowadays, like healthcare workers, you will notice in a private setup, nobody even touches the patient. No, especially surgeons or gynecologists will never touch a patient without testing for hepatitis B, HIV, etc. because of accidental needle stick injury that can happen. Even the cutting edge of the suture needle, no, that the surgeon is using can prick the surgeon and they can get inoculated. So that's why like they are very, very particular when they are doing a case selection. The table that I mentioned here, like if you say that, doctor, can you tell me what is must know, then this table is a must know. If you are an FMG student, only the top 2 entries are to be remembered. That is the acute versus chronic. If you are into NEET PG or NESET, then obviously all the 5 entries are to be remembered. And rather in NEET PG, NESET, they tend to ask for the inferior data where everything is negative, except for either the security system or the IgM class of antibody or the alone IgG class of antibody, where the respective answers have already been explained to you at the moment. Now, I will speak regarding cirrhosis. The overall leading cause of this is also non-alcoholic fatty liver disease. And the definition of NAFLD would be like approximately more than 5% of the hepatocytes are already showing steatosis. Meaning of the word or technical meaning of the word steatosis is triglyceride deposition in the hepatocytes. In fact, non-alcoholic fatty liver disease, the new name for this is MASH, as already explained to you. And this is overall the number 1 cause of why a person would be requiring orthoptic liver transplantation. Orthoptic means that we are gonna be putting the new liver after removing the old liver from its side, because liver is so big now you can't fit it anywhere else. So you remove the old liver and put in a new liver. Remember, in kidney transplantation, we don't remove the old kidneys. Old kidneys remain in place and the new kidney is put in the right iliac fossa. But liver is so huge that we can't put it anywhere else. And for non-alcoholic fatty liver disease, also called as MASH, the test we can do is this FibroScan, because FibroScan can tell you whether fibrosis has started in the liver. I mean, that's a brand name, FibroScan. Basically, the technical name for this, like in a lot of MCQs, they may not write the word FibroScan. He will say, what is a non-invasive imaging for NAFLD? One is I can go for liver biopsy. Liver biopsy is showing more than 5% of hepatocytes showing a steatosis. But if he says non-invasive imaging, then the non-invasive imaging that I would like to go in for is called as transient elastography. The word is TE. It is transient elastography. And along with this, even liver enzymes will get deranged in fatty liver as the damage will progress. The technical name for that is FibroScan. What are the drugs approved for NAFLD that you know from pharmacology also? One of them is resmetirom, and this would be a thyroid hormone receptor beta agonist. It increases hepatic fat metabolism, and the upgraded levels of this THR, thyroid hormone beta receptor stimulation. In fact, I mean the thyroid hormone receptor beta in the hepatocytes is upregulated, which causes more burning of fat. Then semaglutide is in the news obviously for the right reasons, that it is a GLP-1 receptor agonist. It will help in reducing the metabolic impact of diabetes in India, which can contribute to fatty liver obviously. So semaglutide is like I would say that wonder drug that we are using at the moment for reducing cardiovascular mortality in diabetics, and also would be useful for management of cirrhosis. And then is obviously this drug lanifibranor. It's a new drug which is in phase 3 of the trial. So mainly you need to remember resmetirom and semaglutide. And as far as cirrhosis is concerned, like how do we decide whether patient will require or not require cirrhosis? Because there are two patients with cirrhosis. So who will be given a priority? The priority is based on child Tarcott Pug class score. Most of the time, like the indication for registering a patient for orthoptic liver transplantation is class B. If the child Pug score of a patient, is in the range of 7 to 8 points, if they give you single best answer, then you will say register for OLT if the word is register for OLT if the child score of a patient. I'm not writing child Pug score completely. I'm just writing, full word is CTP, child Tarcott Pug score. I'm just generalizing by saying that if the child score of a patient is more than 8 points, you have to register the patient for orthoptic liver transplantation. The child Tarcott Pug score is the oldest like scoring pattern that is available to evaluate damage to the liver. The parameters which are considered in this are bilirubin and international normalized ratio. Obviously by default, if liver is damaged, bilirubin will rise, INR will rise, because clotting factors are produced by the liver. Now we have a couple of factors that begin with alphabet A, and they are the ones that can be quizzed to you. This is taught in surgery also. One of the parameters that will take into consideration is albumin. And if liver is damaged, then serum albumin will become lesser. And if albumin will become lesser, person will have ascites. If albumin will become lesser, person will have ascites. And also from the A alphabet component, I want to say that if the liver will fail, then ammonia levels will rise in the patient. So there would be a development of asterixis and encephalopathy in a patient. So bilirubin, INR, albumin, ascites, and asterixis are the components that we use for child Tarcott Pug score. And there's a dedicated website on which we can register the patient for the need for orthoptic liver transplantation if the child score is more than 8. Nowadays, we have started using MELD score. MELD score stands for model for end-stage liver disease. The minimum value in this is 6, maximum value is 14. And if the score of the patient is more than 17, then we will register the patient for orthoptic liver transplantation. Whether transplantation will happen or not, that we don't know, no, because this would be a liver coming from a brain dead donor. So we never know whether it will come or not, because most of the time family members will refuse to give or part away with an organ. No, most of the time family members, all of them will disappear at the time when the person really needs it. So score of more than 17, you need to register for. Orthoptic liver transplantation. The parameters at the moment are CBI. The alphabet C would be standing for serum creatinine. Alphabet B would be standing for obviously serum bilirubin, and I would be for international normalized ratio. A query that I get from a lot of doctors is that bilirubin is okay, INR is okay, but why did you take into consideration serum creatinine? You would be aware that when the liver fails, the kidney also begins to fail. We get a complication called as hepatorenal syndrome. So if liver is failing, the toxins can damage to the kidney also, and therefore serum creatinine will also be taken. That's the mnemonic CBI. Alphabet C is for serum creatinine, B for bilirubin, and I for international normalized ratio. International normalized ratio can also be written as prothrombin time. The normal value is about 11 to 15 seconds. Now we are also dealing with MELD3. In MELD3, the CBI components will remain the same. Creatinine is the same. Bilirubin is the same. International normalized ratio is the same. What is the extras here? In MELD 3.0, they've also included serum sodium. That same serum sodium 135 to 145 wala value in millicoulomb has to be like put in the online calculator, and then the calculator will calculate the MELD 3.0 score for you. And the last parameter that we take here is albumin. So formerly, like, albumin was never a part of the MELD score. It was always CBI, but in MELD 3.0, it's gonna be sodium and albumin also incorporated. More parameters means more diagnostic accuracy and more statistical organization for the criticality for the need for a liver transplantation in a patient. Next, what I want to highlight is the drug of choice for alcoholic hepatitis. Yes, guys, can you give me an answer without having a look at the notes? Drug of choice for alcoholic hepatitis. I'm not asking alcohol de-addiction. For that, we can be using multiple drugs, but it is alcoholic hepatitis. I want to cut down on the chances of development of liver cirrhosis. So your answer would be given as steroids. That is, we shall be giving prednisolone to the patient. Then for the severity of alcoholic hepatitis, we are using a parameter that is called as SGOT-SGPT ratio. Here I want to say that SGOT is present in the mitochondria and SGPT is present in the cytoplasm. And if this SGOT-SGPT ratio is more than 1, it indicates that there is a worsening of alcoholic hepatitis. If he says what is the marker for alcoholism, like this guy says he does not drink. His wife says he drinks daily, sir. Smell his breath, he's reeking of alcohol. Now, the guy might have consumed alcohol a couple of hours back and he might have brushed his teeth, used a mouth freshener. So maybe you may not be able to smell the breath on his alcohol. And obviously in hospital, we will not use that breath analyzer like traffic people will be using. So to be sure about whether somebody drinks or not, just do a simple test, gamma GGT, gamma glutamyl transpeptidase. It will always be showing an elevation. Along with that, he can say what is the score that can be used to decide the need for starting prednisolone in a patient. So score to decide treatment in AH stands for alcoholic hepatitis. AH stands for alcoholic hepatitis. Like how will a doctor decide whether a person is requiring treatment in the form of prednisolone or not? Then the parameter that we will take into consideration is called as Madri's discriminant score. A lot of MCQs, Madri's word may not be given, only discriminant score will be given. And the parameters which are present here are in the form of bilirubin and international normalized ratio. By default, you will notice that whenever liver is coming in the discussion and a score is coming into discussion, bilirubin and INR are parts of it. Alcoholic hepatitis, alcohol in any form is bad, guys. Whether it's gonna be like whiskey, whether it's gonna be vodka, or whether it's gonna be like red wine, because people say no, wine is good for health. No, man, any part of alcohol is bad. It is substance abuse. We can give prednisolone to prevent the conversion into liver cirrhosis. Now, because the patient of alcoholic hepatitis got converted into cirrhosis and he did not listen to me, then we will be having fluid in the peritoneal cavity. We will be doing a diagnostic ascitic tap in a patient, and I'll be sending this ascitic fluid to the lab for evaluation. What the lab people will do is calculate a SAG value, that is serum albumin ascitic gradient, and that helps us determine whether it's a transudate or exudate. Just like you read about Light's criteria, differentiating transudative, exudative, in a similar spirit here, we are using that gradient to identify the causes. A lot of questions might be mentioning SAG value of less than 1.1. The conditions which would be contributing to this can be remembered by a mnemonic by the name of TPN. So let's just put up the data. Alphabet T would be for tuberculosis. Yes, guys, disseminated tuberculosis can involve the peritoneum and therefore ascitic fluid can be developing in Indian patients. The next cause would be metastasis, which could be occurring from ovarian cancer, that is peritoneal carcinomatosis. Every time we read about ascites, one of the bad cases that we read is malignant ascites, that is due to peritoneal carcinomatosis. Two cancers which are famous to cause peritoneal carcinomatosis can be ovarian cancer. The second one is stomach cancer. So that is why, like in any perimenopausal woman, if you're noticing any ovarian mass on an ultrasound, especially if it's a solid ovarian mass, we must get an MRI done. We don't do a biopsy in ovarian tumor because it will change the staging, but then we have to do a contrast enhanced MRI so that we can gadolinium based MRI to identify the type of tumor, benign versus malignant. So TB, peritoneal carcinomatosis, is the one that is to be remembered. Alphabet P will be used another time. That can be pancreatitis. Pancreatitis can also contribute to local inflammation, and thereby the peritoneum gets irritated, and we can get a SAG value of less than 1.1. Alphabet N is for nephrotic syndrome. So most of the time what they'll do is they'll jumble up the causes of what I described before you as TPN, and these causes will be mixed up with the causes of SAG value more than 1.1. Most of the time students tend to focus on this particular value, and because the causes are relatively more, so you tend to get bamboozled by the data that is present. So my suggestion would be, every time you read the SAG table, focus on TPN first. Once ye TPN wala causes are remembered by you, TB, peritoneal carcinomatosis, pancreatitis, nephrotic syndrome, that is when you are mentally ready to remember SAG value causes more than 1.1. Here the division is made into now ascitic fluid protein values less than 2.5 or more than 2.5. Why more than 2.5? Because at the moment the fibrosis has not occurred in the liver very substantially, so there can still be fluid coming into the ascitic fluid. But if there is a substantial amount of fibrosis present, then in those circumstances the protein will not be able to come into the ascitic fluid. So cirrhosis is present in alcoholic liver disease, so you need to remember now these two combinations, that the SAG value will be more than 1.1. but the ascitic fluid protein value will be less than 2.5 grams in alcoholic liver disease, then is the late format of Budd-Chiari syndrome. This is what is asked in INICET question, that they had mentioned SAG of more than 1.1, ascitic fluid protein was less than 2.5, alcoholic liver disease and portal vein thrombosis were not in the options. It was late Budd-Chiari syndrome that is to be answered, because in these all the causes, the common thing that will be present is fibrosis, and this fibrosis will cause less presentation of leakage of proteins. But if you look at like ascitic fluid protein more than 2.5, increased hydrostatic pressure, congestive heart failure, Budd-Chiari syndrome in the early part. What is Budd-Chiari syndrome? It is thrombosis of the hepatic veins. I'll write that also, but due to thrombosis of the hepatic veins, the hydrostatic pressure will rise, and the rise of hydrostatic pressure causes more fluid to leak into the peritoneal cavity. And then a lot of time people drink these herbal teas. Herbal tea in excess is again bad, because it can contribute to veno-occlusive disease, that is sinusoidal obstructive syndrome in a patient. So at the moment, what I've described before you are a couple of causes for SAG variation, with especially the TPN part to be remembered, and the extreme left of this table to be remembered, where one arrow is going like more than, the second arrow is going as less than. That is for alcoholic liver disease, portal vein thrombosis, you will still be able to figure out fibrosis. But late Budd-Chiari syndrome also obviously will have fibrosis. And what is Budd-Chiari syndrome? So I'm just writing BCS here. This disease is characterized by thrombosis of the hepatic veins. Now your question would be, why is there a thrombosis of hepatic veins? So one reason can be like there could be valves present there. I mean, normally we don't have valves present in the hepatic veins, but if valves are present, thrombus part could be occurring. In fact, surprisingly, one of the leading causes for Budd-Chiari syndrome in a patient is a hematological malignancy by the name of polycythemia vera. So yes, surgical causes can be there. OCPs can cause Budd-Chiari syndrome, but then polycythemia vera and paroxysmal nocturnal hemoglobinuria are two surprising entries for the number one cause of Budd-Chiari, where you get extreme painful right upper, severe pain in the right upper quadrant. You might think it's a gallbladder disease, but there's a tender hepatomegaly, no fever preceding, no viral hepatitis I'm talking about. Guy was okay, and suddenly there's a painful hepatomegaly, and along with that, ascites will develop in this patient, because if the pressure in the hepatic veins will increase, blood cannot go forward, so it will contribute to increased hydrostatic pressure and fluid leaking into the third space, that is the peritoneal cavity. Sudden onset right upper quadrant pain and ascites are features of Budd-Chiari syndrome, where we can do a Doppler and the investigation of choice for Budd-Chiari syndrome, if he says, then your answer for investigation choice would be answered as hepatic venography. I repeat that again. Initially, I'll be doing like a Doppler for ultrasound as well as a Doppler, but the investigation of choice is a hepatic venography, and you will have to use heparin for management of these patients. The number one cause for Budd-Chiari syndrome is hematological malignancies. 3 points must know right now. TPN mnemonic, which is to be remembered for SAG value less than 1.1. For SAG value more than 1.1, remember that if the values of serum ascitic protein is less than 2.5, then one of the causes is late Budd-Chiari syndrome. Early part will cause the fluid value, ascitic fluid protein, to be higher, because transudation can still happen. Herbal teas are bad in excess, that can cause a VOD. And then Budd-Chiari syndrome, as I said, hematological causes are responsible. Where do you do a tapping? The tapping can be 2 cm below the umbilicus, or it can be 2 to 3 cm above and medial to the anterior superior iliac spine. In ascites in a patient, I'll just do a crude diagram representing this. This patient is having fullness in the flanks. This is the umbilicus of the patient, which may be everted. This is my patient. He's lying in the hospital bed. There is a significant amount of fluid present in the peritoneal cavity of this patient. So I might be like, he might mention the words like shifting dullness and fluid thrill present, and the fluid will keep on increasing, no, and it may be so big that it can even contribute to development of breathing difficulty in this patient. So I have a ascites patient who's having severe breathing difficulty. This is midline. This is a muscle by the name of rectus abdominis. So one approach is that I initially will obviously be advising this patient of ascites where fluid thrill is present and shifting dullness is present, to take less salt, and we can use eplerenone or spironolactone for management of these patients. In fact, I can just write this here, that if he says like, what will you do for any case of ascites? Then for any case of ascites, the initial approach is a SR means a salt restricted diet. The second thing is starting of diuretics. One of the diuretics we can use is like eplerenone, or we can use spironolactone. It's a mineralocorticoid receptor antagonist that we have discussed, even usage of heart failure patients. But today it's being used for ascites because it is a aldosterone antagonist. To this, I can be adding furosemide. I can increase the dosages of the two drugs. Still, if the ascites part is increasing, I can add additional medicines like amiloride. So my point is, I have given substantial amount of diuretics. I've even given loop diuretics, amiloride, which is gonna block sodium channel. And in spite of that, if the ascites part is persisting, in spite of all of this that I've written, if the ascites part is persisting, then I'll use the word refractory ascites. So in refractory ascites, I don't have an option. No, I mean, if drugs are not, if salt, SR means salt restricted diet, and drugs are not working, I need to do a tapping so that I can ease off the respiratory distress. So I will be inserting the needle 2 centimeter below the umbilicus of the patient, or I can be inserting the needle about 2 centimeter up and medial to the anterior superior iliac spine, that is in the flanks of the patient. You can see I put a cross on the left side. I could have put it on the right also in the flank. We usually avoid the right flank because in the right flank, what is present here is the cecum. Cecum can get injured because it's like fixed, whereas the sigmoid colon is floating. So you can just adjust the position of the patient because every procedure is done ultrasound guided. So you can just shift the patient and the bubble loop will float away, and then you can put the needle. The needle will always be introduced in a Z fashion. The needle will always be introduced in a Z fashion. That is practical. I mean, I'm just writing the alphabet Z to say that I'll not put the needle straight inside. I'll go in a zigzag fashion. The advantage is that it will create a self-sealing tunnel, and therefore the leakage of ascitic fluid from the peritoneal cavity of the patient can be minimized. You read about Z technique one while giving intramuscular iron in patients because it causes staining of the skin. So just like you're comfortable with the Z technique for iron injection, I said Z technique while introduction of the needle for ascites. Now was a question that came in the paper. This is a NEET PG question. He said a patient of chronic liver disease with ascites presented with massive ascites, and his massive ascites is worsening. Like he was having breathing difficulty, that is okay, but then he said the abdominal girth of the patient is increasing. Plus he's having fever, he's having abdominal pain. Earlier this fever and abdominal pain were not present, but now like he's already admitted, and maybe cases of MI were coming, trauma cases. I was alone on the duty and multiple cases were coming. So I was having a tough time handling so many cases. So this guy is lying on the stretcher for maybe unattended 12 hours. I've admitted the guy, that is okay, but I planned to do ascitic tap, but I did not get time. And now the bad news is that this fluid can get infected from bacteria present in the bubble. Usually the bacteria which is responsible for this complication that is developing in this patient happens to be E. coli, and the complication developing was mentioned by the examiner himself, that is spontaneous bacterial peritonitis, that this fluid could get contaminated. Now there could be like pus developing in this area. I'll remove the word pus here because it will create like the yellow will look like pus then. What I'm saying is ascitic fluid is present initially. It's mainly a transudate with SAG value in the alcoholic liver disease to be less than 2.5. But the point at the moment is that if there is a worsening of the ascites of a patient, there's a fever and abdominal pain, then fever means infection. So the person is having SBP. So at this point of time, what I will do in this patient is a therapeutic, not a therapeutic, but a diagnostic paracentesis. That diagnostic paracentesis, when I put in a 20 ml syringe, go in a Z technique and aspirate it out, it will be having turbid appearance and would be having, because bacteria are coming, no? So it would be having a turbid appearance and neutrophils would be present. See, neutrophils have no business to be in the peritoneal cavity. If neutrophils are coming in the peritoneal cavity, it means it is bad news. He has asked what is the cutoff that is to be remembered for diagnosis of spontaneous bacterial peritonitis. The cutoff is neutrophils more than 250 cells per cubic millimeter in the ascitic fluid is the cutoff. We need to give antibiotics to this patient, cefotaxime. In fact, I should have first given him norfloxacin. This guy was admitted with massive ascites. I had planned to do a therapeutic paracentesis in this patient, but because I was the only resident on duty and there were cases coming in, trauma cases and then MI and then stroke and then pneumonia patients, I did not get time to do a I did not get time to do a ascitic tap in this patient. The patient with his family members were lying in one side of the hospital casualty. Now his wife came. He said, sir, suddenly my husband is having high grade fever. And when I went, I checked his abdomen. It was very tense. She's saying, sir, now the tummy has become more distended, like the umbilicus is just jutting out, like it's like literally inflated like a balloon. The guy is also having abdominal pain, a bit of tenderness, discomfort present. So that means that there is a sepsis risk in this patient, that is spontaneous bacterial peritonitis. The question can be two-step. He can say, what is the treatment? What is prophylaxis? So every time you admit somebody with ascites for ascitic tap, if you know that there would be a delay happening in the procedure, at least start him on norfloxacin so that this kind of a complication in the patient can be minimized. Then patients who are having liver cirrhosis can also develop hepatorenal syndrome or hepatopulmonary syndrome. In hepatorenal syndrome, what happens is that there is a splanchnic vasodilation due to nitric oxide which is produced by the liver. The damaged liver is producing nitric oxide, and thereby there is a splanchnic vasodilation that is happening. If you cause a splanchnic vasodilation, then the blood supply to kidney will be less. If you dilate the blood vessels in the whole of the intestine, then overall the blood supply to kidney will become less, and therefore the RAS system is activated and there is a reflex renal vasoconstriction that will cause further worsening of the kidney function in a patient. The technical word I want you to remember is that hepatorenal syndrome is a pre-renal variety of acute kidney injury that can be seen in patients with liver cirrhosis. Let me say this again. The cirrhotic liver, whenever a person is having cirrhosis of the liver due to alcohol intake or whatever be the cause, the cirrhotic liver will produce nitric oxide. This nitric oxide will be responsible for causing splanchnic vasodilation. The cirrhotic liver cells produce nitric oxide. It causes a splanchnic vasodilation, because of which the blood supply to kidney is effectively reduced. So I said pre-renal AKI, therefore there can be oliguria or renal failure occurring in the patient. AKI definition I've said in kidney part, creatinine rising 1.5 to 1.9 times above the baseline values, or like rise of creatinine more than 0.3 over 48 hours. I'm not writing it because that's covered in the kidney section. But if the kidney is failing, he will ask you, what will you do? So main reason why we discussed hepatorenal syndrome is, one, we should have done a liver transplantation earlier. But now whatever has happened has happened. He did not undergo a liver transplantation. So what medicine can we give is terlipressin and albumin. Usually we read about terlipressin in management of like portal hypertension. So yeah, I will speak about terlipressin again, but today it is being used for hepatorenal syndrome. In the older MCQs, you will notice that terlipressin albumin may not be given. Then it is three things. That is like midodrine. Midodrine, what it does is it causes constriction of the splanchnic blood vessels. Midodrine, what it does is it causes constriction of the splanchnic vessels. If you will cause constriction of the splanchnic vessels, then it will help in preventing this worsening of kidney perfusion in a patient. In fact, both the drugs that I've highlighted before you, both the drugs that I've mentioned here before you, will basically counterbalance the splanchnic vasodilation. Let me just highlight that statement here so that you're able to remember what is going on. The nitric oxide is causing a splanchnic vasodilation, and what these two medicines are doing is that they cause a vasoconstriction. So effectively you are causing a counterbalancing of the splanchnic vasodilation by using the fulvic medicines, terlipressin, albumin, and yeah, even like midodrine, octreotide. I mean, the rationale of using these medicines is to counterbalance the splanchnic vasodilation, which is the cause of errors in this patient. Why am I giving albumin? I'm giving albumin because albumin will draw fluid into the intravascular compartment. If you draw fluid into the intravascular compartment, even that will be responsible for like improving the perfusion of the kidney. So I'm going all out ballistic. I need to plan a liver transplantation. If in the MCQ single best answer is asked, then the marking I'm just modifying to say the single best answer that would be given in this case would be given as point number 1. Otherwise, like any other two approaches can be used to counterbalance the splanchnic vasodilation. Same for hepatopulmonary syndrome. Hepatopulmonary syndrome will require management of the patient by again going for orthoptic liver transplantation ASAP, but person might require ventilator support. Here also there is nitric oxide which is the cause. The nitric oxide is causing an intrapulmonary vascular dilation, which is basically called as intrapulmonary shunting. The technical word he will say is hepatopulmonary syndrome is a condition because blood vessels of the lungs will get dilated. So the blood will go very fast through those blood vessels without getting oxygenated. I said an extreme thing. Blood vessels of the lungs are dilated. So blood is traveling fast through the lungs without getting oxygenated. So the technical word is intrapulmonary shunting. The query from a lot of students is shunting means blood is going from left chamber of the heart to the right chamber. That is congenital heart disease. I'm not discussing congenital heart disease at the moment. I'm saying the blood vessels are dilated. So the blood will be able to rush fast from the pulmonary circulation without getting oxygenated. So there is a hypoxia. The manifestation of this condition is development of platypnea. Most of the time, the platypnea meaning will be asked to you, that is dyspnea in this patient will increase in sitting position. Guys, in orthopnea, the dyspnea tends to worsen in a supine position. In respiratory system, I've described trepapnea, which is dyspnea on breathing, which is worsening in lateral decubitus position. But today I've described platypnea, that is dyspnea worsening in sitting position, along with orthodeoxia. These are again very two classical terminologies. I mean, you don't read these words anywhere else. So platypnea, orthodeoxia in a patient of liver cirrhosis indicate what? Your answer is that platypnea and orthodeoxia in a patient of liver damage indicate intrapulmonary shunting called as hepatopulmonary syndrome. Obviously, I will have to put the patient on a ventilator by default because the patient is critically sick and improving oxygen saturation. But the main treatment is OLT. Had transplantation been done at the thresholds that I was teaching you earlier, then these kind of bad prognosis would not have occurred in a patient. Now is the aspect of portal hypertension. Portal hypertension can be easily identified if the patient is having these blood vessels which are dilated around the umbilicus. These dilated blood vessels around the umbilicus which are currently highlighted are called as caput medusae. Caput medusae are dilated veins. These are portosystemic collaterals. Do not mistake them to what is currently shown in this image, that is called as spider angioma, or is also called as spider nevi. Spider nevi, where do you check for them? You check for them over the superior vena cava distribution. So you will ask the patient to remove his shirt or t-shirt, and you will notice that spider nevi are present on the shoulders of the patient or neck area of the patient. Spider nevi is present in superior vena cava distribution, that is over the shoulders and the neck area of the patient. Apart from this, spider nevi are like not only seen in liver cirrhosis, but they can also be seen in rheumatoid arthritis. They can be seen even in patients of Graves' disease and even in pregnancy. Pregnancy I'm not writing because that is not a disease process, but they're not, I mean, why I'm writing that is they're not pathognomonic. They can be seen with patients of liver disease, that is okay, but can be seen in RA and Graves. One of the hormone which is responsible here is what is called as estrogen. So that this is an important question, that which hormone levels will increase in patients with liver cirrhosis. So it is estrogen levels that rise which causes this spider nevi or spider angiomas to develop. There is no reason why the caput medusae can be mixed with spider nevi, because spider nevi is arterioles. Spider nevi is arterioles which you are seeing on the shoulder area or in the SVC distribution of a patient, whereas when it comes to caput medusae, those are veins which are trying to decompress the portal circulation. The flow of blood in these veins, the flow of blood in the veins will always be away. I mean, the flow of blood in portal hypertension is always away from the umbilicus. This happens to be overall like the most common complication of CLD or chronic liver disease. Then when you look at the nails of these patients, the nails would look totally white. That would be written as Terry's nails. The meaning of the word Terry's nails in derma is that the nails are appearing white, but the tips might be relatively pinkish. It's a totally white nail, but the tips of the nail would be relatively whitish. So it is also called as leukoonychia. And the last finding that you can see here is that of palmar erythema. I mean, if you check out the hypothinner eminences, they're like bloodshot red. And then in the thinner eminences, rather, there is a whiteness that is present. So palmar erythema, leukoonychia, and along with these Terry nails are features that are seen in patients of liver cirrhosis. The word is, do not mix it with coileonychia. Now, I'll just write it again. This is leuko, that is white nails, leukoonychia, not to be mixed with that coileonychia that you get with Plummer-Vinson syndrome. And why am I telling you all this is because these are features which are, okay, the question was asked like this. There were 4 options to see you got me or not. There were 4 options in the question. It was an image-based one. He said, which of the following indicates portal hypertension? Which of the following indicates portal hypertension? Your answer will be portal hypertension on a clinical perspective means that there is congestion in the portal vein and the veins connected to the systemic circuit. So caput medusae is the only finding which is present here which indicates portal hypertension. Point number B, C and D which are given in this question, spider nevi in red, Terry's nails, leukoonychia, white nails with a pinkish tip, and the palmar erythema component are features of liver cirrhosis. Point number B, point number C and point number D, they are basically features of liver cirrhosis in a patient, or I can say in English, features of liver cell failure. Features of liver cell failure. but A is indicating that portosystemic collaterals are getting developed. In fact, if you zoom in, you can also see dilated veins on the anterior abdominal wall laterally developing. So the body is trying to like decompress the portal circulation, and portal hypertension is the most common complication of chronic liver disease. I'll just highlight the data now in more bold. Overall, the most common complication of chronic liver disease is portal hypertension, and the earliest and the most reliable examination finding in a portal hypertension patient is splenomegaly. Yes, guys, because the pressure in the portal vein will be more, so it will be passively transmitted to the spleen of the patient, and that is why splenomegaly will be developing. The definition of the portal hypertension is hepatic venous pressure gradient more than 5 millimeter of mercury, and if this pressure will go more than 12, then there can be development of bleeding esophageal varices. What is the source of bleeding in esophageal varices? From the portal vein side, it is the left gastric vein. From the systemic side, it is the azygos vein. Either of the two can be asked. Left gastric vein might also be called as coronary vein. Then he will say, what is the best management for prevention of bleeding from esophageal varices? Without looking at the notes, quick answers here. What is the best management? Options are endoscopic varicose ligation, TIPS, transjugular intrahepatic portosystemic shunting, octreotide. Best for management of prevention of bleeding from esophageal varices. Options once again. I don't want you to use any support. Think of an answer in next 5 seconds while I speak, right? That's the reflex development that I want you to have. Options are endoscopic varicose ligation, transjugular intrahepatic portosystemic shunting, octreotide. For prevention of bleeding, what I need to do is suggest this patient to go for EVL, that is endoscopic variceal ligation. Yes, guys, because the prevention word is given here, so I will be suggesting EVL, endoscopic variceal ligation, for this patient. If he does not want to go ahead with endoscopic variceal ligation, I can give a drug. This drug will basically ease out the portal hypertension. So we will be giving a beta blocker to this patient, which is one of the long-acting ones, that is nadolol, or instead of nadolol, the good old one that is also used is propranolol. Last time I spoke about propranolol was for prophylaxis of migraine, and it is also used in like patients having like anxiety neurosis or panic attacks to take care of the tremors component, and even in prophylaxis of migraine. But today it is being discussed for prevention of bleeding from esophageal varices. Must know MCQ. What is best for management? If the word is best written, then answer is endoscopic varicose ligation. Drug of choice is nadolol for prevention. If he says acute bleeding, then you give octreotide for management of this condition. So because the BP of this patient is substantially low, so what I will do is first I will be putting a wide bore cannula in this patient. I can just rephrase the numbers there because the numbers look a little off the radar at the moment. So yeah, the interventions are obviously manifold, but what I want to say is I'll be putting a wide bore cannula. While I just erase these random numbers here, my question to you guys, what is the which of the following wide bore cannulas would you be preferring? Would you prefer orange cannula, gray cannula, green cannula? Quick answers, please. Yeah, you'll be using a wide bore cannula. That is, most of the time we are using a gray cannula because I need to rush fluids initially and then give a blood transfusion in this patient. So the first thing when the patient comes is, because he's having hypovolemic shock and the BP of the patient is going towards less than 90/60, insert a wide bore cannula, maybe 2 of them, and with help of this gray cannula, fluid would be given at a fast pace. I can put a orange cannula also, but then the orange cannula, he says ATLS training should have been taken by the doctor. So gray cannula is the one that is recommended, and then we will have to go for massive transfusion. Before massive transfusion, before the blood comes, I mean, obviously when patient has come, practically speaking, blood will not be available as soon as the patient comes. No, so I can give crystalloids, and meanwhile the blood has been arranged. For massive transfusion, the definition is we are giving 6 units each of the following things. We are giving 6 units of packed RBC. Then we are giving 6 units of fresh frozen plasma. And then we are giving to the patient 6 units of platelet-rich plasma, because nowadays we give blood components of the patient. So 6 units of packed RBC, fresh frozen plasma, and platelet-rich plasma are given in ratio 1:1:1. In some MCQs, he will try to play a trick on your mind. It will be written as 6 units of packed RBC, 6 units of fresh frozen plasma. But here he will try to play a trick, which is 1 unit of single donor platelet. Do remember 1 unit of SDP. 1 unit of single donor platelet is equal to 4 to 6 units of platelet-rich plasma. That is why the ratio here is changing. I repeat that again. 1 unit of single donor platelet. This is 1 unit. Okay, let me just rephrase this. The word is that SDP is made from apheresis machine. No, that's the big jumbo bag that I'm talking about of platelets. So the jumbo bag of platelets is 1 unit of SDP is 4 to 6 units of platelet-rich plasma. Platelet-rich plasma is made from pooling the plasma from multiple donors, so more chances of allergic reaction also. So lots of time we prefer SDP because the chances of allergic reactions would be lesser. Another definition of massive blood transfusion is that we are giving to the patient more than 10 units of whole blood. 10 units of whole blood being administered, which may be written as more than 5 liters of blood transfusion. The target is to achieve a BP of at least equal to 90/60. He says don't achieve BP of 120/80. Achieve a target BP of 90/60. We call it permissive hypotension because I don't want my patient to start more bleeding. More bleeding begets bleeding, guys. If I increase the blood pressure to 120/80, the clot that has developed at the site of bleeding varices will get dislodged. So in all trauma cases, by default, we don't increase to 120/80. We increase only to 90/60 so that vital organ supply is maintained. And now we will be starting the patient on octreotide/somatostatin analog, or we can use terlipressin also. I mean, octreotide is something that is always recommended as an infusion, and terlipressin has the disadvantage of being given as a bolus. Like in government hospital, lots of type infusion pump may not be available. So with help of these approaches, we'll be able to manage our patients relatively better. And at this moment, I also want to say that ultimately, when the patient will improve, then he will be put on the treatment of choice, that is endoscopic variceal ligation. At this moment, I can say I've covered 3 questions. If he says what is the treatment of choice for bleeding esophageal varices, you can see what we are talking at the moment is acute variceal bleeding. That's bleeding varices. Earlier I was talking about prevention aspect. Now I'm talking about the treatment part. For treatment, if he says what is the treatment of choice, the answer is endoscopic variceal ligation. You will notice that endoscopic variceal ligation is the common answer for prevention also. Best for, I told this patient last year कि भाई EVL करवा लो. He did not get the EVL done. That is why the guy is deteriorated and was fighting to fire his life in the casualty. The TOC for patients of acute variceal bleeding with hypotension is obviously initially I can't do a ligation because patient is hemodynamically unstable. So this algorithm was mentioned, but the main treatment is still EVL. If he says drug of choice, the answer is octreotide/terlipressin. A bit of controversy in a sense that what is the best drug? I mean, always different authors will have different opinion. Harrison mentions octreotide first, so I mentioned it first. And then is the concept of permissive hypotension, massive transfusion, and we have to put a wide bore cannula for any patient of hypovolemic shock where the blood pressure of the patient is going towards crashing or unrecordable status. At this moment, I also want to add the technical word triado death. What I mean by triado death is that the bleeding will cause more bleeding to start. Bleeding begets bleeding. Bleeding causes more bleeding to occur. Why? Because when you lose blood from the body, you are not only losing blood, but you're losing heat also. That is, hypothermia will occur because you lose warm blood, and warm blood will cause hypothermia. Because of hypothermia, the clotting factors will stop working. Because clotting factors will stop working, there would be a coagulopathy. So rather, bleeding causes more fast bleeding. This also tells you should never give chilled blood to any patient. Lots of time blood is stored in a blood bank at 2 to 6 degrees Celsius. So if we will give chilled blood to the patient, it will contribute to worsening of bleeding in a patient. So we always give blood via inline warmer. And apart from this, because there is a circulatory failure, there would be metabolic acidosis. So instead of going into a mnemonic, I mentioned with the rationale what is triado death, that is hypothermia because of heat loss, because blood is warm. Second is coagulopathy because clotting factors work at 37 degrees Celsius. Now the clotting factors will not be able to function properly, and underperfusion of tissues will explain metabolic acidosis. To prevent all this from happening, using inline warmer, blood products will be given to this patient. We will not warm the blood products by obviously putting them in a microwave. So they have to be given via inline warmer here. And I repeat my statement, bleeding begets bleeding. So lots of time these questions that are asked on the topic of portal hypertension, though I'm very sure you would have read this in surgery also. And another finding of portal hypertension I want to see is ascites that I've already discussed. Ascites will take time to develop. By the time it is 1500 ml, 2000 ml, till that it usually gets detected. So I'm not going to wait that long for ascites to accumulate in the peritoneal cavity and then tell the patient, oh man, you have portal hypertension. It is rather going to be like splenomegaly, which is an early and a reliable finding. And what is the test that I'll be doing in this case? The test that will tell me what is the pressure values or Doppler. I mean, the moment we do a Doppler, if we are able to identify on a Doppler HVPG more than 5, more than 12, then we know that the patient is deteriorating. Higher is the value. The source of bleeding is the left gastric vein and the azygos veins. The portosystemic collaterals is what I'm talking about. And next up, we'll talk about Wilson disease, a very simple, straightforward disorder in which the gene which is going to be defective is by the name of ATP7B gene. The pattern of inheritance is autosomal recessive. The chromosome defective is 13. And due to this, what is the defect? The defect is impaired or defective hepatobiliary excretion of copper. Don't answer directly ceruloplasmin deficiency. Don't answer ceruloplasmin deficiency. Ceruloplasmin deficiency can be seen even in those patients who are having nephrotic syndrome. Now, in nephrotic syndrome, there can be urinary loss of protein in a patient. So don't answer ceruloplasmin deficiency. Ceruloplasmin deficiency can be seen even in primary biliary cholangitis. Guys, ceruloplasmin deficiency is not the defect. It will be the first option given in the question. It is a manifestation of the disease. It is not the cause. The cause is defective gene contributing to development of impaired hepatobiliary excretion. Because of this impaired hepatobiliary excretion, the concentration of copper in the liver will rise, and that is why the hepatocytes will get destroyed in this patient. So we get a hepatodegeneration and therefore fulminant hepatic failure. Less common, fulminant, it most of the time would be chronic hepatitis, but can go into worsening. And you guys tell me what basal ganglia is affected here. In Wilson disease, what is the name of the basal ganglia, involvement of which will cause Parkinson-like manifestations? Your answer would be lenticular nucleus gets affected. Parkinson disease is what is gonna be Parkinsonism-like manifestations that will occur in this person due to lenticular nucleus damage. So it is a hepatolenticular degeneration that occurs due to a defective gene, and the basal ganglia gets affected by excess of copper in the circulation. The mnemonic for this is copper, which means that in the first 10 years of life, you will be having liver cirrhosis. For the first 10 years of life, cirrhosis complications, ascites, repeated hospitalizations, hematemesis could be occurring in a patient. After 10 years of age, we will start getting the following manifestations, that is ocular findings. Ocular features are in the form of a KF ring. The KF ring initially develops in the upper part of the cornea but is not visible to the naked eye because upper 2 millimeter of the cornea is always covered by our upper eyelid. So the KF ring is not visible because it's covered by the upper eyelid, though it appears as early as like 10 to 12 years of age. Then the KF ring will be involving, it's a greenish brown ring. It will involve the lower part of the limbus. It starts appearing around 10 to 12, but then it's not visible. Usually starts appearing at the lower part of the limbus by 15, and then it will increase in a circumferential fashion and will involve the whole of the cornea. We can identify this even earlier by doing a slit lamp examination from your ophthalmology classes, that the slit lamp examination will be causing damage to the Descemet's membrane. The damage to the Descemet's membrane will contribute, that he will say which layer of the cornea is getting affected. Answer is Descemet's membrane, and that the greenish brown ring would be developing in the periphery of the cornea. This KF ring is reversible. When we give a copper chelating agent, it will respond. Then he will talk about psychiatric features. Psychiatric features could be in the form of behavioral changes, aggression that would be noticed, and then Parkinson disease like manifestations could be given in a question. Like he will say this child who was previously having significant school absenteeism because he's getting admitted for complications of cirrhosis, like he has to get admitted for ascitic tap, he's having abdominal distension. So the school absenteeism will be present, behavioral changes will be noticed, and then PD like features like bradykinesia can occur. Extrapyramidal manifestations like tremor, rigidity could be developing in a patient. So the message is that after 10 years of age, in these patients, usually the manifestations are those of P. In copper, P is coming 2 times. So C is the cirrhosis component, O is the ocular features, P is the psychiatric and the Parkinson disease like manifestations. A lot of these questions of Wilson in the previous year began by describing 10 to 12-year-old boy or a girl presenting with psychiatric features initially, then PD kind of features and extrapyramidal syndrome features were given. Then in the question to, maybe throw us off the track, he also started saying words like amino aciduria, glucosuria, because excess of copper can damage the proximal converted tubule. If the proximal converted tubule is damaged, then amino acids would be lost, glucose will be lost. That is amino aciduria, glucosuria, like features of PCT damage in a patient. So the R stands for renal tubular disorder that can be occurring. After describing all of this, I'll say the data once again. 10-year-old boy with personality changes. That is why he wants you to think in terms of possibility of even neurodegenerative disorders. But obviously it's a neurodegenerative disorder, but he wants you to think in terms of like those pediatric neurodegenerative disorders also. So at the moment you read neuropsychiatric manifestations, you are like thinking, okay, neurodegeneration. But then he starts saying person has been previously hospitalized for ascites, previously hospitalized for GI bleeding. So you immediately know combination of neuropsychiatric with liver damage, that is ascites or bleeding varices, that is a combination. That's why we call it Wilson hepatolenticular degeneration. To increase the length of the question, he might mention tubular manifestations of copper causing destruction of PCT cells. If PCT cells are damaged, amino acids will not be absorbed, glucose will not be absorbed. Then comes the core issue, what is the screening test? Umpteenth number of times he will ask you what is the screening test. So we will be answering serum ceruloplasmin. This would be low since the liver is getting damaged. Along with this, a second test will also be done, that is a 24-hour urinary copper. Normally, whenever I teach you regarding a screening test, I give you single answer. This is the only time in this entire video lecture series when I have said two investigations. In the MCQ, if single best response is answered, obviously it is serum ceruloplasmin deficiency. But in like multiple correct, he will ask you what are the tests to be done. Initially, it is ceruloplasmin with 24-hour urinary copper, because ultimately copper in the RBCs are more. RBCs will break down, so copper will come in the urine. That is why that copper is damaging the proximal tubules of the kidney also. The copper is more in the urine because it's coming from where the RBCs, when they lyse, RBCs die after 120 days. The higher concentration of copper in the RBCs contributes to like high urinary copper in these patients. That's why like this test would be done supplementary. The investigation choice for this condition is a liver. That's what Harrison says, liver biopsy with estimation of hepatic copper content. See, I can do genetic studies in this patient also, but we need to do quantification. So liver biopsy with estimation of hepatic copper content is the gold standard investigation that is done, and Harrison focuses on this investigation. Along with this, I can obviously do genetic studies, that is PCR for ATP7B gene, which helps me identify that there's a problem. And first line drug for this patient is a copper chelator. So what is the copper chelator that we'll be using in this patient is by the name of trientine. But for the neurological manifestations, for the neurological features that are present in this condition, I would like to be a little more aggressive. For the neurological manifestations in this patient, the drug that is used is called as tetrathiomolybdate. This again, like the examiner like will have an evil look on his face when he's creating this question on neurological manifestations, because look at the long name, right? I'm struggling literally to write it. Tetrathiomolybdate is for neurological features in patients of Wilson disease, which can cause PD-like manifestations, extrapyramidal syndrome-like manifestations. And because neurological features are there, therefore an MRI head can be given in this question also. This MRI head, very classical. The MRI head findings in this patient that you can see is called as giant face of panda appearance. So additional point to be remembered for WD is Wilson disease, neurological, any patient having neurodegeneration, we are on neurological manifestations, we need to do a MRI head, and this will be showing a giant face of panda. I'm not saying face, I'm not even saying panda sign, I'm saying giant face of panda appearance on a MRI head would be seen. That's because of like damage to the basal ganglia, damage to the brainstem of this patient due to deposition of copper. So don't be under impression that it is only the caudate nucleus or the lenticular nucleus that gets affected, but it's gonna be like whole of the brainstem that gets affected. The most important data for this question is that what is the cause? Then don't answer ceruloplasmin deficiency. Cause is impaired hepatobiliary excretion. Then he will ask you kidney manifestation of this condition. The kidney manifestation is, you think, anybody will think Wilson disease pucha hai, so he'll ask you liver. He'll not ask you liver. Wo bolega what is the kidney manifestation? Higher copper in the liver will cause more copper to come in the RBCs, because RBCs will carry away the copper from the liver. Because the concentration of copper in the RBCs is more, when RBCs die every 120 days, then the copper is liberated into the bloodstream, gets filtered by the kidney and damages the proximal tubule of the kidney of these patients. So these are a couple of those hardcore aspects for the topic of liver that I want you to remember. And yeah, one more disorder, alpha-1 antitrypsin deficiency, that causes liver cirrhosis, has been covered in the respiratory section, where because it has an association with pan-SNR emphysema.